All right, the first order of business we have is we're going to deal with our responses from the agencies and our MCOs and other issues that we need to come to resolution on. So we'll start with Christine Osterlund. Welcome back.
Good morning, Madam Chairman and members of the committee. Christine Osterlund, Deputy Secretary of Agency Integration and State Medicaid Director for KDHE. So I think we're all looking from the same sheet of paper, which is good. So item number 3 on the core sets, we did provide again the list of the 2024 adult core set and child core set. I do want to point out in the spreadsheet that we provided with the quarterly and annual reports, we provided a link to a CMS website page. In that, the core sets, the results of those are also published there. Now, obviously, they lag a few years behind, so what's posted on the CMS site is the results of the 2022 core set. 2023 should be being posted here very shortly, so obviously there is a lag, but if you do want to see how Kansas performed, again, there's a lot of measures, so there's a lot of data out there, but I did want to point that out, that if anybody is interested or if there's particular measures that you would like us to print off the Kansas results, they post results for every state. We're happy to do that. All right, the next one is number 8. It's rural emergency.
Take questions on each one of these as we go along. So I always have to get oriented with this.
Yes, exactly. And which way the pages turn.
Right. So on with the rural hospitals, because of the legislation that we passed this year, when the feds get their other fix, that'll automatically get triggered and go into place.
Yeah, in the rural emergency hospitals, we've got someone here from public health, because that's actually the rural emergency hospital and the licensure is under that division. So we do have someone that can answer any questions you have on that if you want them to answer now or.
No, I think we've vetted it pretty good. I just wanted to make sure that that's going to be an automatic when it happens. So hopefully the feds get it done.
Will it be automatic?
Because we've got some hospitals that are pretty anxious out there to get this.
You know, our regulations, my name is Jerry Smith, I'm the Board Director for Facilities and Licensing. So our regulations have always mirrored what the federal regs are. So as automatic as it would be, I would suspect that if we need to do anything else regulatory or statutory, we would obviously do that. So it would be pretty quick.
Well, and we passed a law.
Yes.
So that when the feds do it, we don't have to come back later. So that's the piece that I'm looking at. So.
It would go very quickly.
Okay. All right. Thank you very much.
Thanks.
Talk about number 8.
No, that was on.
Yeah.
Were you on 8 or 3?
Well, I did 3 on the core set, and
That's
then 8 was the rural emergency hospital. So now we would be on 9.
Okay, so, and as we go through this, we'll decide whether we keep them or we take them off.
Yeah.
Is what we're going to do. So at this time here, until we see how everything plays out and all the data's up to date and kind of stuff, we'll keep it on there.
Okay.
Agreed, committee?
Agreed.
Okay.
All right, we ready for number 9?
Yes, ma'am.
Okay, number 9 is was some follow-up questions from the last Bethell committee around the Doula codes. So we've listed out the 3 codes that are available for Doula reimbursement. One is around prenatal visits, so the prenatal side of Doula. The second code, T1033, is labor and delivery, and then T1032 is postpartum services. The maximum reimbursement for a doula is $1,295, but that doesn't mean that they automatically get paid that. You know, someone may, you know, choose a doula much later in their pregnancy, and so on the prenatal side, there may be very limited billing. They may use them just for labor and delivery. So again, the reimbursement would change kind of based on how they utilize their doula. We did estimate a fairly small, all funds is $350,000. Again, doulas are not necessarily statewide, and then moms will utilize them at obviously very different levels. So we did estimate a fairly low fiscal, and that is what we're seeing. Obviously, claims data is limited at this point, but we have very few doulas enrolled and very, very limited billing. So I do think this will remain a small, at least initially, a small fiscal impact.
Committee, are there questions, comments? And if I recall correctly, there's really not a special training for these individuals to do this, correct?
There's a certification, but it's not a, it's not
You're
like.
not required to be licensed, certified, anything like that there.
They have to complete the training.
Right,
Yeah,
okay.
to enroll, yes. But it's not like what a doctor or a nurse or somebody would go through where, they go through a whole education program through a university.
I still do not understand why we're doing it, but that's all right. But we're going to keep this on here, being this is brand new for
Yeah,
us.
okay.
And monitor, especially on the fiscal side, what's happening with it. So we'll keep
excellent.
it at this time. Representative Carpenter.
And just, could you, I remember what do we pay physicians?
I believe it's 1,700 and,
That's-
yeah,
that's
seven,
kinda
yeah,
what I
seven,
remember
yeah,
was that.
1,700, and that's the reimbursed amount. So a doula can be up to $1,295, but a delivery would be, they would get the $1,795. So it's a little bit different reimbursement because it's a global code.
Now you're confusing me even
Yeah.
more. So if a doula delivered a baby, they would get,
They do not deliver the baby.
Okay.
They're in the room for support. So if they were in the labor and delivery room, a doula would get reimbursed $500 for being there for the labor and delivery. The OB that's delivering the baby would get what I believe, and I'll fact check myself, $1,795. So that would be the difference in the labor and delivery. The doula just gets $500 for being there.
and when does she get the 12, or he or she get the 1295?
The only way they would get that is if the mother selected the doula basically upon finding out that they were pregnant, and that they were utilizing doula services through all the prenatal care, because they're paid per activity for prenatal care, they're paid per activity for postpartum care, and then they have a labor and delivery. So the only way they get the $1,295 is essentially if they're with mom from finding out that they were expecting up through the postpartum period. Most of the time, that's not going to happen. We know a lot of times our mothers don't even become eligible for Medicaid until later in their pregnancy. And so most doulas would never be reimbursed the $1,295.
Very good, thank you. Thank you, Madam Chair.
Representative Berquist.
Madam Chair, maybe you told us last time, but I don't remember who created the curriculum for the doula.
I don't know that was asked, and I will have to find out. It's not a Medicaid curriculum, but we can find out.
Thank you.
Okay, committee, I think what we're going to do, and Senator Gossage had a good idea, and if staff has a better idea, please correct us on this. But I think on the ones that we're just wanting to monitor, so it's not like we're still dealing with a problem, but just monitor, is maybe put monitor and report number of claims and total spent. Is that good?
Sorry, monitor and report, number of claims.
Yeah, and dollars spent. Is this all SGF?
No.
No.
It's, all funds is, we estimated just a little under 351,000, with just under 140,000 being state general funds.
So the 211, that's not Medicaid though, or is it? The federal,
That,
where's the
the
federal?
211,000 is the federal match, the 60% federal match.
Okay,
Yep.
so it's a program the feds have.
Yes,
I'm still learning this program.
Yes.
You can tell. Okay, number 10.
all right, number 10 was a question around overlap between Medicaid postpartum and doula care. So doula care is non-clinical, so like postpartum visits, those are clinical services. So again, those would be billed by a physician, an OB, an ARNP. What the doulas provide are non-clinical services. To bill for doula services, you have to be enrolled with Medicaid as a doula. So a provider is not enrolled as a doula, so they could not bill those codes. That would also be true of, we kind of put in some information here, kind of the closest other reimbursement we have to doulas around kind of non-clinical type services would be community health workers. But again, they really don't focus on pregnancy issues. And again, a CHW, someone enrolled as a community health worker, could not bill a doula code. You have to be enrolled as a doula, just like someone couldn't bill as a community health worker unless they were enrolled as a community health worker. So we do have checks and balances, if you will, in the system of who can bill for what codes. So again, postpartum care provided by a practitioner would be billed under their codes, and a doula would be billing for their non-clinical support services, but they can't bill. Practitioner can't bill as a doula, and a doula can't bill as a practitioner.
Well, and I understood that with our last meeting, and I'm struggling with this, is that we're basically paying another individual on top of the services that we're paying through Medicaid. And that's the piece that I struggle with.
Yeah, and probably, maybe one of the best ways to think about it is the role of the doula is to help get the mom to schedule the appointment, keep the appointment, go to the appointment. If there are, when they go to that appointment, they will be obviously screened for health-related things, but also for postpartum depression and other activities. And then the doula, if there is a positive screen, let's say mom was screened for having postpartum depression, then the doula would help support to make sure the mom, follow up with the mom. Are you taking your medication? Are you seeing your therapist? Whatever the doctor would have told the mom that they need to do to support them. So kind of the doula is that. Those are things that a provider isn't going to do. They're going to, write the prescription. They're going to, do the referral for other services. But the doula is kind of that intermediary to hopefully ensure that mom actually follows through and gets the services that she does need. So it really is kind of that support. Very similar, again, to a community health worker, which does the same thing for non-pregnancy related, activities. But again, the goal here is we know that just because a practitioner may authorize services doesn't always mean that our Medicaid members take that next step and actually engage in receiving those services or taking their medications or, following their treatment plan. And that's kind of really the goal of a doula, is to ensure that our mom and babies are doing that to hopefully improve health outcomes.
Representative Carpenter.
So I don't mean to kick this around a lot, but so do the MCOs have a role in this? I mean, see, you're talking about what the MCO should be doing for a pregnant woman. Is that not true?
So in our new contract, we do have some requirements around care coordination for pregnant moms. In our current contract, that's not as specific, and it's pretty limited. So I would say no. Today, they really don't do a lot of, they do some. I'm not saying they don't do any, but not to the level that a doula would support the mom and baby.
So they're independent of our managed care organizations? then?
Yes. Yeah, they're community providers.
Okay. And so is this a nationwide push to include doulas? I got to tell you, within the last 6 months, I never even knew what a doula was.
Yeah.
And now I hear about, so this is a nationwide
Yeah, there, and we can get you, yeah, there are other Medicaid states that cover doulas. There's also some commercial insurance that covers doula, but you are correct. Doula is I don't know exactly when, kind of doulas came on in the marketplace, but yes, it is more of a relatively new service, if you will. But yes, we are not the only Medicaid state that covers doula, we're not the only state that covers doulas.
Thank you, Madam Chair.
Representing Concanon, then Senator Gossage.
Thank you, Madam Chair. Christine, when you're talking about what they do, you're talking about what we're going to pay for them to do.
Yes.
Their scope is that they actually do deliver at home births. And my concern with this is that if we're having them do the type of things that we're going to pay for, that we're actually encouraging them to do some of the other procedures that we are not paying for. Does that make sense? If they're using a
Yeah, so
doula?
our billing is limited to the codes that you see here.
I get
So,
that.
yes,
I-
yeah,
I
but you're right.
understand that-
Doulas outside of Medicaid can do a broader array of services.
But we're bringing them into the home by paying for it. Yeah, I've got an issue with this, too. Thank you. Thank you, Madam Chair.
Senator Petty, or excuse me, Senator Gossage, then Senator Petty.
Thank you so much for being here. I can remember when Missouri passed their doula law, and that was like 2007 or something like that. It's been around a long time. The concern that I have is what Representative Landwehr had mentioned earlier, which is duplicative payment. And so it does say that the CHW, not specifically geared toward pregnancy, but what would happen if you've got the community health worker, and then you also have the doula saying, yeah, we helped her go to the doctor, we did this, whatever the codes are. How would that be handled?
So a CHW could not bill a doula code and vice versa. So they, if I'm providing, doula coverage, I'm a CHW, I can't bill those doula codes.
But it wouldn't necessarily be a doula code, right? Because it does say they don't specifically gear toward pregnancy, but they could help a woman, get her to the doctor, et cetera, that's pregnant. They would bill their own code, not the doula code, right?
I guess maybe technically, I think the thing to remember with community health workers is they're employed by like FQHCs. They're not standalone entities. And so as a FQ, for instance, because I know we have several of them that employ community health workers, if they're serving a pregnant mom, they're not going to have their own employee and a doula in the room at the same time. I mean, I think, you kind of got to look at it. CHWs, again, are more, they're hired by entities. Doulas are independent. And again, we know Medicaid reimbursement is not always known to be outstanding. So, why would I have an employee be in the exam room and that's costing me as a provider entity when they have a doula in the exam room as well?
And I guess I'm not looking at it as costing, it's more like billing. So I can bill for this worker over here, and then the doula's independent, and they can bill over here, and you've got bills coming from both sides. I just wondered if there were safeguards built in to watch for that.
Yeah, there would be. If we saw CHW claims and doula claims on the same date of service for the same patient, yes, that is, trackable. That would definitely raise questions. And what I'm kind of getting at, what we hear, again, from our FQs, is the cost to employ a community health worker is greater than the reimbursement they get for Medicaid. And that's kind of what I'm getting at. There's no incentive for them to be paying their staff to be providing the same service where we're not reimbursing them at 100% of that cost. If they have a doula present as well, they would like to use their staff resources to do activities that, aren't, being duplicative. But again, we do have, edits in the system, and that is stuff that we can identify very quickly if, again, there's duplicative. And that would be true not just of CHWs and doulas, but the whole array of services where there would be risk of duplication, if I can speak this morning.
Great. Thank you so much for answering the question.
Senator Petty.
Thank you. Christine, I think the question was asked about this doula movement. It's a national movement, and we do have a maternal health care problem in Kansas, just as many other states do as well. Hasn't this been an approach that's being used to directly impact that, to help high risk, I guess, underserved communities, mostly minorities, to have that non-medical personnel who will, as you just said earlier, help them to get their prenatal care taken care of, to go to their appointments, to follow up after, to be that support. I know in my area, the state, there's just a big issue about lack of doulas, about funding being taken away, and that's being looked at as a big negative. So I thought that our MCOs were, it was not part of their contracts, but that they were offering this as a service in our last contract. Was that correct?
Yeah, I'm sure some of them did because, again, MCOs have flexibility to do things. We just wouldn't reimburse them. It wouldn't be part of their capitation rates. But yes, they do provide services, and I would be sure that some of them did do doulas. But you're absolutely right. Doula, the doula movement is really around trying to improve maternal and infant health outcomes. We know Kansas does not perform well, and where we rank nationally is not where we want to be. So yes, the whole reason behind this was, again, trying to support mom and our infant babies to hopefully push the needle, and that Kansas's outcomes for delivery and that first year of life would improve.
Thank you so much.
Representative Reese.
Christine, my understanding is that a doula cannot deliver.
Not, Medicaid would
Kansas.
not, yeah. That would be a licensure question. That was kind of my understanding, that they can be present, but
Yeah.
I don't want to speak into what doulas can and can't do outside of Medicaid. I can just say for Medicaid, we would not reimburse a doula for delivering a baby. We pay them $500 to be present when the baby's being delivered, but we would not reimburse them for, that would be a clinical service that we do not have opened up to them.
Right. Okay, thank you.
Representative Ballard.
Thank you, Madam Chair. I'm glad we're having this conversation because I think there's really quite a little confusion about it and whether or not it's being double billed as well, and I wasn't sure about that. But again, I think you have talked about why we have doulas, and part of it is because it was a minimum in terms of available to make sure we have that. Also, if we look at the baby weight and the mortality and all of that was happening, you would think the mother would be very conscientious about going and everything else, but there's a lot of people that don't take prenatal, they don't do all those other things you're supposed to, and then the state ends up having to pay to take care of all of that, and this is to take care of it before it happens.
Correct.
And provide
Yes.
the services for it. And it's been verified, you can't deliver babies. You're doing some of the work that people have. A lot of times it's because that individual does not have an automobile. They don't have transportation. They don't have all these other things to get them where it is. And so most of it, the way I understand it, was a money saving as well as health for mother and baby in many ways. And I guess for that reason, and because I read about, especially people of color, how they fit into that category, it makes sense that, yes, we want to save money, but we also want a healthy baby, and we want a mother that's in good shape to take care of this child as well. And they are not at the top end. They are actually on the low end in terms of what they receive as a result of all the things we would like to accomplish by having a doula.
Yep.
Am I
Correct.
correct?
Yeah, that's a lot of the motivation behind it. Also, we know, a lot of these mothers may not have the family support that, some other folks may have, again, to, encourage them, help them get to appointments, help them do things. And for everything that you just said, and knowing that sometimes that family support structure isn't around them, but it is all geared towards delivering a healthy baby, and then helping mom in that first year where we know postpartum depression, just the overwhelming of now having an infant to take care of, but again, that the baby is healthier than we've seen in Medicaid, and then that we're helping mom and baby in that first year of life, and to your point, to avoid the bad outcomes and the more expensive care that can come when you're not doing what you need to do through your pregnancy, and even taking care of yourself post-pregnancy, because we know, for moms that first year, there's a higher mortality rate in that first year postpartum. So again, absolutely everything you said is really the motivation around this movement that's, really gained traction in the last several years.
Thank you very much.
Senator Gossage.
Thank you, Christine. Just a clarification. So is this service outside the MCO contract?
No, the MCOs it's in their capitation rate.
Okay, that's what I
Yes.
thought. I just wanted to verify.
It's
So the
just not an employee, they're just not employees of the MCO, but you are correct, it would be part of their capitation rate.
Okay, so the MCOs, when those payments come in, they can see both for that same claimant.
Yeah.
Okay, that's very helpful. And do we know of any savings within, states, because this has been around for a long time, savings of states that, for what they're paying for by having a doula that somebody feels comfortable with, that helping them through the pregnancy?
I'm not aware. We can ask that question. We're actually going out to the National Association of Medicaid Directors meeting in about 3 weeks. And I can ask the states that have had doula longer than we have in Kansas if they have any data available. I'm not aware of any yet, because in the Medicaid side, this has been more of a relatively new service that states have been picking up. But we can't ask that question of the states that are ahead of us in time if they have any data yet that shows impact to health outcomes.
I just recall it coming up at an NCSL Health Committee meeting that there was savings within the state, so
Yeah.
I'd be curious to know.
Yeah.
Thank you.
Okay, now you've totally confused me this morning, Christine. We said that this is outside of our Medicaid.
So when I said that, what I meant is they are not an employee. So care coordination, when we talk care coordination for the MCOs employ care coordinators that take care of certain populations within Medicaid, and so they're MCO employees. Doula is not, they are not employees of the MCO. They're a provider just like another provider. So yes, I should have been clearer on that. So that's what I meant by not a part of the MCO. They're not MCO employees providing these services. They are a community practitioner or non-clinical person.
Okay, that part I understood, but if we're looking at a funding source outside of this, and at the same time you said it's in the capitation rate.
Yeah, it's in the capitation rate. So they would provide the service, they would bill the MCO, be reimbursed, and then we get all the claims data from the MCOs, so that's actually how we have, it's encounter data, which then comes to us. So then we can also pull and see all the doula reimbursements done. But the MCOs, they would bill an MCO just like other providers would.
I guess I'm really trying to wrap my arms around this is why wouldn't that be a case management service within the MCO? So we're dealing with one system instead of two different systems.
That is actually one of the goals in KanCare 3.0 is we call it community care coordination, of trying to bring these different streams, if you will. So you've got the MCOs that have care coordinators. You've got providers that have, they call them usually community health workers. Some call them care coordinators, but you have providers that have these folks employed. Then you have doulas, and I'm sure there's other types of community. And what we're trying to do is bring that into alignment. And what I mean by that is our goal is if we have a location in the state, let's say where we have doulas, and doulas can provide that care coordination for mom, then that allows our MCOs with their care coordinators to focus on areas of the state where that type of provider doesn't exist, because there's never enough of these folks to go around, and that's one of the complaints that we've heard in 2.0 is that that ratio of care coordinators from the MCOs to the population. And so what we're trying to do under KanCare 3.0, it'll take us a little bit to get there, is to look holistically that between these different CHWs, doulas, care coordinators, that we can make our reach statewide, actually provide the level of care coordination for all of our populations, not just, moms and babies. That need care coordination services, but making it coordinated, not duplicative. So if we do have, let's say, CHWs, I know our FQ down in Pittsburgh really utilizes CHWs. Well, so how do we maximize that area with the CHWs that are there, let the MCOs focus in other areas where we don't have CHWs. So that's one of the big goals of KanCare, is to make this streamlined, non-duplicative, statewide, and that all of our populations get the services that they need.
Representative Reese.
I think another piece of data that would be good to hear about is the impact of the doulas regarding the mortality rate, especially within the African American population, because that is where the highest maternal mortality rate exists. To see what the impact of doulas would have on the mortality rate, whether we would see that get lowered. And a clarification, just, it seems to me also that the doulas, different from a community worker, is that the doulas are going to be there during the birth, in the community worker may or may not be there.
Correct.
And the whole purpose of having the doula is to have the doula there.
Yes.
Before, during, after the birth.
Correct. And then I also want to just also point out what doulas, this is all mom choice. If mom doesn't want the doula, they only want the doula for prenatal care. That is mom's choice. It's not a requirement. It's not a mandate that the doula has to, do everything that they could bill for. It truly is the mom and the family's choice of what they want to utilize a doula for.
Senator Gossage.
One last clarification. So we see this dollar amount under 9, and I'm wondering then, because there seems to be some confusion, is that on top of, or was that amount, you're telling us that amount was included in the full Medicaid, how much you expected Medicaid to cost for this year, and then it was part of the calculation for the capitation amount?
Yep, so that $350,000 is what Medicaid expected to spend in a state fiscal year to cover doulas. So all funds, $350,000 is what we're estimating Medicaid will pay, and then, yes, that is calculated into the capitation rates. I can tell you that 350,000 really doesn't move the needle in capitation rates much at all, because obviously that's a small dollar amount. But yes, that is what we expect to spend in the state fiscal year.
All right. Thank you.
Representative Berquist.
Thank you, Madam Chair. The services that are provided apparently by a doula, and we are pretty new. Representative Carpenter and I are both new to even hearing of doula in the last meeting we were in. But the services that are provided here in the state of Kansas, or that we're trying to get established, do they only include carrying a child and mother through to birth and everywhere in between, or do they include abortion?
No, Medicaid does not cover abortion. Again, doulas, it's on their website. They do, outside of Medicaid, provide some support around abortion, but that is not a Medicaid code, and Medicaid does not cover that. And we have a lot of other providers that may provide abortion-related services, but those are not reimbursed for by Medicaid. And there's actually federal, it's called the Hyde Amendment, and it's actually federal regulation that greatly limits what Medicaid. So states don't have a lot of flexibility, but Kansas Medicaid, we do not cover abortion for doulas.
Yeah, and just to follow up, that question wasn't in regards to them performing abortion, but assisting, and across the nation there are others that do. Now that I've researched it in the last few weeks, there are doulas that provide the services to assist them as they go to get an abortion. So
yeah, but but
not
that's
in this case.
No, not for Kansas.
Thank you, ma'am.
Yep.
Representative Reese, we dealt with your question, correct? All right, I just didn't mark it off. Representative Carpenter.
Thank you, Madam Chair. I was just trying to figure this out. So, Christine, what rate cell is it under then, out of your Medicaid report? Is it under CHIPS pregnant women, or is it PLE pregnant women?
I will have to find out what rate cell it's included in.
Okay.
I don't know that off the top of my head.
Yeah,
There's too many
I
of them.
There's 38 of them. I get it.
Yeah. Yeah, I would assume that's where it is, but let me verify that, because we have too many rate cells for me to want to say that off the top of my head.
I get it. Thank you.
All right, committee, are there any further questions?
Madam Chair, I have a question.
I'm sorry, Dave did tell me that you had one, so I apologize, Senator. So Senator Baumgardner.
No problem. Thank you very much, Madam Chair. My question about the doulas is, as of mid-October, it indicates online that there are only 20 doulas in the state of Kansas. Where exactly are those located? Because I don't think it's so much the 350,000 that's being budgeted to move the dial, but if you only have 20 doulas, that's not going to move the dial much either. Where are they located?
I would only know where the ones that are enrolled in Medicaid are located, and I could get that to you. I could get the number and where they're located.
So we don't, Madam Chair, we don't have any idea of the 20 doulas that are non-clinical professionals in our state. We don't know how many of them are Medicare doulas. There can't be that many. I mean.
Would that be correct, Christine?
So we wouldn't have the information on how many doulas are certified statewide. I'm sure the Doula Association would have that number. What I would have access to is how many doulas have completed Medicaid enrollment and where they're located. We don't have access to data of how many doulas are certified around the state. But I can provide all the data around the ones that have enrolled in Medicaid. But I would assume the association probably has that information just for non-Medicaid.
Senator Baumgardner.
Thank you, Madam Chair. I think that we do. We need that information, and I think that that is, it really points to a bigger issue of how many healthcare providers, and actually this is a non-clinical professional, so I don't think that they are a service provider. I don't know that you could say they're a healthcare provider, but that is something that the legislature has asked for some time now, is just when we look at the map of Kansas, where are Medicaid enrolled healthcare professionals? In this case, it would be a non-clinical professional. So we need it not only in doulas. In some ways, we can't even say that the 350,000 isn't enough. It could be well above what is really necessary. So I appreciate the opportunity to ask the question. I do think that if any money is dispersed with regard to this, we do need to be tracking how many prenatal, postnatal women received any type of service, and how did that change in any way that prenatal, postnatal problem that we have of too many deaths in the state of Kansas. Thank you, Madam Chair.
You know, I think, Christine, that the senator makes a good point, because whenever we're paying for services, we know who our providers are, whether it's in the healthcare field or whatever it is. So, and staff, I'll have to have you help me with the wording, but somehow we, you know, going back to what the senator's question was, is what should we track and how can we track it?
Yep.
And I think if these people are working with the MCOs, they could be a part of that. The association could be a part of that. And, you know, if you guys would, you know, come back and help us with that, I think that would be helpful for us going forward.
Yep, yeah. And we
Because the
can-
outcomes
yeah.
will be very important.
Yes, yeah. And we can provide, like I said, we can provide, you know, a lot of information around Medicaid, and what that might inform the committee of is what maybe you want to ask other insurers or the association if they have access to that same type of data for non-Medicaid. But absolutely, we can work with your staff on going through what kind of data points are available and what might be helpful.
Okay, have I confused staff at all? You guys are so good. So outcomes would also be a part of what we're looking at. And so that becomes an item on this sheet. Representative Carpenter.
Thank you, Madam Chair. It's amazing. On the second question, the committee has ran off the rails already today. So we're off to a good start.
Are you going for a record here?
No, I don't know. I'm just saying, but I think this committee and the legislature has been committed, you know, to healthy outcomes, and we've put a lot of money into this. We have presumed eligibility, you know, so none of this means that we're not
Correct.
serious about infant death and all that kind of stuff. We have presumed eligibility before they're even eligible for Medicaid. So we've done a lot of steps.
Yes.
We have 12 months postpartum. You know, I'm just saying, this questioning isn't questioning.
Understood, yes.
Okay.
Yep.
Thank you.
And just one thing that I'll mention that's kind of, again, not specific to doulas, but part of our data bureau that we created, this is a whole area that we want to really be able to dig into from a data perspective. And because I think one of the things that KDHE has not done well is when we implement something, whether that be doulas or anything else, is deciding how do you measure success? And then tracking that and reporting, because sometimes we're going to try things in Medicaid that don't get us the results that we were anticipating up front. And there could be a variety of reasons for that, but that is part of our commitment going forward to the legislature and to the public, is to have more of that outcome-based, being able to identify what's helping us move the needle, and looking at this area holistically, because one service, and I think the committee has alluded to that, one service in and of itself is not going to move the needle. In fact, we just created within KDHE, we call it our Infant and Maternal Health Roadmap. And what that is trying to look at this area holistically and what can Medicaid do in the next 3 years, and we'll be sharing this with the legislature, that could really, again, with the idea being really help us move the needle, because piecemealing services isn't really the right answer. What we should be doing is coming and saying, for maternal and infant health, here's holistically the things that we think Medicaid should engage in to really impact outcomes, and being able to provide what that might mean from a cost perspective as well as a cost avoidance perspective, but then also having those markers already determined of how do we measure success and how do we provide, that data. So we are within Medicaid trying to look more holistically, if you will, at areas. We're going to be digging into some other areas. EPSDT is going to be one of the next areas that we're going to look at to try to, again, do this in a much more holistic way instead of piecemeal service by service.
So to add staff to the, I think, we need to figure out, Christine, somewhat, where can we have them register? And it sounds like probably with you guys, for us to know how many of these providers that we have out here, and then looking at the outcomes, et cetera. So if you can help us figure the best way to do that, we'd appreciate it.
Okay, will do.
All right?
Yep.
Any further questions on this one? We're going to go ahead and keep this on our list,
Yep.
just because, as I was sharing with Senator Gossage, there'll be a pretty much new committee next year, and this will give them a basis that we've already covered, and then you wouldn't have to come back and cover it again.
Okay.
All right?
Excellent.
Next.
All right, so I think we're on 11.
Yes.
And this is, again, more around doulas. So what we've provided here is just some of the other areas of support for moms and babies. Obviously, we've talked about the clinical activities. Also, I wanted to point out that our MCOs provide some value-added benefits to support pregnant moms and babies as well. And if you're interested, I've got the website, the link there, but we can also provide it in written form. But again, our MCOs do a variety of things, again, outside of Medicaid, what's covered by Medicaid. That's what a value-added benefit is a service that the MCOs are not reimbursed for, or services, I should say, because they all have several value-added benefits. They're not covered by Medicaid, so they're not part of their capitation rates, but they offer them as a way to support their Medicaid population. So we do have some value-added benefits for moms and babies. And then under public health, I've kind of listed here some of the programs that the public health departments or local health departments offer to pregnant moms and babies. And again, one thing that Medicaid, again, helpful that public health is a part of our agency. We coordinate with public health a lot when we're doing services, to the point to make sure we don't have duplication, and that the two services too are complementing each other. And I think we're getting better and better of working with our public health peers to get our services to really complement each other. Again, what our goal is in 3.0 is to expand the reach and do more statewide coverage. And by partnering with public health, that's another good arm for Medicaid and public health to work together and have our programs really complement each other and really, again, as I was talking before, provide that kind of holistic movement of the needle, because only by working together are we going to really impact health outcomes, not just for, again, moms and babies, but just our Medicaid population as a whole.
All right. One thing, as I was reading number 11, that I thought about is staff, we need to add, I don't know that it's a KDHE thing, but the pregnancy resource centers, we should have a report, because now we've had them in place, well, they've been in place for a long time, but now that they're being funded, partially funded with the state, is a report that should be coming to the legislature. I just don't remember when that report's due. So let's put that as an item on here, because I think that's something for us to monitor, because they do a lot of the providing services during the pregnancy and up to 2 years after the pregnancy. So I think, there's a lot of things even outside of what
Yes.
we do on, with your department, so.
Yeah, exactly, exactly.
All right, so we'll keep number 11 again, just to continue going forward with next year.
Okay.
Yeah, staff just has to figure out where it gets added on the spreadsheet, and I leave that up to them. Number 12.
Okay, number 12, we talked about this some yesterday, the timeline for network adequacy. We've already started that work. I shared those numbers with you yesterday. It will be around December 1st when we will submit our required information to CMS. But we actually monitor, one thing I did want to point out, we actually monitor network adequacy every quarter so once we get to January 1, it's not like we're going to stop looking at network adequacy. Those are quarterly reports that are done and work done with our MCOs to ensure that not only do we have network adequacy at the implementation of a new contract, but that it's maintained throughout the life of the contract.
Okay, and I think, again, we'll keep number 12, but let's add to that, staff, that, because this answers our timeline issue. It's, what are the numbers?
Yep.
So what's the data coming back to us, so that this committee can keep on top of that? Unless there's objection, committee, if I make that suggestion to keep something or whatever, feel free to chime in and disagree with me. I'll still win, but that's okay.
We know that.
I'm kidding. Okay.
All right.
Number 13.
This is the last question for Medicaid. There was the ask of Mercer and their contract and what we've paid to Mercer. These are all funds. Numbers listed here. I just realized that we didn't break this out because we do get federal match. But essentially on this contract, I think most of it is 50-50, but we can do that if you so desire. But Mercer started working on KanCare 3.0 in January of 2023. You kind of see the breakdown here. So the RFP stakeholder support was all the public meetings that we did. It was the collection of all of the feedback that we received from stakeholders and providers of changes they wanted to see in the procurement, and we did get a lot of feedback. So Mercer tracked all that for us, and then they ensured that things got put into the RFP. And then you'll see the actual procurement. So that was development of the RFP that was released. And then we had the Executive Oversight Committee. That was a committee of the two secretaries, Secretary Stanek and Secretary Howard. And then leadership from KDADS and KDHE from the Medicaid side. And again, this was the committee that was kind of the decision-making committee on what would be included in the RFP, the wording of it, and other decisions that, had to be made as we developed the RFP. And then the evaluation, this was that dollar amount represents their support of our consensus review committees as well as PNC. And then right now we're in readiness, and so that's the total of what we've spent so far, and they're assisting us in getting ready for January 1. So they've provided some support to us in the readiness reviews that we've been doing with all three of the MCOs. Obviously, with Healthy Blues, readiness review being much larger in scope than our two incumbents, but that's what that represents.
Senator Baumgartner, do you have any comments or questions on item 13? Did we lose her? All right, we'll go to Senator Petty.
Thank you, Madam Chair. Christine, how does this amount that we spent with Mercer to go about on getting our next round of MCOs, how does that compare with 5 years ago?
We can get those numbers because Mercer actually did, I believe, I know they did the last round. I know they did KanCare 2.0, so we can get that. I also believe they helped with the initial implementation, but yes, we can get those numbers for you of what we paid back in 18, 17, 18, whenever
It
that.
could just be interesting,
Yes.
to just how, it becomes more and more expensive every
Yes.
time we have to go through this process. Not that it's important, but.
Yep, absolutely. We can get those numbers for
Thank
you.
Let's see if at some point we can't get the question back to Senator Baumgartner, and then we can make a decision whether it stays or not. So when we get done here, make sure I come back, circle back around on it. That's it for
All
you?
right, that is it for me.
All
Thank
right,
you.
Thank you very much, Christine, appreciate it. Next, I have Andy Brown, Deputy Secretary of Programs, KDADS. Welcome back.
Thank you. Andy Brown from KDADS. And so my first item is number 2 on our KDADS list. And this is around developing models for intensive community support for the IDD community. For Q4, our update is that we have 6 contracts that have been administered with $2 million that we were provided, with the objective for each project being to enhance services for individuals with IDD and co-occurring behavioral health needs. Also, we're working on a project with Guidehouse in order to try and provide individuals with complex behavioral health needs and IDD an improvement in the quality of crisis services. So that project is funded through ARPA. It's enhanced federal funding for Medicaid, HCBS, that goes through September 30th of 2025. But Guidehouse will be providing education and training for individuals and families, IDD providers, 988 providers, and crisis responders to increase competency around IDD.
Okay, we started it in 23 in December. Is there any data for that 6 months there?
I believe we have data, and we could probably pull that together for the next report.
I think staff, that would be good for us to get some data. So now we understand, with the development and everything. So now it's important for us then to not only monitor the cost of the program, but what are the outcomes of the program, so that we know whether we're succeeding in what our intention is. Because this is becoming, I believe, a growing problem, is what I'm kind of hearing in some reports. So, any questions, comments on item 2? No, we'll keep it, and then with those additions, staff. All right, item 3.
So for item 3, this is about technology first efforts. We've awarded a task order to McKinsey & Associates. So that work will be beginning here shortly.
Well, this has been a long time to be worked on, isn't it?
Yeah, yeah.
Comments, questions? All right, we'll keep it, huh? Oh, do you have a dollar amount on this?
I don't think I have the dollar amount with me today, but I
Can
can,
get it to us?
yep.
And I think that's something going forward that it becomes part of your response, please.
Like a spent year-to-date.
Huh?
You're thinking like how much have we spent year-to-date on it, or do you want the total amount?
Well, I think the total amount, and then break it out by, this part here, and then this is, keep it in our fiscal year so that we're not juggling all that. We have a bad enough time trying to do the fiscal year state and the fiscal year fed, so.
Yep.
All right, we're going to keep that item with that addition.
Okay.
Item number 4?
Yeah, so item number 4, this is around the KMIS system update. So for Q4, we're in the process of procuring the vendor to complete the KMIS study as requested by the legislature for fiscal year '24. The agency is working with Department of Administration for an RFP with anticipation for it to post this month. And KDADS expects an analysis and report to be completed by June 30th of 2025.
All right, we'll keep that item and then look for the addition of report for KanCare Oversight next year, after that 6/30 date, right?
Yep. So item number 5 is around ABA analysis for therapy. We've moved to the point now where we're just monitoring utilization of the ABA group therapy code. And if there's continued interest in monitoring that, we could just maybe start doing a report on the utilization.
I think that we need that.
Okay.
All right, so that stays. Item 6.
Item 6, this one's around respite care. As we mentioned last quarter, we were working on hiring a TA program manager. Right now, we're in the interview process for that position, and hope to have a candidate selected soon.
Okay, we'll keep that item so that we can continue to get updated on it.
For item 7, this one is around hospital inpatient settings and what obstacles there are for hospitals billing for services while they have someone that's waiting. And we've gone through a couple of different steps on this. Our update for this quarter is that we have a follow-up meeting scheduled with the Kansas Hospital Association and hospital stakeholders on October 14th, where we discussed options for service codes and improved processes to identify appropriate placements for patients that are no longer needing acute or inpatient treatment. So we should have some additional updates at the next Bethel.
Okay, so again, we'll keep that item there and then just make sure we ask for the update of current information for KanCare next year.
Item 9, this one is an ongoing sort of item around the statutory and policy changes that are needed to reduce wait times or to provide mental health treatment to defendants while they're waiting for competency evaluation or treatment. So these are people that are justice involved and awaiting trial. So our update for this quarter is that the Governor's Advisory Panel and South Central Regional Hospital recommended Criminal Justice Coordinating Council or Judicial Council review the Care and Treatment Act for mentally ill persons and propose changes to the involuntary commitment statutes for the 2027 legislative session. This review should include identifying processes to prioritize individuals in crisis, screen for involuntary care and treatment, to ease the strain on law enforcement resources. The Judicial Council has developed a legislative proposal to use outpatient treatment orders to reduce demand on state hospitals for forensic treatment. And the KDAD's presentation includes information on mobile and outpatient competency efforts with the CMHCs.
So Andy, when I look at the last quarter, KDADS was working with Wheat State Healthcare to expand the outpatient competency.
Yep.
So do we have a report then that shows us
So
what
Drew,
that progress is, and if not, will we in the future?
So I think Drew covered that yesterday in the agency presentation, but we're continuing to work with Wheat State on expanding the opportunities at the community level.
So somehow, staff, I think that we need to we'll keep this item, but somehow tie it back to a report, because I didn't necessarily catch that, so.
Yep.
If we just figure out what that system is going forward, that'd be good. Okay? Number 12.
Yeah.
Wait
So
a minute. Representative Berquist. I'm sorry, Andy.
Thank you, ma'am. During our discussion of this item that you just finished with, it was brought to mind, or brought to fact, that there was at least one person incarcerated over an extended period of time, over a year, waiting for this evaluation. when I see the possibility of a group studying for recommendations to be brought to the Criminal Justice Coordinating Council and possibly have action for the 2027 session. It seems less urgent, and maybe for an individual or 2 or 10 that are incarcerated and that aren't getting these needs met, policy needs to be met with urgency to at least address the people that are in that urgent situation. I don't know what the update was on that individual, but I do know that 2027 sounds like a long time to wait for a solution for something that could be have somebody only waiting in jail because they can't get an evaluation. And that's my concern. Thank you.
And correct me if I say something wrong here, Andy, but I think part of it is, we think of an evaluation, we think of something simplistic, but these evaluations are very extensive. And as you heard yesterday in testimony, when the new hospital gets up, half of those beds will go to working on this issue. And once they get to the hospital, they could be there 2 months, 3 months, a year. So those evaluations are complex depending upon the individual and everything that they have to go to. So I'm going to make an assumption, which I don't normally like to do, that's probably a part of this 27 date that you're seeing, which I agree with you, we're frustrated with it. But I don't think that anybody had any choice. But it does appear that in the testament we had yesterday, there is assistance that we are starting to get into our jails, and we've seen some of that to get services provided. So it's tough. Representative Bergquist.
Yes, and thank you for that response. I appreciate that. And that's the concern I have, is making sure that people who have situations that are beyond just criminal, that need to be evaluated, that they at least get to the point where they're being evaluated. And to be in a mental facility for a period of time, to be able to be evaluated, is not as much the problem as being held as a criminal in a static situation without an evaluation. And thank you very much, Madam Chair.
Well, remember, they're being held as a criminal because they did commit a crime.
Certainly, certainly.
Right. So it's not like we're incarcerating mental health people because they have mental health issues.
Gotcha. Thank you.
I wanted to clarify that. So we're going to keep this item on here and monitor it.
So for number 12, this is around the BI waiver. So for this quarter's update, the MCOs have been responsive in assuring services such as meal delivery, medication reminders, and personal emergency systems are used immediately. Participants enter therapies as agreed on in their person-centered service plan. If there's a wait time for therapists, they are informed and are encouraged to consider other providers if the timeline does not meet their needs. Due to receiving the ARP funds, we are unable to implement the changes in the BI waiver to improve the framework and timelines as they were viewed as being more restrictive. We will be revisiting this at the end of 2025 when these management limitations will be lifted. And we continue to monitor enrollment, service utilization for areas that we need and can improve our performance, both in timeliness and being person-centered as we support the BI waiver populations.
Okay, Andy, so why was the receiving of ARPA funds creating a roadblock for us?
So I think it was simply because that there were restrictions within that kept us from being able to move forward.
In the ARPA funds?
Yes.
I think it would maybe be good for us to know what that was, what those roadblocks were.
Yeah, okay. We can better define that.
So are we making improvement or not?
So I believe we're making progress on improvement through the MCOs and also through our work with KDHE. We aren't making changes yet to the BI waiver itself, however.
Okay. I think we need to figure out what report we may have already out there, and if not, one that we need to create in order for us to actually see data so that we can take and show the progress rather than just verbiage. Representative Carpenter.
Thank you, Madam Chair, and I can't find the slide, but it was in yesterday's testimony about the brain injury, and we have like 170 some people that have been on the list for like 4 years. Is that accurate?
Yeah, so Michelle says that is accurate.
You know, I've railed on this many, many times about, are they still receiving therapy? And our brain injury, you know, continues to go up a couple hundred people every year, and we end up putting more and more money on that. But at some point in time, who makes that decision to discontinue therapy? And quite frankly, you know, I'm not trying to be incompassionate here or anything, but they go to a long-term care facility.
Well, so the goal of the HCBS program is to prevent people from ending up in long-term care facilities. So when we're trying to evaluate whether or not someone is benefiting from the waiver, that's really kind of our ultimate metric, right? Is if you're able to receive services in the community and maintain, you know, a sense of independence within the community, that's our preferred approach. So we really do look at long-term care as being a, you know, sort of a measure of last resort when we're looking at HCBS waivers.
And I do too. But at some point in time, there is a point where therapy is not working and there's no services available for those folks, and that is the option. And I worry about, what I worry about is that, and of course we have such an open-ended deal with the brain injury, but I worry about other people that are not getting the critical services in the first week, or, you know, when it's critical for brain injury folks to get services. I worry about them not getting services because we're diverting those services to folks that have been on the brain injury for long periods of time. That's the only way I come from. We all know there's tons of science out there that says that you can make remarkable improvements in people if they get services, you know, immediately after the brain injury. And we all know that. So that's my only concern about this whole thing. Thank you.
Well, I guess it comes down to then, you know, what is your definition of beneficial? Because from a medical perspective, and we have this in other areas of healthcare, that you have to show improvement. So what's the difference between improvement and beneficial?
Yeah, and I think we would be happy to come and maybe do a 20-minute presentation on the BI waiver and how that's evaluated, if we want to do that at a future Bethel.
I think that would be good to do that. So staff, we add not only a report, but then a presentation for Bethel next year. 13.
All right, so for 13, this is around the waiting list for the PD waiver. So for this quarter's update, our pre-mega offer round waiting list was 2,428. After the mega round offer, we sent out letters of 1,133 individuals. We had 440 individuals that accepted. We had 53 that declined. So our post-mega offer round wait list is now at 1,069. KDADS is working on 2 additional offer rounds of 500 each to fill additional slots between now and the end of the year.
I like the way that you've laid this out, and I think we'll keep the item on here so that we can monitor going forward.
Yeah, credit to the staff for that.
Yeah. You know, I'm wondering, staff, if on the items that we're just monitoring, if maybe we just put monitored And then we're not guessing, well, why did we keep that on there? Okay, item 14.
For item 14, this is around the IDD waiver. Our pre-mega offer round wait list was 5,407. During the mega offer round, total offers of 778 were made. Total offers accepted were 519, or 66.7%. And our post-mega offer round wait list is now at 4,549.
Senator Gossage.
Thank you, Andy. Can you tell us why someone would not accept an offer?
I don't think I personally can tell you why somebody might not, but there could be multiple reasons that could be. It could be somebody's moved, or that they no longer feel like those services would be beneficial to them. There might have been a change in their personal coverage levels. It's hard for, they might have gone into an institution.
So then, if we have 519 that accepted, and the offers made were 778, one can assume the others were declined, or that just didn't hear back?
I'd have to go back to the staff and ask about that.
Then my next question would be, then let's look back up at the previous, and we say 53 were declines. So were they taken off the waiting list?
Yes.
Thank you.
Would be on both of these that they'd come off of the list. Okay. We'll keep that to monitor. And again, this layout's very helpful. Number 15.
Okay, so for number 15, this is again related to the wait list. And we have been working on trying to clarify some additional questions. So the actual dollar amount for the KU-CR contract, that was $99,924. I think that came up yesterday as well. We did use a bid process. The key project activities included developing a career ladder that addresses all sides of the DSW career, so entry, advancement, pathways to other careers, landscape analysis, or a systematic method of identifying the strengths, resources, and needs of the program within a broader environmental context. It included a labor market analysis, a behavioral economics survey, the creation of a marketing campaign, and a long-term implementation and sustainability plan.
Committee questions? Senator Gossage.
Could you explain the bottom paragraph? KDADS has also applied for and been accepted into the State Peer Learning Collaborative. What does that entail?
So a peer learning collaborative is a form of federal technical assistance. So we work with other states that are working on the same issues, and we learn about that process together and share information with other states.
Specific to this?
Yes.
Okay, thank you.
So at what point do we get a report?
Hang on just a second. Okay, so that's an ARPA-funded project, and it should be completed in '25.
Do we know when in '25?
Probably the end of 25.
So, January.
Okay. Senator Petty.
Is it 11/30 of '25? Is it the project timeline? Is that it?
Yes.
Do we have a report by then?
Yeah.
So we wouldn't have updates ongoing between now and then.
We can provide updates.
I think that's what we should do. Pardon? Yeah, so we're monitoring it, but they'll come back, and if they've got data, you know, each quarter, they can provide us that data, and then at the end of the year, then we'll have a complete report. Because there may be, you know, and I'm not quite as well versed in this particular item, but there may be tweaks that need to be made along the way as we see things not trending the way we think they should, and et cetera.
Yeah, well, and I believe the deliverables will come in at different points on that timeline. So like, we may have the market analysis completed, you know, earlier in the year and be able to share that information at that point.
Right, that'd be
for
good.
example. Yeah.
Okay? Senator Petty. I'm pausing because for some reason I want to say representative all day today.
That's your favorite word. So. Favorite title.
That's true.
I'll stick with the senator one. So it looks like this is the $25 million question here, though. If this study can figure out how we can increase the workforce and keep them coming, we've answered all of our other problems. So good luck with that one.
Thanks.
Okay, item 16. Oh, wait a minute. Representative Berquist.
And thank you. And these meetings that are held throughout the year are really beneficial to us, keeping updated to update our plans for the next legislative sessions. And so these updates, if they can come somewhere before our next Bethell, and then that would be beneficial to us to be able to discuss. And instead of running into the end of the year, in November of next year, and trying to get ready for another legislative session in a hurry. So, thank you.
Right, and that's why having these quarters laid out is very important for us. Thank you.
Thank you, ma'am.
All right, number 16.
So this is around case management services for the FE and PD waiver. Our update for this quarter is that meetings with the MCOs have led to a draft plan for the implementation of community care coordination. There's a reference here to the beginning of April 2025. We had a meeting at the end of last week, I believe, where that has been revised. So we're no longer expecting the implementation to start on April 25. But we are making progress on the development and implementation of that plan. So it should happen, we're projecting probably in the September through December range in the second quarter of next fiscal year.
Boy, that's a ways off, isn't it?
It's a ways off, but there's a lot of planning that we need to do and system changes that we need to make.
Okay, and I think on all of these items, you know, like we've done ahead of this, Andy, is any report and data that you can provide in this explanation will be definitely beneficial to us. So, yeah, and I'll get to him. We'll keep this item on here so that we can continue to monitor and see where we're at. Representative Carpenter.
Thank you, Madam Chair. So, Andy, isn't that part of the new MCO contract?
Yes.
So across the board, it's not just for the waivers, but it's...
That's correct.
Okay.
It should benefit additional populations outside of the HCBS program. The way we've structured it with the MCOs is that the MCOs will have the opportunity to identify individual members that may benefit from community care coordination and make a referral for that. Also, a provider might identify and make a recommendation to the MCO for that individual to receive community care coordination services. So it'll be open to additional members outside of HCBS.
All right, very good. Thank you.
All right, 21.
Well, I'm on 17. Okay. That's all right. It's okay. So 17 is around foster home recruitment and retention and looking at workforce issues. We did present yesterday afternoon on the McKinsey report on the PRTF capacity, staffing, and ideas for improvements around PRTFs. So we're continuing this work, and we can continue to provide updates.
You know, I still think, Andy, you know, one of our problems, and I mean, it's been there as long as I've been up here with the foster care, is not getting the training for our foster care homes when we know that these kids are going to go there when they need to be somewhere else, but we don't have the capacity to handle them. So what progress are we making to assure that these parents have the training and they have the tools and then also have backup when things happen? Because, I mean, we're talking your runners, your fire starters, your sexually active, and then those that are dealing with SED.
Yeah, so our BHS staff meets regularly with the DCF staff to talk about how we can enhance that part of the program. There's a lot of contractual relationships that are involved in that. And so we're working to increase the amount of information that's in the contract agreements with the CMHCs and also with the CMPs to try and make sure that there's adequate information being provided to the foster families about what the process for accessing care looks like.
Representing KanCare.
Thank you, Madam Chair. We also made a significant investment last year in therapeutic foster homes, which is, that's the training to handle some of these kids.
Representing Ballard.
Thank you. I was going to mention therapeutic, and I'll just echo that. That was important. A question that I hear often is, are foster homes really doing what we want them to do for the children that we place there? And I don't know how to answer that question. So I'm going to ask you a few questions. Are we still facing shortage of foster parents?
So it might be better to save those questions for Tanya from DCF.
Okay, I can do that.
Yeah.
Thank you, Madam Chair.
Senator Petty.
I just need a reminder when the crisis, when when a child goes into a crisis center, how long can they be there?
So it depends on if it's a crisis respite center or if it's a JCIC or what type of crisis center it is. But for the acute types, like crisis intervention centers, it's a shorter term stay. For crisis respite, I think it can be up to 28 days. And Tanya might be able to clarify that.
Thank you.
Committee, are there further questions or comments? Again, I think we'll keep this item here and then look forward to a report with data for progress on how we're improving and where we're headed with that. Number 18. Are you responding for DCF and KDADS today, or?
I think Tanya's here.
Oh, okay.
Yeah.
I can't see her.
It's okay. She's here.
Oh, there she is. You were hiding, Tanya. Okay.
So for 18, indeed, we just said, please see the response from presentation from Unitas. So Unitas gave a nice presentation yesterday. I didn't know if there's any additional information you guys need from us, but that is a DCF program, and you had the additional presentation yesterday.
All right, so on that, we keep that and then look forward to regular reports.
Yep. So for 19, this is around the Autism Task Force. So we did form a task force in 2021. KDADS did that through our secretary. That program or task team has completed its charge, so that team is no longer meeting. The ratified report, we provided a link to the report. And I've been in conversations with the secretary about holding a meeting to review the report and the progress on the report, and maybe pick some items from the report that haven't had progress made on them that we might be able to focus on over the next year or two. Unfortunately, I had to delay that meeting because of the KanCare public meetings. So I'm still hopeful to be able to do that before the session starts, but it's something where we're probably not going to bring the task force itself back together to redo the work that they did a couple of years ago. We're just going to update it. And then for the additional questions that were included in there, numbers 1 through 6, we provided a separate handout for you guys to review with answers to those questions.
Is that something we went over yesterday, or?
The questions, no. So that it's just a separate handout that would have been part of your packet, I believe. And I can go over those if you want, but it'll take a little while.
We're just verifying that we did get it.
Okay.
We've had a few errors here happen, so. And I think just off of the cuff it's an item that we want to keep. And then I like your suggestion is going back and looking at what got addressed, what didn't get addressed, and what's our progress. So another report.
Yep.
So you're going to be full of reports for next year. Maybe not new programs, but reports.
Yeah.
Did you guys find it?
It's item 43 in the last drive.
Okay, so it is on our S drive. 43, she said? 43. And 44? 43 and 44. Yeah, not today's S drive.
Right, yeah. You want me to address them? Do you want me to say something?
Go ahead.
Okay.
Representative Ballard.
I would say that one we need to keep. We heard testimony yesterday via Zoom about some of the concerns that we're having, and I think many of us continue to have it. We have heard every year in social services about just things that's getting a little bit better, but we need to do this, and I think monitoring it is making it possible for us to make progress. So I would say we keep it.
Any other further comments, questions? All right, so we'll keep it and look for more information.
Yep. So for number 20, this is around the rates for the HCBS waivers. So again, we've included in your packet a complete list of all of the services and rates for each of the waivers that you can review. I don't know that it'd be the best use of the committee's time for me to go through it individually.
I'm just going to find it real quick here.
Yep.
That was yesterday.
Item 44 in the last drive. For today.
Oh, for today's. Oh, okay.
And it lays out the
Item
name of the service.
Or 44.
Yeah.
I'm sorry, I talked over the top of you, Andy.
Right, but we're on 20.
Go ahead, Andy.
I was going to say, like, it lays out the name of the service, the procedure code, what our fiscal year 25 rate is, and then what the unit definition is.
Representative Carpenter.
So, yeah, Andy, I appreciate this. I didn't realize, I didn't follow the conference committee report last year. I won't do that again. They dropped that, they cut the rate. We did parity, and the House did.
Yeah, I know.
And the Senate cut it, which I didn't realize until I started getting calls and people were bagging on me about the difference in the payments for waiver, and I was like, what? We did that. And then I realized. So anyway, that's what it's about. We're going to try it again this year, and we'll just monitor it a little bit better. We've got to get that. I mean, that makes no sense whatsoever to have, different waivers at different rates.
Yeah.
And I don't remember the cost of it, but I'm sure I'll be finding out. Thank you.
Sure.
Cap, is there a way for us to put a link to where this report shows up, I would assume it'd have to go back to the website that the public sees. So that if we're looking at this report on our computer, we could click and link to that report off the spreadsheet.
Yes, I can do that now that it's live on the website.
Right, yes, I agree with that. And we'll keep that on there so we see what happens to this next legislative session. I'm sorry, what?
Keep or monitor.
No, we're going to keep it, and then we're going to add a link of the report that we do have here. Because once it's public and posted out there, then they can link to that. So if we were to go back and look at this spreadsheet, we would be able to link right into it without having to search through, oh, remember that was done on the 23rd of October. And then it doesn't have to be produced a second time. 21.
Okay, so for 21, this is around the testimony you heard at the last session about the Explore Your Options resource guide. If you'll remember, Douglas County presented some information about the guide that they had printed in Douglas County using grant funding. And there's a request for us to look into whether or not we could do that at the statewide level. So we've been looking into the feasibility of updating and publishing an edition of the Know Your Own Options resource guide. The guide has not been produced for several years. And the staff position that was responsible for creating and maintaining the resource is no longer part of our commission. So we also do not currently have any designated funding for the printing of a guide. We also reached out to Douglas County to get information from them about how much the cost for them to print their guide was. They printed 1,000 copies of their booklet. The cost to do that was $7,600. So they used volunteers to verify the community resources, and their coordinator spent between 800 to 1,000 hours formatting and compiling the guide over 8 months. We extrapolated a little bit there, looking at Douglas County representing roughly 4% of the state overall population. So replicating for this across the state would be significant cost. We do think that it would probably require a position in order for us to be able to have someone that's managing this project year-round and making sure that those resources are being kept up to date for the next printing.
So we'd still probably run into the same problem if we just looked at it from a digital perspective of you're needing a person to
Yeah.
compile it, et cetera, et cetera.
Yeah.
Senator Petty.
It seems like it'd be more productive to support the local levels to do it as Douglas County did, to provide them with the funding because they're closest to the services and they can monitor on it. Whereas at the state level, whether it's my community or, our Representative Carpenter's community, they're changing constantly, and the closer they are, the better they are, even whether it's in print or digital, either way. Mm-hmm. So I'd say if we're looking at this funding, we should look at funding our area agents.
Yeah, so I do think that it makes sense to have a local, maybe like a local grant program that we do that would support this in the future, and that way Douglas County would be able to continue to do that work under future grants, and additional communities could implement that as well.
So that would be the state coming up with a pot of money and making it a grant deal specifically targeted at this. Senator Gossage.
Do we have any feedback from Douglas County on how often these are used? Reason I'm asking is so much of the time they can be outdated just as soon as they're printed. And you have resources that are gone, et cetera, and then they have to make changes. And many times if folks are needing these kinds of resources, they're referred to a department or an individual or a phone number where they can call and they can look up, the information that's already available online or that they have access to in a digital format. And so I'd be curious to know how much they actually used it, how soon was it outdated. If we could have a report back on that, that would be helpful.
Yeah, we can reach out to KABC and ask about that. I do think that they had only recently got their printed copies right before their presentation last Bethel. So I don't think they've had that for more than a few months, but I can ask and see how many of the copies they've used in the last.
And, not just, okay, we distributed this many copies, but, how many people called in regarding that resource? Because, just because you can distribute them, they can end up being thrown in the trash or use the line of garbage bin.
May I comment on
Thank
that a
you.
little bit? Sure.
Senator Petty?
Well, I understand the thought about that they're sometimes old before they're even distributed, but maybe it's just my age, but I find that you have digital resources, but if you have a printed copy, and we're talking about early agings, that even though a person might leave, you still have that person that has that brochure, and I'll just use myself as an example, that even if it might be a year old, you can go back or if somebody asks you about, you can look back and say, here's a possibility of a resource that you can reach out to. So I'm just saying things in print don't always get used that day, but they are a resource that's available and that then that person can refer back to, or their family member can refer back to for them. So I think it has can have a long-term value that we sometimes don't see immediately.
Yeah, and I will add that like my personal experience using these guides when I worked in senior services a few decades ago was that, I was able to sit down with individuals in my office and highlight sections of it and give it to them so they could then do follow-up. So it does allow the opportunity for the counselors to use the guide with the person there and help demonstrate that. And a lot of the information that's in there is just contact information for the programs. And that oftentimes, even if something in the eligibility or the rules of the program changes, that contact information stays the same and is still beneficial.
Representative Ballard and then Senator Baumgartner.
Both individuals have indicated a little bit of what I wanted to say. I hear often people talk about the guide. And I think part of it is normally the locations don't change of where they were. You may have a new person who takes over. But then in the Lawrence Journal World, there's a whole section that's printed every other day in the week of every department, who's there, who's doing what, who the new county commissioners are, who the city commissioners are, who the school board members are, who the legislators are. So as a result of that, you can get your update. But in terms of what's available and how you get there and your phone numbers or your emails or whatever stays the same. So from what I have heard, it is valuable, but you really should call to find out what they're really saying about it. But I don't hear anybody saying, well, I pitched this because it was whatever. I think we keep it because you don't have anything else. And this is one way that you know what's available, especially when you're trying to address concerns for people and you're trying to find out what it is. Thank you.
Senator Baumgartner.
Thank you, Madam Chair. My hand's been up for a little while, so I'm going to kind of take us back just a little bit real quickly. But with regard to the autism and the screening, and I think that was maybe number 18 or 19, could we get a little bit of update on just how behind we are on that screening? How many kids or families are still waiting for a child to be screened? And the reason I ask that is Pittsburgh State University Department of Psychology is going to start doing screening or has started doing screening in the Southeast Kansas region. And a part of that announcement was because of the backlog in the screening process. So do we have data on that?
So I will have to probably talk with KDHE to see if we can get information about the total number of screens that are provided for autism that we're aware of. There are obviously folks that might be getting screens for autism that are being provided outside of the Medicaid system as well, so we wouldn't have data on that.
Okay. I just think that as we talk about this, if we are not addressing what our current backlog is, we're not really addressing the needs of Kansas families. So next I'd like us to move to, and I believe this might have been either 19 or 20 when you were talking about the HCBSs. And as far as home services, where are we on addressing the issues for providing services and then foster parents not losing funding because home services are being provided? We have a set of foster parents, and I think it's right at about just under 36 kids that have some pretty major disabilities, and they are required to, the foster parents are required to provide pretty much round-the-clock services for those foster kids, and yet they are getting dinged as far as how they are compensated because of home services that are being provided. So has the right hand found a way to work with the left hand, meaning KDADS and DCF, so that we don't lose these foster families that are taking care of kids with some major disabilities?
Yeah, so I think part of what you're referring to is around the tier structure for reimbursement. Yeah, and again, I might just defer that question to Tanya. And I don't know if, Tanya, do you want to come up and try to address that now, or you want to?
I can, it's also on our spreadsheet.
So we've got it in two places, basically.
Well,
It's kind of,
Okay.
because it touches two agencies, that's our issue. So Senator, would you like to wait till Tanya does her presentation, or would you like her to come up and present now?
No, that's fine. I mean, we can wait. It's just, I think that there isn't, on that Venn diagram, it's not two circles on top of each other with regard to those of us that are members of child welfare as well as this committee. And the alternative, if we lose those foster parents because they are not receiving the supports that they need, is that these children would be hospitalized, which would be very expensive. And so I just want to make sure, again, we are talking about two agencies, but we only have one secretary, the same secretary overseeing both. I just want to make sure that the left and the right hands are working together to address the needs of this group of kids that are in foster care. Thank you, Madam Chair. I will wait to hear Tanya's presentation later.
Okay, so I think, staff, what we need to do is somehow notate that, because we're keeping 19, that it links to another one that's under DCF. Okay, which, yeah, I haven't gone that far because I'm doing good hand on one at a time here.
Right.
But that way it gives us that connection.
Yeah.
And Senator Baumgart, did you have something, Andy?
Well, I was just going to say, Senator Bob Carter, I do think that we are working together pretty well. Like I said, I meet on a regular basis with DCF about foster care children and behavioral health issues. We talk about waiver issues like the SED waiver and some of the other waivers as well. So I do feel like that both agencies' staff are working on this issue jointly. And I think Tanya will be able to provide a more detailed update.
I guess my only response would be what we are hearing as legislators. is that with regard to children that are in foster care that have perhaps the most extreme behavior issues. So now we're not talking about physical disabilities, but we are talking about behavior issues, tend to be the ones that are spending nights in contractor offices. So I think that I appreciate that KDADS and DCF are talking with each other. But that conversation and the frank reality hasn't been getting to the legislature. And that's something that we talked about at our last child welfare meeting. And one of the contractors, Cornerstones for Care, was pretty smug and dismissive about, well, we're taking kids across the state line. And it's fine to take them across the state line, but it doesn't mean that they're receiving services. It's just a group home as opposed to receiving necessary services. So I appreciate the conversation. It just needs to get to the legislature because in the end, we're the ones being blamed for things that do and don't happen. Thank you, Madam Chair.
Senator Baumgartner, while I have you on there, and you must have had to step away when we were going over item 13, if you can flip back to that. Huh? Oh, that was for KDHE, so I'm shifting gears. If you'll just pause with me, Handy. The question was whether you felt like we needed to keep that item on here and if there was any additional information you would like to have.
I'm sorry, I did have to step away.
No, that's fine. That happens.
I needed a restroom break, sorry.
TMI, Senator.
I had to fix my hair. There we go.
Okay, there we go.
I think my preference would be that it stay on there so that we continue to receive updates.
All right, that's what we'll do. We just wanted to, being you were part of that, being put on the list, so.
Thank you.
Huh? Number 13. Remember, we were going to circle back around to see what she wanted to do with it. Yeah, and then we'll make that notation on number 19 that links us back to the DCF piece. Okay. So back on 21, Andy, and staff, I haven't figured out wording. The printing seems unnecessary in my opinion. If we were to, I like the grant fund idea, that we make it a digital item. And again, it goes back to the communities. I like the local piece. That the committee, and I don't know how we get that to probably the social services budget committees in the House and the Senate to look at what it would take to fund that, how that grant process would work, have the ability to print sections. So it goes back to you talking about highlighting just a section for someone. You could print it off, highlight it, give it to them, or be able to print off the whole thing if someone feels like that they want to have that paper copy in their home. Is that something you can help us with then next year?
Yeah.
Okay. Do you need anything else from me, staff? We just got to make sure it gets to the budget committees. Senator Petty.
Madam Chair, when, you talked about you digitally and not in paper form, but of course, I like the grant funding process since I suggested it, but could it be an optional for the as part of the grant? They'll come up with the language, but it could be optional for them to decide whether how they want to use those funds, whether paper, digital, or a combination of both. Print, digital combination. Because I have people all the time ask for something in print.
Well, and I understand that, but I think it goes back to the discussion that we also had is how this information kind of changes on a regular basis. And if they want to print, currently, they can do that. But I think what the state should fund should be on a digital perspective. Then it's up to them whether they've got funds within their existing budgets to print. That's my opinion.
I know, we always disagree.
Well, I don't think always. There's probably
Sorry,
one out there.
wrong Rose, I occasionally.
Well, that's better than zero. So now is that as clear as mud now, staff, what we're requesting? Okay. Well, and Senator, this will all be worked out, so I'm not, saying that this is what it has to be. It'll be worked out with the legislative committees to hear from the stakeholders and everybody else, and then they can make that final decision.
Right, absolutely.
Okay. So we'll keep that on ours and then get an update on what happens during the next legislative session. 23.
Okay, so for 23, this is about the impact of Senate Bill 228 and House Bill 2184 on reimbursement. And so our update here is a little on the short side, but data on the amounts paid and the number of defendants waiting for admission to the Larned State Hospital are included in our agency presentation yesterday. I believe Scott went over those.
I think we need to monitor it, and when Representative Carpenter gets back, let's circle back with him and get his feedback on it. So for right now, we'll keep it. 24.
So for 24, is there a state solution regarding the REH eligibility and skilled nursing beds grandfathering and what can be done at the federal level? So just briefly, for our update, the rural emergency hospital is a federal designation. So to achieve the desired grandfathering, state law would need to be changed in order to allow the agency to waive physical environment requirements for a skilled nursing facility. And that would not change the federal requirements to be licensed as a skilled nursing facility.
Well, did we, because you've been in the room since we started, correct? So when we talked about this earlier,
Yep.
do you believe it's been addressed in the legislation that we passed this last year to be ready for the feds to come in on the grandfathering piece?
Let me check with Lacey.
Because my concern is when you talk about that the state law would need to allow the agency to waive physical environment requirements, and I don't know if that was any of our discussions when we worked on that legislation. I can't even tell you the bill number.
Okay, so it's a kind of a two-part answer. So for the critical access hospitals that are operating swing bed units, that's the piece that right now is not able for us to be grandfathered without change in statute. So our long-term care units are, as per the previous testimony.
And if you need to come up, that's fine. Did you follow that bill when we were working that? So was this not discussed during that process?
I don't know that it was necessarily discussed because then you're kind of crossing over agencies. So I think when the bill was discussed, the matter was brought before KDHE because they license both critical access and rural emergency. It wasn't necessarily brought before KDADS. We license adult care homes, nursing facilities, skilled nursing facilities. It's all in the same per our statutes. We certify on behalf of the Center for Medicare and Medicaid Services long-term care units for participation. We do not certify swing bed units for conditions of participation. That is done in critical access hospitals and in rural emergency hospitals. Both, I believe, it's done by the accrediting body. Yeah, Jerry's not here anymore.
Is anyone left from KDHE? Christine, would you mind carrying the message back? I think that's definitely something that needs to be addressed this next legislative session. I'm kind of sad we didn't catch it in that bill. Oh, Senator Baumgartner?
I'm here. I'm looking for the email that I received, but I was curious with regard to the hospitals, the critical care hospitals, as well as the rural emergency care hospitals. At any point in time, the state of Kansas does not require any type of survey to be done before that hospital goes into place. Is that correct?
And you can come back up if you want to, however you guys want to tag team.
Okay, so KDHE would be the agency that's responsible for this. But I mean, Lacey is telling me that she believes that the answer is no, that there's not a survey that's required prior to license.
So there's no type of needs survey or assessment of other services within the area that are being provided, correct?
No, Kansas is not currently a certificate of need state.
Okay. Is that certificate of needs, is that a federal requirement or that is just a state requirement?
I would have to take that one back. Since my kind of coming on with the state, we've never been one, so I'm not exactly sure if it's a state or a federal designation.
Madam Chair, I think that might be something that we do want to look at. I know that there is a very significant need for hospital services, particularly in our rural areas. But I also know that part of the problem that our rural areas have had is when multiple hospital organizations are trying to locate in a very close proximity with each other. I think several of us remember just in Independence, Kansas, so this would be several years ago, but we had two hospital systems right there in Independence. One did close. I know down in southeast Kansas, there is one hospital that's in Pittsburgh, and then the announcement of a new hospital going in Frontenac, which most folks don't understand when they're driving down 69 highway that they're in Frontenac or whether they're in Pittsburgh. But it was brought to my attention that most other states do require some type of a needs assessment so that existing facilities can remain staffed and there isn't that competition for staffing, and that the needs of the community are actually being met. Thank you, Madam Chair.
Discussing with Representative Ballard, because there's something, we're recalling certificate of need being brought up many, many years ago. In fact, Representative Neufeld was actually Chair and Social Services budget at the time, and I just don't remember why we made the decision that we made. Tara, do you mind coming up for just a moment? Okay, the first question I have for you is on the certificate of need. Do you have any input on that piece? If not, that's fine.
Yeah, this is Tara Mays, Kansas Hospital Association. We don't have any information necessarily. I do know that it is state regulated and it's pretty varied amongst the states that have looked at that piece of legislation across the country.
Okay. And then going back to the rural hospital piece, if you'll elaborate on that.
Sure.
Or the critical access, I should say.
Sure. When we talked about the bill last legislative session would allow hospitals that had previously closed to become a rural emergency hospital. We all envisioned at that time that the rural emergency hospital that would keep skilled nursing facility beds would be licensed by KDHE. When that did not happen, the licensure authority went to KDADS instead of KDHE, and KDADS has let our first rural emergency hospital that applied with skilled nursing facility beds know that they would have to meet current requirements as if they were a brand new facility. This committee heard from Mountain Ridge Hospital CEO just last time you met in August, and that would require about $3 million worth of upgrades for that rural emergency hospital. And so what we would ask this committee for is to consider a recommendation that we fix that in state statute to direct KDADS, like they do for so many other long-term care facilities, to seek a waiver so that the rural emergency hospital could keep those skilled nursing facility beds.
Would you like to respond on that? I'm sorry, Andy, I'm just directing your staff.
No, it's okay. But I do think that is what our report says, is that it would require a statute change.
Right.
Good.
So just to reiterate, the reason the statute would need to be changed is because while we do have regulatory authority and we do have exceptions for facilities who have been previously licensed as a nursing facility to come into compliance and be licensed again, in this situation, they had a swing bed unit in which they had the bed swung to the skilled nursing side. They were not operating a long-term care unit, nor were they certified as a long-term care unit. So our staff that does the survey and certification process on behalf of CMS has not gone in and surveyed that hospital for conditions of participation on behalf of CMS. As a critical access hospital with a swing bed unit, those surveys and certifications were done by the accrediting body.
Okay. Senator, yeah, it kind of is. Senator Fagg and then Senator Gossage.
Thank you, Madam Chairman. I think Tara covered it pretty well. Back in August, we had talked about this and made a recommendation. So that's something today I want to make sure we follow through. They have been working on a draft bill to take care of that. So this is kind of what's in the works. And a question that I would have, Andy, for you is if a rural emergency hospital can have a skilled nursing facility under their hospital license, or do they have to have a separate license as an adult care home? So I wonder if you could kind of elaborate on that a little bit.
I'll probably ask Lacey to come back up and answer that one.
Okay.
I think I can get you part of the way there, but I would also have to verify with KDHE, but they would be allowed, or KDHE can, I believe, provides a separate and distinct designation and have a licensure path. It is not preferable because in many cases, I don't think KDHE does the skilled nursing facility realm. That is mostly KDADS. You have that little example I just gave you there, where we have an operator who was operating as a skilled nursing facility in their mind and in what they were doing. However, they weren't certified that way or surveyed that way, so there's kind of a gap. I think that if rural emergency hospitals want to become adult care homes, we can look into having that statutory change made that allows for swing bed units to be grandfathered in and allowed to become an adult care home and operate as a skilled nursing facility.
Madam Chairman. So when we get ready for recommendations, I got some stuff on that. So they've been working on this, so.
Well, and I think we just, at this time here, will flag staff to make sure that we do that as part of our recommendations, is to, it sounds like we're going to be asking for legislation. Okay. I had Beverly before you, is that, okay. Senator Gossage.
Madam Chair, you just said what I was going to recommend.
Representative Carpenter.
Just so we can get further off track here, and I agree with talking with Senator Baumgart, but we run into that in El Dorado trying to become a critical access hospital, and in the old days, 30 miles was a long time, a long ways. Well, El Dorado can't become a critical access hospital because they're less than 30 miles from 2 other critical access hospitals. And so, but that's a federal deal. So that's all I want to say about that. We don't have authority, but we've been working with our congressional folks, and we still haven't gotten any resolution whatsoever to the fact that they can't become a critical access hospital. And they're not interested in becoming a rural emergency hospital too. So just to be farther off track, I'll just inject that.
Did we have anyone else that comments on? Representative Concanon.
Thank you, Madam Chair. I'm toying with this question in my mind. I'm not sure whether it's for Tara or Lacey. It's probably not for you, Andy.
That's okay.
So it's my understanding that our critical access hospital that we have in the town that I live in, that we have, that it's, the swing beds are not a separate unit. They're the hospital has 25 beds, and when the person that's in acute stay has, when it's time that they are ready to be dismissed, but they're not quite ready to go back to the nursing home or home, then they decide that they're going to swing them, and that becomes a swing bed. So I'm really struggling with this whole idea of licensure and certification when this is all the same hospital beds. It's just a separate designation on their chart. So can I have Tara answer that? I mean, yeah, this whole conversation is not making any sense to me.
Madam Chair, Tara Mays with the Kansas Hospital Association. Appreciate the question. In many hospitals, you wouldn't know the difference between a swing bed. This particular instance, that is not the case. There is a separate wing for the swing bed facility because
Are you talking about the one at Mound Ridge?
The one at Mound Ridge
Okay.
that you all heard about in August is a little bit different. So they were able to have CMS come in and do their approval of their REH with the swing beds as a separate unit. Now we're just trying to solve the secondary problem, which is the complex licensure piece that we now need to have with KDADs that originally they thought would be with KDHE. So that's why we need the statutory change, just because we assumed it would be with KDHE. Now that it's with KDADs, we need to go back and change the statute.
Okay, so this is just the impact on those that have a separate, no? It impacts all of our swing
It will,
beds.
any hospital that would consider a conversion to a rural emergency hospital that wants to keep their skilled nursing facility beds, this will impact them in the future as well.
Okay, all right, thank you. That helps, thanks.
Further comments, questions, committee? Staff? I think this is another one of those items because I think we're going to, if I understand the note was given me that, is there another item that this gets attached to? Or it's still by itself? Okay, so Senator Fagg addressed it. Um, So we just need to put on there, or to that, we need to have legislation drafted. Okay, let's make sure we tie those two together, and then we're not discussing them separate. We're talking about item 8 that was under KDHE, so now we bring them together. And then the recommendation for legislation to be drafted.
So the issue is you just can't decide to just do what you want to do. You have to fall within compliance.
Right, well, no, we know what we want to do and what needs to be done. And it sounds like to me the agencies and the hospital association are in agreement. Correct me if I'm wrong.
Yep.
Tara, I can't see you. We're in agreement of what needs to be done. We just got to figure out what that language is for the hospitals with KDADs and get it introduced. Yeah.
Okay, I just need a verification on that, because it sounds like you just can't decide that you're going to do this and just do it on
No.
your own because it's convenient and the bed was available and the person was in your hospital. You're going to have to comply with what's really happening, or everybody else could be switching around and doing anything they really wanted to do. Okay, gotcha.
That was clear as mud, wasn't it, Andy?
We're statutorily limited from being able to do it right now.
Yeah. Senator Fagg.
One thing that I would like to reiterate what Tara had said, in the Mountain Ridge case, you're talking $3 million. That shows you what kind of impact that can have on rural Kansas and what that can do to your hospital. So I think they're, Representative Ballard kind of working on that kind of stuff about how many days, how long, the details of that. So the details are being worked out.
All right. That's it? What? Oh, yes. What was Carpenter's piece? What number was that? I know. Yeah, I didn't mark it down here. I got distracted. Okay, we were going to circle back around to number 23, and unless there's objections from the committee, Representative Carpenter says it can be dropped. All right. Thank you very much, Andy. We appreciate it.
Yep. Happy to be here.
Are you hanging around so we can abuse you some more?
I'm planning on being here as long as you don't ask me about MCO contracts.
I would have said no.
Okay. Next, we have on our list Cheryl Semmel, Director of Government Relations, Office of Special Counsel, Judicial Branch. Welcome. I'm only used to seeing you in Education Committee.
I know. I had to show up and at least make one appearance before you left. I mean, but Representative Landwehr, Senator DeGrasich, thank you for the opportunity to be here this morning. My name is Cheryl Semmel. I'm here on behalf of the Office of Special Counsel for the Chief Justice for the Kansas Supreme Court. We have one item on your spreadsheet, and we also provided written testimony to provide a little more detail and status on the implementation of the Family Treatment Court Pilot Program. So just a real quick reminder, the Family Treatment Court Model Program is a family-centered collaborative approach. The whole idea is to work with those families with substance abuse disorders who are involved with the child welfare system. The Family Treatment Courts, not unlike some of the other specialty courts, involve multidisciplinary teams to address some of the concerns and issues that the families are facing. Parents voluntarily enter into the program and they agree to increased interaction with the court, with chemical dependency treatment and intense case management programs with the whole idea of reunifying with children. In September, we are pleased to say that the 3 pilot programs that we were hoping to stand up were put into place. Those were in Miami, Lyon, and Cowley County. Within the first 3 weeks of those programs being in place, there were 9 families that had already been referred, and those courts were engaging with those families and getting things underway. I do not have an update for how many additional families have been added. Based on the current resources, though, we are anticipating that we can serve up to 40 unduplicated individuals. And I'm just going to stop here because I realize definitions are important. So we talk about families because the whole goal is to work with the family in its entirety to address the needs and concerns. For purposes of federal funding, they require we use an unduplicated count number so that you'll sometimes see those 2 different terms. Obviously, family sizes vary. So you'll hear me talk about families a lot when we talk about the number of families that we're interacting with, but you'll see the other number for funding purposes. Quick background, this past summer, we worked extensively with Children and Family Futures. It's a nonprofit organization that provides some technical assistance and helps with the strategic planning process. During that process, we identified 3 primary goals for the Family Treatment Court Program. Those goals are outlined in the testimony, but I'll cover them real quickly. One was to improve access to coordinated substance abuse disorder treatment and support services. The second was to enhance the capacity of the family treatment court model so that we could effectively address the needs of families. And 3, to improve the well-being of families and children that have been removed due to substance abuse disorders and those related issues. I will tell you that there is a very comprehensive document that provides objectives for each of those goals. And those objectives will be evaluated and assessed as these programs move forward. Our hope is that we can make adjustments as necessary to meet the needs of those families and those children in the system most effectively. We have worked with KDADs throughout this process. There was $1.5 million included in their budget to assist with providing treatment to FTC participants. The judicial branch has submitted 3 applications for grant funding for each of the treatment courts. We are still awaiting feedback on whether or not those grants have been awarded, and we'd certainly be happy to provide feedback and follow up should they be. But I'd be happy to answer any questions at the appropriate time.
Committee, it looks like the testimony she's referring to is number, I just had it, 45. Questions, comments? I guess what I'd like to see is that we keep this item on here and then look for future reports and data of showing what the successes, results are, what the benefits are. Because I know that there's a lot of that out there with all the different specialty courts we have across the state. So that would be another one for us to monitor. Okay, any other questions? All right, seeing none, thank you very much, Cheryl, appreciate it. Next, I have Tanya Keys, Deputy Secretary, Department for Children and Families. Welcome.
Thank you, Madam Chair and Committee. I'm Tanya Keys with Department for Children and Families in the role of Deputy Secretary. We have 2 items on the spreadsheet. I believe we'll start with what is number 4. Number 4 is a follow-up for a status regarding the Unitas contract that DCF administers. It is a SPARK grantee. You heard from Natalie yesterday afternoon with a lot of information. With regard to a DCF update, I just want to remind folks the total award was for $7.7 million. And I'm reading from our response here for the quarter ending September 30th, so more recent information. Actual expenditures through that quarter ending were about $1.9 million. So with that, in terms of the utilization, because we are covering the cost of the license, the user license correct? So with how they're doing the pace of their licenses, we would estimate the commitment through the grant end date will end in September of 26 would be 5.4 million in terms of expenditures for those user licenses. And you also heard, I'm so sorry, it sounds very loud here. And you heard yesterday about 800 license. Our data shows that the total licenses through September 30th was 829, which, as you heard yesterday, exceeds their goal of getting 700 out there. That you also contained in our information is details about who some of those organizations are, who have the licenses. We provided you a list of all the organizations that have the license, and I know you also heard that yesterday from Natalie. I'm happy to answer any questions with regard to an update on Unitas.
Senator Gossage.
Thank you. I'm a bit confused about, because we understood that this was going to be Spark funds, not state funds. So are these Spark funds that are a pass-through through the state? So
Yes.
these are not general funds that are the 5.4 million, is that right?
Yes, thank you for the question and opportunity to clarify. Yes, the Department for Children and Families is the state agency that issued the RFP for these funds. So we were an administrative support to be able to facilitate the Spark funds being dispersed. So our function is the administrator of a portion of Spark funds in the categories that the Spark committee set forth. But yes, these are federal funds.
Thank you.
Senator Petty and then Representative Carpenter.
Tanya, thanks a lot. Who is, and the Wyandotte County one, you said Wyandotte County, the first ones. Who is the Wyandotte County one connected with?
Let me glance at the list here. Cowley County. I see Lansing's in Leavenworth, so that does not count. Turner School District. I'm glancing here very quickly. I don't see something unique to Wyandotte County, but I can look at this.
School district is in Wyandotte County.
Yes, that's, I mean, in just reading the list, that's the only thing that I recognize is in Wyandotte. I don't know all the names, so I don't know all of their locations. I apologize.
If you have a chance and you could send that to me, I appreciate it.
Yes.
Thank you.
Representative Carpenter.
Thank you, Madam Chair. So I look here, it does say that it went through an RFP process,
Yes.
and so there were other bidders.
There were other bidders, and I believe in your materials from yesterday, the Department for Children and Families provided a list of all the bidders, and it had an explanation of the bid process.
I'm not sure the Department of Children and Families testified yesterday, but it may have been in our information. What's that? 7B, okay. And I remember Unitas did, but I didn't realize that it went through an RFP process through this. It sparks money, I know that. I didn't know it went through an RFP process. Thank you.
Committee, further questions or comments? We're on 4. Yeah, number 4. I say that we keep that and continue monitoring. Number 5.
Number 5, thank you. Number 5, as I understand it, was a question about who determines the levels of care and rates for children with high needs. The question was received. We have, as mentioned earlier, when Deputy Secretary Brown was here, did provide testimony to the Child Welfare System Oversight. And I'm sorry, am I on the wrong number? We're okay?
Yeah, I'm sorry, that's not, I'm crossing departments.
Okay, so I apologize. It appears to be number 6. It is not number 5. I apologize.
No, that's not your fault. We're good. Senator
So-
Baumgartner, did you have any comments on 6? Go ahead, Tanya.
Okay. In general, children who are in the custody of the secretary and in foster care, we do have a structured rate system that's based on the needs of the child. The case manager for the child determines that level of need. That's generally for all children in the custody of the secretary who are in out-of-home placement foster care. This question is really asking about those with high medical needs. And of those with high medical needs, sometimes they might be on the technology assistance waiver. Right now, there are 30 children in the custody of the secretary in foster care on that waiver. There are about 29 children who are on the IDD waiver. And then we have children who are not on the waiver. However, they're on a wait list for the waiver. So of children who are high needs, there are some who are more specifically associated with either active on a waiver or they're on a wait list for a waiver, if that makes sense. And I think this is what this question might be referencing. So that's how I'll proceed to answer the question. So children who are active on the waiver are receiving a set of services based on the Community Developmental Disability Organization, the CDDO. In addition to those services and supports through the CDDO, the Department for Children and Families does have a daily rate of care that's provided to their relative or their foster home provider. So where they're living, it is again based on their need. We have a series of rates. We know that for children with high medical needs, so for example, the technology assistance waiver, those are the highest physical needs that we would have, medical health needs. Most of them are at a rate that is at the level of intensive 1 or intensive 2, which is either $78 a day or $94 a day. So that's the rate that they receive. We have an opportunity to add on additional supports or services and cover the costs. It's our intention that a foster parent or a relative not have any out-of-pocket expenses. So we do have ways, if that rate isn't covering an extraordinary need or a difficulty or a complexity of care need that's not met otherwise, we do have flexibility to be able to do that. I think part of the question was who determines that. It is the case management provider. We do have providers who might contact us through customer service or maybe just email me or you or others and say, hey, I need help. I don't understand what's happening. I don't feel that the rate that I'm receiving really is able to meet the needs of the child. When we receive those, we work through them one by one. And as Senator Baumgartner mentioned, we have had some contacts recently about that. So that's for children who are active on a waiver. If they're not on a waiver, but they're on a wait list for a waiver, we have another set of rates called IDD tier rates that are available. But it's the same principle. It's based on their level of need. They do have an instrument that is used currently it's called the basis. And I think it's going to become soon, they won't use that basis instrument anymore. They'll use the Medicaid functional eligibility instrument in the future for consistency to identify the level of need. Once that level of need is identified, then that reimbursement to the foster home is implemented. So that's generally how it works.
Representative Concanon.
Thank you, Madam Chair. So thanks for the explanation, Tanya. I'm a little bit confused on some of it. So when we talked about this at the Child Welfare Oversight Committee a month or two ago, we still have very medically needy people on the, which waiver am I trying to say? TA waiver?
Yes, possibly, yes.
Yeah, so they're being judged by the tool that you were talking about that's for IDD. They do not meet any of the IDD criteria, so they're being paid the lowest amount, which is $25 a day. And they would qualify for much, much higher, and until last June, they did qualify for a significantly higher rate until that something was changed in the tier rates. So it had, since we've met last, is there a change coming because of that, or what am I missing?
Well, a couple of pieces. So with regard to the 30 children who are on the technology assistance waiver, the case manager can choose a level of care. They don't need, based on the needs of the child, they may not choose what we would call basic level 1, which is about $25 that you referenced. They can choose another tier. So most in that category that we know are on the waiver are receiving the rates of either intensive 1 or intensive 2, which is intensive 1 is a rate of $78 a day, and intensive 2 is a rate of $94 a day. You know, certainly I don't know each child and haven't looked at each child's, but the idea is that it's not automatically basic 1. They can choose which level is appropriate.
So the case manager, who is not a medical person and is using this tool, is making a decision on this family. We've already lost 3 foster homes because of this change that I know of. I'm sure that there's more. And this foster mom that I've talked to is ready to quit because this child doesn't have half of a spine. I mean, there are so many medical problems, and this foster home's been wonderful. They're working miracles, but she spent $2,000 of her own money because the MCO wouldn't pay for a medical bed or a hospital bed for her. And she's needing the oxygen. What am I trying to say? Oximeter, and there's another piece of equipment. They need a different size wheelchair, but the MCO will only pay for a new wheelchair every 5 years. Well, this little baby has grown and needs a new wheelchair. And there's just significant problems going on there, and a case manager is out there making these decisions. And I mean, there may be fixes in the work, but they need to be reimbursed back to June, whenever the change was made. And we need to, we've had some time here, we need to have something happen. And here's the other thing. I hear from the administration, from the agency, that the KVC or whoever, I think it's KVC in this case, is making that decision. And then, you know, there's another issue with not being able to hire anybody to work in the home. And so the parents are doing that, then they're not being paid that by the MCO. And there's just all of this between the three, between the agency, the MCO, and the private contractor. There's a lot of finger pointing, and we're not getting anything solved.
Yeah, and thank you for that. And we hear you, and I think we've been talking with some of these families. If not, I hope we are, or have an opportunity.
In fact, she was told that she would be called, and has not, as of yesterday, has not received a phone call.
Okay, I'm happy to follow up. I can get with you on that.
Okay.
To talk about what we're doing in the future. We've been working with the Disability Rights Center, the Kansas Council on Developmental Disabilities, KDADS, and DCF, and others to be able to, one, I hope, simplify the rate structure, make sure that it meets all of the needs. Again, we don't want any out-of-pocket expenses. Certainly advocacy with managed care organizations for circumstances that should be covering that isn't covered. That's a bit of a different piece, but with regard to the DCF rate, we know for these with the highest physical health medical needs, we really want to simplify it. We want to have a system that covers the cost so there's no out-of-pocket expenses, and we are working to establish and adjust the current rate structure that we have, and also identify a tool that can be used for consistency across the state and support for case managers and perhaps even their supervisors who may have questions about the tools and how to go about the process.
And Madam Chair, I would just like to recommend that you take a look at that process of having a caseworker making those decisions, someone who's trained in social work. And I completely respect what they do, but they're not medical people who are making some of these decisions on very medically needy children. So,
thank you.
Thank you. Thank you, Madam Chair.
Representative Concanon, is there something that you would like to, because we'll keep the item on here, is there something that you would like to see put on here to carry forward?
Everything I just...
Staff? When I asked her what she wanted on there, she said everything she just said. So if you can kind of, no.
Yeah, well, yeah, there's just so much to this. I think if we just keep this on there to continue the discussion, and we're also talking about it in another committee, so I actually don't have the mental capacity to put something together right now, but.
Can you summarize kind of what she said and figure out how to? Okay, they've got you. That's why we have this great staff. They have to give my verbiage as well. Okay, Senator Baumgartner, did you have anything to add?
She's fixing her hair.
Yeah, she's fixing her hair again. Representative Ballard.
Thank you. I want to follow up on a question I had asked Mr. Brown about foster parents. Where do we stand in terms of having enough? Because I know we've had a shortage.
We'll never have enough.
Thank you, Chair and Representative Ballard. So right now we have just over almost 2,300 family foster homes across the state. Again, we always want to build capacity for family foster homes. Legislative post-audit in March of 2022 did an evaluation of the impact in every county. So what we know is generally, the majority of counties in Kansas have enough family foster homes in their county or in their community based on the need for foster care in their community. But not all counties have the same capacity. So there are counties, about 40% of the counties, and a lot of them were in western Kansas and north central, about 10 or 15 counties that at that time, for their need for foster care, didn't have enough family foster homes. And the method to look at is, the number of children in need of foster care in that county. And then you think about our goal is 50% of children or more be placed with a relative or kin. So the need in that county is adjusted for licensed family foster homes because we're hoping half of children in care are living with a relative. Right now we have just over 5,700 children in care, and again, almost 2,300 family foster homes, but not every county has the same capacity.
One of the big concerns was the number, but the other thing in terms of the training and how do we select foster parents? Because I mean, you'll get a letter and somebody will say this person shouldn't have ever been a foster parent. I mean, it's terrible. Or they hear about they're not treating the children well, or they're not doing this, or they're not doing that. And then you'll hear about these other people that are spending their additional money, their personal money, trying to make sure that these children are receiving the care they need. I guess the question that was asked me, and I'm going to ask you, do we relax our rules because we need to have some foster parents there so we are not being accused of putting children in offices? Are we not getting the best people, or are we just taking whoever we can get to meet the number of kids?
Yeah, there's a number of child placing agencies who work to sponsor, support, recruit, and retrain individuals and families who want to become licensed as a family foster home and be in that role, and that their heart and their home are open to that. There's rigorous training. There's an assessment that occurs for that family, home visits, conversations. There's basic training in terms of MAP and tips. There's additional training after they've been a foster parent for a bit. For example, if they wish to be more involved or serve older youth, their Children's Alliance of Kansas and their members do a great job of creating curriculums to be able to support different levels of care, different specialties, perhaps even courses that help understand mental health needs, behavioral health needs. Certainly there are regulatory requirements with regard to background checks, first aid, CPR, other items. So there is a process that occurs over a number of weeks for someone to become licensed. Those folks who are willing to go through that, ask questions to make sure it's the right fit for them, the right timing in their life for that, if they want to serve in that way. There are also supports in a similar way for relatives who want to be a care provider for someone in their family who's experiencing foster care. I don't know how to answer the question about, are there folks out there who are becoming foster parents who may not want to become foster parents. We really want to support relatives and foster parents to provide the best care for their family member or someone in their community if they're a kin, or any child that they want to be a foster parent for. And we believe that they reach out to those sponsoring agencies because that's what they want to do. They want to be a resource in their community.
Tanya, thank you very much. I appreciate that. It's a question that is very difficult to answer when people are wanting to know and they have specific things that they want to talk about. But it seems to me that there is a protocol, there is a process, and you don't just take anybody.
Sure. And in fact, the protocol, there are a number of hours that need to be reached for initial training. There's ongoing training requirements and ongoing hours, ongoing support from child placing agencies. They have their own peer network as well for support. So yes, there's rigor and routine and support and services to anyone who wants to be a caregiver.
And I appreciate your answer very much. Thank you.
Senator Gossage.
Thank you, Tanya. Just a quick question for you. Yesterday we were given lots of information kind of at the beginning of committee that were responses by the different departments. And I had an opportunity to look at some of those. And one, I see that one rather alarming statistic is that we had, in 2019, 95 unaccompanied minors in the state of Kansas went to the system, but in 2022 it peaked at 807, went down a little bit, 755. Has your department looked into why this number is so exponentially grown?
The Department of Children and Families was able to provide the committee information from the office, from federal office of the Office of Refugees, ORR. That's not a program that we administer. Those persons who sponsor those who are asylees is through the Office of Refugee Resettlement, which is a federal agency.
So in Kansas, what you're saying is that we're having like 7 times as many resettlements that have children that are unaccompanied. here in Kansas?
I don't know that I can answer that. I know that we provided information from Health and Human Services, their public information on their website. I could get back to you to see who on our team would have an understanding of what these numbers are, but it is not a program administered by our agency. It is a program administered through federal agencies and their organizations that they sponsor that supports that program. So I don't have a lot of detail on it.
If you could find out more detail, that would be very helpful. Thank you so much, Tanya.
Further comments, questions? So staff, do we have an idea of what we're needing to add to this one? Okay. Go ahead, Senator Gossage.
Tanya, just wanted to verify, but it's through a federal program. They identify these unaccompanied children, but then they are put into the DCF system, correct, here in Kansas?
No, they are not put into the custody of the Secretary for the Department of Children and Families. The Office of Refugee Resettlement has their own program with their own sponsors that help them care for day-to-day those children.
Okay, thank you.
All right, thank you very much, Tanya. That concludes you, correct? Or do you have an, okay. Committee, we're going to go back to number 5, which was actually a D of A, and I noticed that that's a written only from Pat Doran, and that was a request by Senator Petty, and I just visited with her, and we can take that one off the list unless there's objection. Okay. Yeah, I'm thinking that. Okay, being we're running behind, and that's what happens when we get into this spreadsheet. Is there anyone that is here to either, it's whether it's on the spreadsheet or you've got other testimony on our agenda today that cannot come back and join us in about 30 minutes? Okay, so what we're going to do, committee, is we're going to recess for 30 minutes. It's a working lunch for us, so we'll grab our lunch, and I call it working. It's eat, and let's get back to business as soon as we can. So, so your lunch is out here, and we'll take and reconvene in about 30, 35 minutes. Thank you. Patient with our schedule. Sometimes we get pretty much in the weeds on some of this stuff, so.
Not a problem.
Welcome to committee.
Thank you. And good afternoon, Madam Chair and committee members. I appreciate the opportunity to be here. And I'm addressing both questions 1 and 2 for the MCO questions portion. I'm Chris Bierman, Director of Community Development with Aetna Better Health of Kansas. And I hope that Angelica Hughes is online because she is going to help me answer question 1 with regard to Medicare Advantage for D-SNP.
Angelica, are you with us?
I am here. Can you hear me?
We can. Welcome to committee.
Perfect. Thank you.
Okay.
And then I'll answer question 2 once Angelica's done.
Thank you. Good afternoon, Madam Chair and committee members. I'm Angelique Hughes, Chief Duals Officer and Executive Director for Aetna's Dual Eligible Special Needs Plan across our Mid-America and West territories. I'm here to speak to item 1, which is an explanation of Aetna's supplemental benefits for our current dual eligible special needs plan. So that would be current contract year 2024. And it looks like, there it is. Okay, so you have a screenshot of the benefits that we currently offer.
Susan.
So for our, let me back up.
Yeah, this one.
Yes.
Yeah, but I think their chart is on page 13. So if you look at what she's got up there on the screen, just flip over a page.
Oh, I know.
Or back a page, one of those. Right. Okay. Did you ask me a question? Did she ask me a question? No? Are we ready to proceed?
We can proceed?
Yes.
Perfect. Okay. As you'll see on this chart, we offer supplemental benefits to our D-SNP members. Now, on line 3, it's showing 3 different plans. It's the CMS H contract number, H5325. You'll see a -001, 002, and 009. So essentially, Aetna offers 3 different D-SNP options to Kansans, and the options are available based upon the county where an individual resides. So that's why you'll see through columns B through D 3 different plans. However, the benefits across the plans are consistent, but there can be some variation in dollar allowance amounts for members. So the first benefit that we show here is showing the extra benefits card. So we do offer, it's actually a credit card for members that they can use. They can pay for healthy foods at a approved grocery store, for example, over the counter, so non-prescription drug items. They can use that for transportation, such as Uber, such as Lyft. They can use that for utilities, so to pay their electric bill, their water bill, their trash bill at their home. They can use that for personal care items, pet supplies, rent, or mortgage assistance. So you'll see across our 3 plans that benefit is available, and the amount is $250 per month. And the member has the flexibility to choose how they want to spend that dollar amount. The next item is non-emergency medical transportation. We do use the vendor access to care, and transportation is provided in each of our plans. You'll notice under the first 2 plans, members get 50 one-way rides. Under the 3rd plan, they get 40 one-way rides. Next, meals are provided. Now, these are post-discharge meals. So these are meals that members can take advantage of after an inpatient hospital stay or after discharge from a skilled nursing facility. And we do consistently across the board provide members with up to 42 meals over a 21-day period. Now, what we want to highlight, because there can be some variation among Aetna and competitors who might offer similar benefit, is that for our meal benefit, it's per incident. So if a member, for example, had an inpatient hospitalization 10 times throughout the year, that member could take advantage of those 42 meals 10 times a year. So having those 420 meals as opposed to just being restricted to that one-time 42 meal allotment. We also offer a fitness benefit. We partner with Silver Sneakers, so members can go to approved gym locations. And they also have the flexibility. Silver Sneakers does offer different online options, so members can exercise and participate in healthy fitness activities from the comfort of their home if they prefer. We also have a dental benefit. Our dental benefit is very rich. Our current benefit covers almost everything except for teeth whitening and missed appointments. So our members this year who need implants, who need dentures, who need a myriad of preventative and comprehensive services are covered for that dental allowance. We also offer vision as a supplemental benefit. So this will cover an eye exam, and then it will also provide coverage for prescription eyewear that a member may need. And they can access our iMed network to get the eyewear that's needed. We also offer a hearing benefit. So this provides our members with one routine hearing exam every year. And then also they have a benefit of $2,500 per year each year for actual hearing aids. And they're able to access our nation's benefit network to get those hearing aids. We also offer telehealth as a benefit. In addition, we offer diabetes screening and prevention. We also offer diabetes self-management training services and supplies. We also offer podiatry visits. So this is in addition to the benefit that Medicare would cover for the members. We add an additional 12 visits per year for the member for podiatry, for routine podiatry services. We also offer smoking and tobacco cessation benefit, and this affords unlimited individual and group sessions for counseling sessions and support. We also offer a fall prevention benefit, and there is an allowance of $150. So this will help members if they need approved home and safety devices in their home, such as a grab bar in their shower, for example. And we also have a personal emergency response system, and we do partner with LifeStation for that benefit. And there's different options. Members can have a device on their actual home phone if they have a landline. They can also wear a gadget around their neck, for example. So there's different options. So if they need help, they can choose the option most convenient to them to push a button and help will come. And the last benefit that we wanted to share today is acupuncture. Each of our plans affords 12 visits each year to our members for acupuncture services. And these are all of the supplemental benefits that we wanted to share with you today. Are there any questions?
Committee questions, and I might provide a caveat here, keeping in mind that none of these will be available because Aetna's not an MCO anymore. And the plans all change next year. So a lot of these benefits that you're seeing here may not be there because the Inflation Reduction Act cut a lot of these out. And that's even for the commercial side of Medicare Advantage plans. So these look all great and wonderful, but consider it at least cut in half of what you see on here. So are there questions or comments for Senator Gossage? Angelica.
Angelica, Representative Landwehr brought up the question that was my question of two. One is, because of that act, we know that there are being some cutbacks on the benefits. So for your D-SNPs in other states, will there be cutbacks for next year?
Yes, we, as she mentioned, there were some cuts that had to be made. So I don't know if I could even say that any of our plans was untouched. Yes, we did have to make some reductions across the board for our D-SNPs in other states.
Well, there was $754 million cut out of Medicare Advantage plans this year. The other question I had is, are your hearing aids still through the True Hearing program?
Ours are through Nation's Benefits.
Nation's Benefit. Okay.
Correct.
Thank you. Thank you,
You're
Madam Chair.
welcome.
Further questions or comments, committee? All right, seeing none, thank you.
Thank you.
Thank you, Angelica. And I'm going to answer question 2 for Aetna. What is the count of Spanish-speaking users through your interpretive services?
Give us just a minute. We got to find this on our
Sorry.
sheets.
Problem.
Ah, there we go. Page 12, folks. And it'll be item number 2. All right, go ahead, Chris.
No problem. Thank you. So this is for 2024, starting January 1st through the end of August 31st. We had 3,419 individuals call into our interpretive services or utilized interpretive services by phone with a monthly average of 427. In-office visits for our interpretive services were 56, a monthly average of 7. And that's what I had to present, if I could answer any questions.
Comments, questions? Representative Reese?
No, that's exactly what I was asking for.
Okay, anyone else? And then you're responding for the other MCOs as no? They're
No,
each responding to
just
themselves?
me.
Okay.
Just that.
All right, thank you very much, Chris.
Thank you.
Appreciate it. Next we have, is it Sarah Kurgan? Sunflower, welcome. Did I pronounce that correctly? All right.
Thank you, Madam Chair and Committee. Sarah Kurgan. I am Senior Director of Operations with Sunflower Health Plan, and I will be responding to question 1 for the issues log, and then I also have Maria Salas, who is our Director of Health Equity with Sunflower, and she will be responding to question number 2. So question number 1 for Sunflower was in relation to the D-SNP benefits, and I actually provided information for plan year 2025, which my impression was that was what the question was pertaining to, was for 2025 benefits.
Yes.
Okay. And I also inserted the benefits into my presentation, so if you saw that information already, it's also reflected there. And so you'll see a lot of these benefits are very comparable to what you just heard from our Aetna counterparts. And these benefits are the supplemental benefits that we offer that truly go above and beyond what is offered with original Medicare. And so what I first want to call out is the WellCare Spendables card. This is a card that you may recall I presented on at the last committee. And this card is a flexible card that allows members to utilize this benefit to pay for items like utilities. They can access healthy foods. They can also pay for gas at the pump. There's lots of different ways that members can utilize this benefit. And this benefit ranges anywhere from $90 up to $167 per month, depending on the D-SNP plan that member member is enrolled in. We have 3 different D-SNP plans that are in the state of Kansas for our Sunflower Health Plan product, and you'll see those 3 represented there on the screen. I also wanted to call out for this particular benefit, if the individuals do not utilize those dollars within a given month, it does roll over. So if they want to use it for rent or utilities and have that roll over, they can maximize those funds. If they want to use it for a quarter or save it up and spend it at the end of the year. The next benefit I want to call out is our non-emergency medical benefit. And so this ranges for 2 different plans. We have 12 one-way trips members can access. Our next benefit is the post-acute meals. And this is the same benefit for each of the 3 D-SNP plans. And that is 14 days of meals or up to 3 meals per day for a total of 42 meals for the total occurrence. So members can access this benefit each time that they discharge from a hospital stay. The next benefit is our fitness benefit. So this benefit could be accessing gym services. It could also be a fitness kit that is mailed to the members in their home. They can also access a fitness tracker and videos and fitness programs. This is administered through our Silver Sneakers program. The next benefit I want to highlight is our dental program. We have a couple of different dental plans here. So for 2 of our D-SNP plans, we have what is referred to as a gold plan. This provides both preventative as well as comprehensive dental. And the dollar amount ranges anywhere from $3,000 to $5,000. And then in the center, you'll see we have a platinum plan. So for this, it also provides the preventative as well as comprehensive dental. And then for this particular plan, individuals can access dentures as well as implants. There is no max benefit for this particular platinum plan. Our next benefit is vision. This ranges anywhere from $400 up to $600 for individuals to access eyewear. We also provide hearing aids, and this ranges from $500, up to $1,000 every year. The next benefit is telehealth. This is included for all of our plans. We also provide diabetes screening. This is up to 2 exams per year. We also have diabetes self-management. This includes training, services, and supplies. If I recall from the last committee meeting, there was a question around the type of supplies. So we provide the one-touch monitor. That is our preferred supplies there. Any questions for me in relation to our 2025 benefits?
Representative Reese.
Thank you so much for all the information. How does one choose, or how do you know which plan you end up in?
Yeah, so it depends on what type of coverage the individual has, which is a part of the presentation I'll be sharing later on, as far as if they have full or partial coverage for their D-SNP eligibility.
Okay. And I have more questions, Madam Chair.
I want to tag on just to the answer she just gave you on that. Can you give us a brief definition of what that means, full or partial?
Yeah, so as part of our contract that we enter into with KDHE, we establish within our 3 D-SNP plans that we have, whether they would fit within the full benefit dual eligibility category or partial, which would be a qualified Medicare beneficiary or and I don't know if we want to go to that part of the presentation now, if that's easier, or do you want to hold to have that visual?
Yeah, we can do it later. That's fine. Go ahead, Representative Reese.
Okay, thank you. On the non-emergency medical transportation, is that like going to a doctor's visit, right? Okay.
Yep.
And so it's 12 one way?
12 one way.
Okay. Most people are going to need to go both ways, home,
Right.
doctor, home, right?
Right. And once they exhaust that benefit, then it rolls over to the Medicaid benefit, which is unlimited.
Oh, okay.
Yep. And
That's helpful because it's really only 6 round trips.
Right.
Right, okay.
And then for our Medicaid enrollees that are with Sunflower Health Plan, we also, for plan year 2025, are offering an enhanced transportation benefit that allows them to access additional services outside of medical transportation. So that could be things like going to the grocery store, bank, different places in the community.
One more question, Madam. On the spendables, I forgot to ask you this. Are they limited to, like, the healthy foods? Is it only a certain type of food that they can use that on?
Correct.
Is it on fresh fruits, vegetables, or?
We have, thank you for that question. We have a catalog that outlines the list of healthy foods that are qualifying foods. So when that individual goes to make that purchase, it would actually reject those foods. They could pay for those separately out of pocket if it doesn't, if it's not included in the list of healthy food items.
And the over-the-counter benefits, that's for over-the-counter medications like aspirin and things like
Yep.
that.
And they can purchase those at a brick and mortar location or through a catalog online.
Oh, okay, so they can't go to Walgreens or?
They can go purchase those at a store, at a location. That's a preferred location.
All right, thank you.
One of the things to keep in mind, Representative Reese, and the reason we're putting such an emphasis on the D-SNP is the Medicare is the first payer. So why not utilize that money and then hit onto the Medicaid program?
Oh, sure, absolutely.
Further questions, comments? Senator Fagg.
Thank you, Madam Chairman. Thank you for your presentation. I was wondering, in your application, I'm wanting to apply, and in applying or any of the documentation that comes to me, is there anything mention of voter registration and any of that stuff?
That is a question I will have to take back to our marketing communications team to see. I'm not certain.
Okay, thank you.
Thank you for that question.
Further questions or comments? Did you have one, Barbara? Representative Ballard.
I'm sorry, thank you. May I ask Senator Fagg, would you follow up on that, please? I wasn't sure exactly what you were asking.
I've been around some applications and stuff, Representative, that voter registration comes up in that I don't understand why. So I didn't know if there was anything in their documentation that would suggest that or ask that. Just trying to get a feel of making sure nothing had to do with voter registration with what they're trying to do. So, and if it was, to understand why. That's what I would be saying.
Okay. That's an interesting question because it made me wonder to think about it because I have never seen it before. But I don't know if that's in reference to transportation to go vote, or when you said it came up, I wasn't sure. Okay. It's an interesting question. Thank you.
Okay, I'm going to go out on a limb here. You know how much I hate to assume, but I believe where, part of that comes from is what some of our agencies are doing on some of their applications process. Would that be accurate? Yes. Yeah, that's where it comes from. Representative Reese.
I think, Senator, I think some of your questions might be answered if you would read about the Voting Rights Act of 1965. That act's been in place since 1965, and there's some things in there that might bring some clarification to what you're asking.
I'll put that on my list to read. You know how that goes. Thank you, though.
It's not very long.
Turn your mic on. Representative Ballard.
Well, then I would follow up that because I was about to mention, was it anything to do with the Voting Act? As I'll use an example, at all universities or anyone receiving federal dollars, especially with other schools receiving it, you have to offer voter registration on your campus. That's a federal regulation because the 18 to 24-year-olds, and now it's extended to 29 because of your non-traditional students, are the lowest in the population for voting. And part of of that act was to make sure that young people are becoming more engaged. So that's why I was wondering when you asked it what it had to do with this relationship. But if you go and if you read it, it indicates that for as a citizen in a combination of things, you should be able to get to those events in order to register. And if it's not being provided at your place that you're resident, that you're living at the things, then you have to maybe perhaps provide some transportation because that's a citizen right in order to do something like that. So I don't know if that's what you were referring to, because I hadn't seen an application that really had it, but it was a federal expectation.
I'm good. I had him here. Committee questions? Further questions? All right, seeing none, thank you very much.
Okay. And then we have Maria Salas to respond to the second question around translation.
Is it Maria? Welcome to committee.
Yes, thank you, Madam Chair. Good afternoon, Madam Chair, members of the committee. My name is Maria Salas. I'm the Health Equity Director for Sunflower Health Plan. Again, thank you for having me today. We thank you for the question. Number 2, what is the count of Spanish-speaking users through our interpreter services? For year-to-date 2024, we have a total of 3,548 phone engagements. And for office engagements, we have a total of 317 year-to-date. And I'm happy to answer any additional questions around that.
Okay, committee, we're back on page 12 now. Yes. It's the number 2 question, so then you would look for Sunflower. So that would be that orange with green section. Find it? Okay. So they provided their 23 numbers and 24 numbers is what they've done. Representative Reese.
Thank you so much, Maria, for the information. Looking at the office engagements. Okay, the difference between the phone engagements in the office, one is one using interpreter via phone?
Correct.
Okay, and the other one is having a person.
In person, yes.
Okay. All right, that helps too. Are you guys happy with the numbers, or are you feeling like, they're kind of low?
Looking historically, they are pretty well aligned. Not too much change from prior years. So I would say we wouldn't have too much concern of those numbers fluctuating.
Okay. All right, thank you.
Okay, thank you.
Committee, further questions, comments? All right, seeing none, thank you very much, Maria.
Thank you.
Now we've got Kim Manning, Executive Director, Dual Special Needs Plan, UnitedHealthcare. Welcome to committee.
Good afternoon. I'm not Kim Manning, but I'll introduce her. I am Tim Thomas. I'm the
Just online. Is that you, Senator? No? Who online was getting ready to say something?
Kim Manning was.
Oh, okay. Welcome, Kim, to committee.
Thank
She's
you.
also with United. All right, go ahead.
Go ahead, Kim.
Good afternoon, Madam Chair and committee members. I am going to walk you through UnitedHealthcare's 2025 supplemental benefits for our dual special needs plan. I'll wait for the chart to come up.
Committee, that's on page 16.
So for our special needs plan, we do have 2 HMOs in the market. Our first benefit is what we call our UnitedHealthcare U-Card. It's a pre-loaded credit card of which members can utilize for healthy food, over-the-counter items, and then utility assistance. There's 2 monthly funds available, $265 a month, or for the other plan, $214. The other innovation with our U card, it also serves as the member's ID card when they're going to their physician, vision provider, dentist. It also serves as their fitness center card getting into the fitness program. So it's a combination card with many of the benefits and services that our members have. Additionally, I'll mention later in my descriptions, we also have a rewards program, and those rewards are loaded onto this card as well. So it's convenient for the member. Our next benefit, you've heard this mentioned. We also offer non-emergent medical transportation. We offer 48 one-way trips for our members. We do offer the post-acute meals, so it's 28 meals, within 14 days upon discharge from an inpatient stay or within a skilled nursing facility, and it's unlimited for the year. So if someone is inpatient several times within the year, this benefit can be used each time. For our fitness benefit, we do offer what we call Renew Active. So it's a gym membership to many local and national gyms. So even gyms that are in our rural and frontier counties can join the gym network. So going to the gym, access to digital online services. We also have social activities built into our fitness benefit for members. They can also utilize some of the online programming through AARP that is called Brain Health, which some days I think I need that. So it's a very active benefit for our members. For our dental benefit, we offer $3,000 per year for comprehensive coverage for services like cleanings, exams, extractions, root and canals. It does not cover cosmetic, orthodontic, or implant services. For vision, we offer $400 or $300 eyewear allowance, and then the annual exam for the member. For hearing aids, we have an allowance up to $2,200 or $2,500 each year for our members. And then, as I mentioned earlier, members can earn some additional funds for completing some health-related activities, such as completing a flu shot, completing their annual wellness visit, and then other fitness activities. They are rewarded for that health activities that they do. I'll pause for any questions.
Committee questions, Senator Gossage.
Thank you, Madam Chair. Thank you for being with us. I'm noticing that one of the other carriers had podiatry visits, smoking cessation, fall prevention, the PERS, the Personal Emergency System, acupuncture. I'm not seeing any of that in your list. Was that just omitted, or do you offer those services?
We are not offering the services for 2025, as was mentioned earlier. Many plans across the United States had to make some changes with their benefit offering. What we did look at is making sure that we stayed true to what the members are finding most valuable and mostly what they have in terms of need. And by far, the food allowance, being able to go to the grocery store, get healthy food month over month is probably the most used benefit by your members. Second to that is dental.
I understand. And on your dental, I'm not seeing implants. Are implants covered?
Implants are not covered for 2025.
Thank you. Thank you, Madam Chair.
Further questions, comment? Representative Reese.
Can, using the U card for healthy food, can a person go to a farmer's market? Can you use it there?
Only if they are within the network that we have for our U-Card, and I would have to take that back to see if any have registered for the network.
Oh, okay, thank you.
Further questions or comments? All right, seeing none, thank you very much for being here today. Appreciate it. Now we got the second batch.
Good afternoon, Madam Chair. I'm Tim Thomas. I'm the Director of Operations. Yes.
Go ahead.
Yeah, so our numbers for interpreter services are fairly consistent. We have 55.3 per month where we use our language line for the interpreter services, and then we do a little over 21 per month on site. One key thing that I wanted to add is that we do have over 330 calls per month that we use, that we excluded from this because we have our Spanish-speaking agents local that handle those in addition to the numbers provided.
Questions, comments? I'm looking at you, Representative. Okay.
Thank you.
All right, thank you very much. Okay, so that puts us now on page 17, correct? I would say that we keep them, the last two. So as you go into the new committee next year, it provides some information so they wouldn't have to be presented again. Everyone agree with that?
Yeah.
Yes.
Okay. All right, so now we're on page 17, correct?
Yes.
Huh? So we're done? That's too much paper.
So we have a presentation with Blue Cross about the D-SNP they're going to offer.
They're going to back to, looks like the PACE program. So we have Lee Chaffee. Did I say that correctly? Welcome to committee, Lee. And I want to thank everyone that was willing to move down for us to adjust, so.
Yeah, thank you, Madam Chair and members of the committee, for the opportunity to give you a little information on the PACE program here in Kansas. My name is Lee Chaffee, and I serve as the Vice President Executive Director of the PACE program for Midland Care Connection. I will be speaking on behalf of all three PACE programs in Kansas, which is Ascension Living Hope, Midland Care PACE, and Blue Stem PACE. Melissa Johnson, Executive Director of Ascension Living Hope, is here with me in person, and I'm not sure if Emily Rains from Blue Stem PACE was able to hang in for virtual questions, but if so, she might be on. If not, I'll try to answer questions for Blue Stem. I'm not sure how familiar you are with the PACE program, so I'm going to give you a little overview, some statistics, some outcomes, where PACE is in Kansas currently, just to help educate you about PACE and what we can do. PACE stands for the Program of All-Inclusive Care for the Elderly. The PACE model is built on the belief that it is better for seniors with chronic care needs and their families to be served in the community whenever possible. PACE programs deliver the medical and supportive services required, providing the full continuum of care for older adults with chronic care needs while maintaining their independence at home for as long as possible. Let me tell you a little bit about the services that PACE offers. The central point to a PACE program is the Adult Day Center. The Day Center offers physical and occupational therapy, recreational therapies, meals, individual counseling, social work, personal care, and the day centers also have a fully functioning provider clinic where medical care is coordinated by a PACE physician familiar with each of our participants' history, needs, and preferences. In addition to that day center, PACE provides all home health care and personal care, all necessary prescription and over-the-counter drugs, social services in the home, all medical specialties that the participant might need, such as audiology, hearing aids, dentistry, optometry, podiatry, and speech therapy. PACE provides any respite care that might be needed during a participant's time with our program. And PACE provides any hospital or nursing home care when that might be necessary for our participants. PACE is funded. We receive a capitated payment each month to provide and cover all services and costs associated with participant care. How does one qualify to be served by PACE? The person must be 55 or older, 55 years of age or older. They must live in a PACE service area, and I'll talk to you a little bit about that when I talk about the 3 programs. They must be able to live safely in their home or in the community with PACE support at the time of their enrollment in our program. And they must be certified to need nursing home level care. So if they were not served by PACE, they would be needing nursing home care. So now I'd like to share some notable statistics about PACE, what we do as a program, so you understand who we serve. I did provide some written information about Midland Care specific statistics, but what I'm going to present to you verbally is an average of the 3 programs put together. So 63% of the participants we serve right now are women, and 37% are men with an average age of 73. Our participants, on average, have 6 chronic conditions, with 50% of them having dementia. Talking about meals, in the PACE program, we serve upward of 12,000 meals each month to our participants. Many of them get meals in the day center. If they don't get meals in the day center, those meals are delivered to their home if that's something they choose and is necessary for their well-being. Each of our participants receives between 9 and 12 transportation trips per month, but it is unlimited. If they need more than that, we provide them transportation to all of their appointments, anything that might be necessary to help them stay in their home and stay in the PACE program. On average, 75% of our participants are duly eligible. They're drawing both Medicare and Medicaid benefits, and about 24% of our participants are Medicaid only. A small portion of our participants are Medicare only. These participants, or these percentages, do vary between the 3 PACE programs depending on the area that you're serving in. The PACE model is gaining popularity due to our successful outcomes. Some of those successful outcomes include our participants have less than 1 emergency room visit per year. Over 90% of our participants are able to be served in their home for the duration of their time on the PACE program. The PACE participants' hospital readmission rate is 28%. 96% of the PACE participants would recommend PACE as a program. 97% of their family caregivers would recommend PACE. So Kansas has three organizations that offer PACE currently. Ascension Living Hope is a nonprofit ministry of Ascension Living. That was the first PACE program here in Kansas, and it started in 2002. Ascension Living Hope currently serves Sedgwick County only. They serve 328 participants, and they employ 145 staff members. Midland Care PACE, my organization, began in 2007, and we have experienced significant growth since March of 2020 in the PACE program. We currently serve 610 participants across 15 counties in Northeast Kansas. We have adult day centers located in Topeka, Emporia, Lawrence, and Kansas City. We employ 240 staff. Midland Care PACE is a part of Midland Care Connection, which is an organization that provides care and services for around 2,800 people a day across 22 counties in Northeast Kansas, 6 counties in Central Kansas, and 12 counties in Missouri. Midland Care Connection provides services including PACE, hospice, home health, Meals on Wheels, palliative care, adult daycare, and grief and loss counseling. In 2022, Midland Care Connection received approval from KDADS to expand to Johnson, Miami, and Franklin County. So we've been working on that process of expansion to offer PACE to those 3 counties. It has not been offered there before. We are currently in the construction process to build a day center in Olathe, Kansas, which we're excited will open next year in the fall. We were approved to enroll participants in those counties to start serving them with our program earlier this year, and we're serving 10 people currently in those 3 counties. Midland is extremely grateful for the state of Kansas's support in the growth and expansion of PACE into these 3 new counties. The third organization that provides PACE in Kansas is Blue Stem PACE. It's the newest of the 3 PACE organizations. It's been serving a 6-county region through a PACE center located in McPherson, Kansas, since 2016. In 2022, Blue Stem added an alternative care site in Hutchinson. As a rural PACE provider, Blue Stem currently serves around 120 participants across a 4,500 square mile service area, and they employ 80 staff members. Blue Stem PACE is a part of Blue Stem Communities, a not-for-profit that also operates 2 life plan communities, Showalter Villa in Heston and Kidron Bethell Village in North Newton. Interest in PACE, the PACE program, has been growing among state and federal policymakers, specifically during the pandemic, driven by the desire to develop a more robust service that allows older adults at risk of premature nursing home placement to remain at home. Over the past several years, notable public policy advancements have reduced these barriers. And I have noted all of those in my written testimony, some of the public policy advancements that have happened that have allowed for PACE to grow. The first one was the removal of the enrollment cap that happened with the implementation of KanCare. Prior to that, there was an enrollment cap of how many people could access PACE, and now there is not an enrollment cap. Streamlining of the regulatory process by eliminating the requirement for adult daycare surveys or inspections by the state of Kansas. We are audited and inspected by CMS. Rebasing of the capitated rate that we receive every 3 years per CMS guidance. That was a policy change that was made that did help with the growth. The one thing that really helped with our growth was the increase in the protected income level. That was really helpful to let more individuals access PACE. There were a few others that are noted in the written testimony that I provide. Currently, one of the significant barriers to accessing PACE is just a general consumer knowledge of this program and what it can do for individuals in Kansas. Recently, all 3 PACE programs were awarded an ARPA grant through the Kansas Department of Health and Environment for PACE outreach and engagement. We're very excited to partner, all 3 of us, and for the next year, we will use those funds to do a marketing campaign to make sure that consumers in our service area are aware of PACE as an option for them as they age. Talking about statistics, talking about facts, I can share with you all of the numbers, all of the services that we provide, but what I really want to share with you today is just a story, if you'll allow me. I know you're running late on time, but if you'll allow me a couple minutes, I want to tell you a little bit about Ben. Ben is an individual who is served by the Midland Care PACE program. In 2021, Midland Care became familiar with Ben and began meeting with him. He was struggling to care for himself and had just been in a prolonged hospital stay during the pandemic. He came out of the hospital. He was extremely deconditioned, weak, and he was just struggling with his days in his home. He had several chronic conditions. He was falling frequently. He was having several additional hospitalizations. And Ben suffered from significant social anxiety, which was made worse with all of those trips to the hospital. So we engaged with Ben, and Ben wasn't quite sure he wanted or needed help, right? He wasn't quite sure it was time, and he certainly didn't want to leave his home. He wanted to stay in his home. That is where he felt comfortable. And so he thought, well, maybe I'll engage with PACE in a few months, but our intake coordinator, Mona, who met with him, she's like, he needs it now. So we talked with his family, and with a lot of encouragement from his family, Ben made the leap, and he decided, okay, I'm going to let PACE help me. That's kind of where the magic begins in PACE, is when they say, yes, PACE can come in. And so what PACE does is we are the provider of the services, and we develop deep relationships with these individuals. We have the primary care provider that can learn all about what they need and spend an hour or two with that person. What kind of, I don't know any physician that is able to spend that kind of time with their patient, but in the PACE program, that is possible. It provides better medical outcomes for that person. So Ben engaged with us, he trusted our team, and he began working with physical and occupational therapy.
Lee, I'm so sorry to interrupt you, but we are way behind schedule.
Oh, okay.
If you could just wrap up real quick.
Sure, no problem. Well, end of the story, Ben is walking. He's going to Wichita to hang out with his grandkids. He's having extremely great outcomes because of the PACE program. And all of that, in the way PACE is funded, is at a discount to the state of Kansas. PACE is funded at 90% of what would otherwise be paid to nursing homes or HCBS. So our main ask of the legislature is that you continue to review and rebase PACE Medicaid rates annually so that we can continue this wonderful program and sustain it for years to come. So thank you, I appreciate it. Sorry, I didn't mean to get long-winded. We will sit for questions, whatever questions you might have about PACE.
Committee, any questions for Lee? Yes. Michael, excuse me, Senator Fagg.
Thank you, Madam Vice Chairman. You know, as I was listening to this, it's a great program. Do you have any homeless people? How's the homeless people fit in this thing?
Yeah, that's a great question. It is something that we are very committed to and passionate about. The federal regulation does state that someone has to have a safe place of residence to be enrolled in PACE. However, we do consider a homeless shelter a safe place of residence. So we do have a certain amount of participants that might be unsheltered at the time or become unsheltered while they are in PACE. So we do do what we can to help get them safe housing so that we can continue to serve them.
I just have a quick one.
Senator Petty.
Thank you. Thanks for your presentation. So I see here, I suspect this is going to be your request for 2025 about the annual rebasing, because now we're doing it. Although we did, so we did it in 2023 and 2024, but you're wanting it to be every year, not every 3 years.
Yes, we would like it to be reviewed and rebased every year just so we can remain sustainable and continue to save the state money on individuals who might otherwise go into a nursing home.
Representative Ballard.
I appreciate it very much. Thank you so much for a refresher on it, because I sometimes forget who actually is eligible for it, but also by identifying the three places you have. And of course, I was not aware of the new one in the police station. Thank you. I don't know how much you heard it, but basically, I want to thank you very much for refreshing our memory on that. And the three places, especially the new Blue Stem, and you said that's to open in when?
Blue Stem is already in existence. Blue Stem serves central Kansas. The Olathe Center, which is the new counties in Johnson, Franklin, and Miami, that's for the Midland Care Program. We have already started serving participants in those counties, but that day center will open next fall, in the fall of 2025.
To do it. Well, that was that was really good informational. And of course, I'm glad you stressed the fact that it's a 90% of the funding rates as well. So thank you very much.
Representative Carpenter.
Thank you, Madam Chair. So I got in on the end of this, but I think I think I know exactly what you're talking about. And we've had that discussion, you know, about rebasing it every year. And you're going to be fine when inflation continues like this. but you're not going to be as well off when inflation starts to decline and you're rebasing it every year. So that's the trade-off. We're not doing a look back over 3 years. We're doing it over just 1 year. And it'd be fine like now with periods of high inflation, but I'm not sure that's a good idea.
Thank you.
I might be able to be convinced, but I've looked at it pretty hard.
Well, I'd be happy to meet with you and talk with you more about it to convince you. The PACE program, again, it does save the state money on folks who would otherwise be in a nursing home. It's a great program. We encourage quality of life, and they get to stay at home. But
Never mind.
I understand what you're saying about
Never
the 3
mind.
years versus
So,
the 1.
When I heard rebasing,
Mhm.
I was talking about nursing homes. I apologize for that.
No,
So
I
was out in the hall, didn't hear it.
Oh, pace.
Pace.
Right.
And I
Right.
agree with you 100%.
Okay, thank you.
Thank you so much for coming. We've really got to move on. Thank you, committee.
Appreciate that. Thank you.
And
Thank
next,
you.
we will have Melissa Johnson, Executive Director of Ascension Living Hope. She was just for questions. Very good. Thank you. And then committee will move on to Emily Rains. Same thing, just virtual for questions. Wow, we're moving farther ahead than I thought. Kyle, I see you right over there. Next, we have Kyle Kessler. We're moving on to update on Behavioral Center for Excellence.
Good afternoon, Madam Chair, members of the committee. I'm Kyle Kessler, Executive Director at the Association of Community Mental Health Centers and current Chairman of the Board of Directors for the Kansas Behavioral Health Center of Excellence. We appreciate the opportunity to be here this afternoon to talk about this relatively new initiative. We started conversations about 15 months ago to really drill down into what we consider to be a significant behavioral health workforce shortage in our state. And we don't just have hot spots, we have a hot state. So as the biggest hot spot in our hot state is South Central Kansas with a shortage of medical and clinical providers and a new state mental health hospital coming online in the next year and a half, 2 years. We knew that if we did not really start acting with intentionality and immediacy, that what we have seen in the Larned State Hospital area with the cost on contract nursing going from about $5 million to $40+ million in the span of 5 years would just be compounded in the south central part of the state. And so you would have an awful lot of wage wars and competition in terms of for continually decreasing resources. And then that would require more reliance on out-of-state telehealth and telemed contractors. So to that end, about 15 months ago, we started working with a number of partners, including several providers of behavioral health services and treatment, as well as educational entities in South Central Kansas, including Wichita State University, the University of Kansas Medical Center in Wichita, Friends University, Newman University, as well as the statewide associations for community colleges and technical colleges on trying to flesh out what programs were available, as well as what opportunities we might be able to see to kind of return our state to what we consider to be a past glory or a point of pride, because the history of mental health in Kansas is widely recognized, where we were a leader, and a major part of that was the Menninger Clinic, which was right here in Topeka for over 80 years, and it left about 30 years ago, as most folks are aware of, and relocated to Houston, Texas as part of the Baylor College of Medicine. And what we lost when they relocated, I don't know that anyone realized the level of behavioral health staff and overall healthcare staff that were being produced and trained at the Menninger Clinic, and whether that was, 10 to a dozen psychiatrists every year, postdocs in psychology, social workers, marriage and family therapists, nurses, clinical pastors, which is something I've been reacquainted with, and even how they would help train clergy to deal with mental health crises in their congregations. It was something that we really strived to see how we could potentially recreate that. And because we did have a pipeline for developing and producing a high-quality workforce, and we want to recreate that in the aggregate. Some of, our members in the community mental health system, staff in our office, have heard me make about 1,000 references to the movie Moneyball and the idea of recreating something in the aggregate, not necessarily replicating it identically, but being able to do something with a variety of different resources instead of just one, or just a couple. And so to that end, by using a consortium approach with a multitude of partners, we now kind of fast forward to just a little bit with how helpful the Senate was in working with us on some identified initiatives that were produced and developed by this group that had started working together. I know Senator McGinn, Senator Petty kind of launched some of those conversations in Senate Ways and Means Budget Subcommittee. And then over on the House side, some even heavier lifting was done after Chairman Waymaster in House Appropriations appointed a subcommittee, which was chaired by the late Representative Les Mason. And I really want to give an incredible amount of credit for the work that was done on that, because I think it really did start out as initially talking about the contract costs relating to workforce and behavioral health workforce and nurses at the state hospitals, but then expanding on that to look at the overall workforce. So it was truly an all-star team of legislators working on it. And now I'm just going to sound like a kiss-up, because it actually was Representative Landwehr, Representative Kincan, Representative Ballard, and Representative Carpenter, in addition to Representative Helgerson. So out of that came a $5.7 million appropriation, which was approved during the conference committee process and signed into law by the governor in the omnibus appropriations bill. So then we fast forward, and the result of that appropriation, and my colleague Michelle Ponce here in a few minutes will provide a brief summary of those initiatives, so you see what the variety and diversity of those items happen to be and kind of where we can see them going in the future. Because if we fast forward one more time to about 5 weeks ago, I was visiting with one of our keynote speakers at our association's annual conference on behavioral health, and it was Dr. Joe Parks, who is currently the Chief Medical Officer at the National Council for Mental Well-Being, which is our very large national association. And so in visiting with him, he said, hey, I'd like to hear more about your Center of Excellence stuff that you guys have been working on. And so he said, you know, what about policies? I talked to him about some of the things that we'd been discussing. He said, okay, now funding, how is it being funded? And I said, well, initially we were able to secure about $90,000 to $100,000 in startup funds for some of our the work we were doing in our office, and as well as now with contract staff on the ground in Wichita. And so, but now one of those was from a Medicaid MCO. That MCO, Aetna Better Health, won't be in the state. And so we're hoping to figure out how to replace that money, because we have found it to be very helpful in the work that we were doing with consulting and paying for some of our own infrastructural costs. So even with that, then I was excited to tell him about the $5.7 million appropriation. And he said, oh, that's outstanding. And so just to know a little bit about Dr. Parks. He's also a former Medicaid director in the state of Missouri, and then under a different governor was the mental health department director, and he's a practicing psychiatrist. So he's a bit of a unicorn in the healthcare, finance, and practicing world. And so he said, oh, $5.7 million, that's incredible, Kyle. He said, so is it 2.2 state general fund and about 3.5 federal match? And so I could feel a mild amount of shame and ridicule coming over me, and said, no, it's actually 5.7 state general fund dollars. And he said, well, Medicaid graduate medical education can be used for, and I was very familiar with Medicare, GME, and it almost does take an act of Congress to get something through that. It's much more rigid and very clearly defined, I think, with CMS and HRSA at the U.S. Department of HHS. But apparently what they're being able to do with Medicaid GME provides a lot more flexibility to the states in trying to also look at What are your outcomes? What are you producing? What's the amount of oversight that you have? And the National Council on State Legislatures, NCSL, last year did a really good webinar over this, and they were talking about those two things. The states where there are challenges with how some of these workforce initiatives work either veer too far towards the oversight part so they don't accomplish anything, or they veer too far to the outcomes and outputs piece, and so they don't pay enough, and they play maybe a little too fast and loose with some of those guidelines on supervision. And I've been around government enough during in our state health and human services agencies through my career that I don't ever want to be on the working end of a CMS recoupment. That's not something that makes anyone feel good. So I think that for us, I'll kind of conclude my comments and then turn it over to Michelle. But really, the point of the Center of Excellence was to provide timely access to high-quality treatment services, exceptional training and education opportunities in behavioral health, and to be an incubator for innovation. And those are all the things that used to be associated with the Menninger Clinic. So that's what we really hope to see going forward. If I was going to make an ask to this committee at the appropriate time when you're doing your committee recommendations, it would be terrific to add something to the report supporting the continuous work and programs and funding for the Behavioral Health Center of Excellence going into the future, and being able to draw down those additional federal dollars for some of the other programs that, again, range from more psychiatrists to more nurses, more clinicians and social workers to more behavioral health techs. So we're developing strategies for all those things. And one of the first actions of the new board of directors, which is in the process of being incorporated and getting its 501c3 designation, was to appoint Michelle Ponce, who's our associate director in our office. She was appointed as the acting director of the Center of Excellence, and she does an excellent job of negotiating additional responsibilities for no more additional money. So I don't know how sustainable that is in the long term, but oftentimes when I introduce her, I say, yes, she does what I do, just faster and smarter. And then other people started also introducing her that way. So now it doesn't sound quite as good when I hear other people do it. But I will turn it over to Michelle, and I'll stand for questions at the appropriate time.
Welcome to committee, Michelle.
Thank you. Madam Chair, members of the committee, I am Michelle Ponce, Associate Director for the Association and newly appointed Director of the Behavioral Health Center of Excellence. Kyle did a really great overview of what we've been working on. It's kind of crazy, not even quite a full year. A lot has been accomplished. I want to talk about, in brief, some specific initiatives that are currently in the works. But first, what I really wanted to talk about first is what has made this really work and has been really inspiring to observe. So we have these groups of providers and educators all in the same room. The providers or provider partners, they really know what their needs are in terms of staffing so that they can meet the needs of their clients. And they're communicating that to the educators in the same room, who have the ability to develop or strengthen programs to train those providers. And they know what their students need to be successful, to enter the workforce, and they're communicating back to the providers in the room. So before we even get to the funding, we've had some short-term wins already. For example, we had one of our social work faculty members tell us, these meetings have been so beneficial, regardless of what you might or might not be able to do funding-wise for us. I have new social work placements that I didn't have before this group started meeting for her students, and that was just one of my big wins to start with. Kyle mentioned, and I want to thank you all for the FY25 funding that was appropriated for the Center of Excellence. And what that is scheduled to do, we have just recently executed a contract with KDAD so that that funding can then be released to the Center of Excellence. And it's earmarked to increase psychiatric residency programs at KU Med, Wichita. It's also going to fund an addiction fellowship program at the KU Wichita campus. There is about $1.3 million for various programs at Wichita State University, including a new forensic psychology program, expansion of a behavioral health emphasis in their physician associate program, some additional paid internships, and some expansion of counseling and psychology programs. In addition, $2.3 million is set aside for what will be essentially a grant program available to any community and technical college across the state of Kansas who has a 2-year nursing program. And that funding, it will be up to $5,000 per qualified faculty member in the nursing program for retention and recruitment bonuses for those nursing faculty. Looking ahead, we'll be back in front of you when the budget committees begin meeting. The programs that are currently funded in FY25 will be requesting that those continue to be funded. They're not one-year programs, but our Center of Excellence partners have identified some other strategies that they think will help us not only recruit and retain current staff, but continue to grow that pipeline. They are looking at some applied learning opportunities, particularly for forensic and psychology assessment training, additional internship opportunities, and expansion of clinical mental health counselor and addiction training, expansion of the Master of Science Family Therapy degree program at Friends University, creation of an undergraduate pathway at Friends University that prepares their graduates to pursue the licensed addiction counselor credential, reestablishment of a psychology internship program that was formerly known as the Wichita Collaborative Psychology Internship Program that really opens up opportunities for students to serve in mental health centers, not only KanCare there in Sedgwick County, but surrounding areas as well. Additional stipends for social work students at Newman University, as well as additional psychology or psychiatric residency programs at the Kansas Health Sciences School. I know that was a lot, and I'm happy to provide any additional details or answer any questions that you may have.
All right, thank you very much, Michelle. Questions, comments? Senator Fagg.
Thank you, Madam Chairman. Thank you both for your presentation. One thing that, I sure like the idea of the community college, friends. It sounds like a great deal. I worry about if you get a freshman into the system and you offer them some stuff and then they change their mind. You're probably new enough at this, you'll be tracking through this to see what this actually produces, because I think as you look for money to the future, it's got to have performance in that somehow to show what we're doing. Because I worry that you're going to train them up and then they're going to end up in Michigan. That's what I'm saying to you. So.
Yeah, as we move forward, we will be tracking the number of actual graduates who receive some of the funding through the Behavioral Health Center of Excellence. I mean, our hope is that when they receive their training and also have the opportunity to work within our community provider system, that it incentivizes them to stay in Kansas. Anecdotally, we do hear that graduates leave the state, but if we can train them and provide them the opportunities to work here, we're hopeful that that will help retain them.
If I could, I might just add to that very briefly as well, Senator, because I think it's a great question because, one, like the faculty piece and the people who can train the workforce or the students is a big thing. So that's where on the community college and tech college side, that will be recruitment and retention for faculty, as well as establishment of faculty positions at WSU and the infrastructure at KU Med for psychiatry. So that's a big part of that. But then when we start looking at internships, practicums, and then the physician's residencies later on, we're hoping that we can figure out a way, and we've had that conversation initially, that if we can get a student to sign, okay, I'm going to get a $5,000 stipend for a practicum, or this residency, a contract I'm signing is 3 years, but I'm going to stay an extra year or two in Kansas. So kind of a Doc Hollywood thing, where they end up having to stay for a couple of days and then say, wow, I love it right here in El Dorado or wherever the case might be. So I think for us that, and the number of unpaid internships and practicums at universities, says the father of a social work student who's doing a free practicum and also paying course credit for it. We need to value our workforce early and often, and to show them how valuable they are and how important that work they're going to do is. So I think the days of people doing free work and also paying for that tuition should be in the past. I would add also, before I forget, I certainly want to, I don't want to miss the opportunity to thank Representative Concanon and Chairwoman Landwehr for all of their work and collaboration over the years. I would lament that if I did. And on workforce, the work that we did on graduate medical education several years ago on adding psychiatry, and Representative Concanon was a champion of that, and that helped set the stage for us to continue working on this. On MHIT and CCBHCs, certainly the chairwoman has been a champion to the Matterborn. I appreciate you both greatly.
Senator Petty.
Thank you, Mr. Chair. I will say that last year, when the presentation was made to the subcommittee in the Senate about the Center, Behavioral Health Center of Excellence, I was a little hesitant, a little cautious about the success and moving forward. So it is encouraging to hear about the partnerships that are being developed and moving forward, because it absolutely is all these areas that you're touching. We have a great need, and if it starts impacting in the Wichita area and moves out from there, I think that's, important. So I'm looking forward to seeing what you're asking for next.
Well, so there's a couple pieces to that, Senator, and your skepticism was certainly, received appropriately, and I am the very last person to ever use the term, we really are building this airplane while we're flying it, because that doesn't make anyone feel safe. No one likes that. And I already have some anxiety related to flying. But anyway, in terms of how we are now actually accomplishing some things, and we hope that you'll see that the accountability associated with your trust is something that we want to absolutely live up to. And part of our hope, and my first call, honestly, I should have included after talking with Dr. Parks, was to call Secretary Howard, because she knew who he was from her time in federal government. And so we started talking through some of this and her knowledge of Medicaid, in addition to Secretary Stanek, and we've had some really good initial conversations about them wanting and seeing the need for that workforce in the south central part of the state. And in fact, when we were in House Social Services Budget Committee last session, one legislator who will now be over in the Senate said, usually what's good for Wichita and is helpful there impacts things further west. So that's another thing we want to live up to. You want to add anything?
Yeah, first of all, I don't blame you. It was still a little bit fuzzy when we spoke to you last spring, but a lot has happened since then. We have filed articles of incorporation. The Kansas Behavioral Health Center of Excellence is its own real entity. We have a tax ID. We have a pending application to the IRS for nonprofit status. The group has adopted and approved bylaws. They have elected a governing board. And there was one more item, but I completely forgot. They have come together and developed a public policy agenda. So I think all of those things really speak to the commitment that the partners have made, and they're really not even looking at it as just another meeting. We've spent the summer working with Wichita State's Community Engagement Institute to go through a strategic planning process. Just last week, we said, so we've been meeting every 2 weeks for a year. We know that's a pretty hectic pace. Should we look at it, spreading those out? Unanimously, they all said no. We don't want to lose the momentum. We want to keep meeting every 2 weeks. So if that gives you any indication of kind of the commitment they've made, I think we're making good progress.
Committee, further comments? Representative Reese.
This is all really great information. And a question I had is, on the page that starts with looking towards year 2, the intention to build on some of the programs. One of the things that I hear from folks who are therapists, whether they're in training, whether they're psychology counselors, social workers, one of the things that they feel would be an attractive thing is that if they are guaranteed in some way of being able to be supervised for their next level of licensure, for the independent license. And so some folks are that's one of the reasons why they're moving out of Kansas. We don't have enough LSCSWs or whatever the equivalent is in psychology and counseling to be able to help them, because that's what, 2-3 year process.
Sure, and again, Kyle Kessler, and Representative, it's a good question, and it's a bit of a conundrum. It as proof that the Center of Excellence Board is not any kind of groupthink. That was actually one of the, I'd say, debates that there was about whether or not you should have master's level clinical social workers being able to do some amount of supervision requirements for psychology or marriage and family therapy students, or vice versa, and how that turns around, because there is a shortage of the clinical oversight, which you need to then move upward and onward. So I think that there are a lot of providers that do use that, and that may be some place that we might be able to look. I'm hopeful that that can be an angle of this graduate medical education. If we put it pen to paper and CMS approves something and there's some grant funding available through that to help pay for some additional clinical supervision, and again, tie a clinician to Kansas for at least a year or two, as we're paying for that, it could be a win-win.
Thank you, Madam Chair, for the follow-up. A follow-up, Kyle, is during the practicums, it's easier done, where you cross disciplines, you've got a psychologist who is supervising a social worker in their MSW program. And that's fairly easy to do. A couple of hoops to jump through, but it's kind of fairly easy. It's after that. It's once you graduate and then you're wanting to have the independent license.
Yeah.
That's where we'll lose people too.
Right, and I think that we understand that generally, that there is that distinction between the two, but we know for sure that the second issue relating to the clinical supervision or the clinical licensure is probably trickier than just the practicum pieces, which is location, site, oversight, and things like that.
Committee, further questions, comments? Kyle, and I didn't see it here in your testimony, did you talk about when this all was a thought in the very beginning, is you kind of traveled around and visited with a lot of potential partners?
Yeah.
Did you list those anywhere or talk about, because it's an extensive list of people that normally have turf battles, but there was no turf battle. They were bought in on this.
Michelle alluded to that. I alluded to it. She went into more detail on it. But yeah, the 6 areas of higher education, no battles between MDs and DOs or MFTs and psychologists. So refreshing. And in fact, a couple departments, one social work department and one psychology department from the same school, as I was going around introducing myself at our first meeting, they turned to each other and said, "Hey, and it's nice to meet you. I've been meaning to get across campus to visit and say hello." And so, I mean, some of those things, we don't realize how busy folks in higher ed get when they are looking at curriculum changes and faculty recruitment and what classes that they will be teaching and the right number of students and some of that kind of counseling that they do. And then on the provider side, Substance Abuse Center of Kansas, Ascension Via Christi, Mental Health America of South Central Kansas, and KanCare, and Kansas Department for Aging and Disability Services. Those are all the board member positions at this point in time. And KDADS has one on the behavioral health side, Behavioral Health Commission and Commissioner Adkins, and then on the hospital side with Deputy Secretary Bruner, all at the table.
Okay, and then what do you need, or do you need anything from the legislature on the GME side?
I think the recommendation to go forward with it would be great to include, but that's something that, again, Secretary Howard and Secretary Stanek, as well as Director Osterlin and Commissioner Adkins, have all been really receptive to the idea as a real possibility to help fund a lot of our year 2 initiatives. So the more success we can have with that, then the less we come to you all with our handout and making modest pleas.
Okay, so then by, setting it up as a nonprofit entity, does that then open you up to, other groups or organizations that may want to contribute financially to this program?
We certainly hope so, and that's the idea behind this. I mean, that it won't have, necessarily any active lobbying. I mean, our association happens to be a 501c4. I think the Hospital Association or others are 501c6s, and there are some that are actually 501c3s. But we see this to be an education and training entity, and hopefully eventually have some research capacity to it as well. But yeah, we would hope that allows for some funding flexibility in receiving contributions.
And kind of tagging along where Senator Fagg went with where he was headed, is there anything from a clawback perspective of you've invested into this student that if they bail, then they have to reimburse? Kind of like what we do with our physicians, that graduate in Wichita, Kansas, and at KU, go out Western Kansas, and over 50% of them stay in Kansas. Because you're right, and I think Representative Concanon can tell you a story about a doctor that occurred with.
Well, and I think it's something that we want to look out further, but in the same way that Representative Ruiz made the point about there's the practicum site and then there's the clinical supervision. In the same regard, I think that for us, being able to try and keep them for a year or two, and then for some of those clawback pieces or their payback if they say go, hey, I've had this great opportunity at the Mayo Clinic. Mayo Clinic's going to buy out my $25,000 or $50,000 out, or whatever that may be. Developing something like that, I think, is a really good idea. I mean, and we're, in that regard, we probably still have some additional work to do and some consulting in that area because we want to get it right. And there are a few of these centers around the country but I think we're doing it in a very unique way by all of the different partners. If for example, for some reason, someday KanCare goes away, we plug in another mental health center or CCBHC. Or if Friends doesn't want to participate, then we grab another university there. And the vice chair of the board is from Friends, so I don't anticipate them going anywhere. But I think that us being creative and making sure that we aren't beholden to one specific entity is pretty important part of it. Do you have anything you want to add?
And then next year, you'd probably like to see this committee recommend legislation so that this isn't a proviso.
Well, yeah, it would be great if it goes into the base budget. We would be thrilled for it to be there, and that's one of our asks from KDADS as well. But if we could keep it in the base, and we don't at this point in time have a reason to believe that it won't be, then we can keep building on that either through matching funds or partnerships in that way.
And then one last question: could you see this as it grows, of the feasibility of maybe having satellite locations in other areas of the state?
Yeah, and so that's another thing, and I'll turn that one over to Michelle because she's looked at that a little more closely. But as we've had about 36 different participants at different points in time, and we have our board now, we're also establishing advisory committees. And so we have one in South Central Kansas, but to go ahead and put one in Northeast Kansas or Western Kansas or Southeast Kansas or Topeka area and have a bunch of different representatives from higher ed and the provider side, it could absolutely grow in that regard. And even the board membership isn't exclusive to South Central Kansas. It's a four-year university providing this, or a private university providing this, or a medical center for DO or whatever. So we're very vague in naming those partners. Is that fair?
Yeah, absolutely. The only thing I'd add real quickly back on the funding and the nonprofit piece is I want to make sure everyone is aware we are not putting any of the state funding towards administrative costs. Our association believes very strongly in this initiative, and we have committed that we will continue to provide staff support for as long as that is needed. That said, we have been making sure that our state health foundations are aware of the work that we're doing, and we will be actively looking for some private dollars that if at such time that would fit with the mission and vision that the group has, that perhaps we could identify funding of that nature to hire full-time staff. But we will be here until if or when that happens. In terms of growing beyond Wichita, I think that is the vision. There are a number of reasons that Wichita was the right place to start, not the least of which being those partners all there in the same community, as well as the new state hospital that's going to have its own staffing needs soon. So it just seemed like the right place at the right time. looking forward as the center grows and matures, I think there's a couple of things that could happen. Perhaps it could be replicated. Perhaps we could do something very similar on its own, maybe in Fort Hays. Or, as Kyle mentioned, maybe it's expansion of advisory councils. We purposely left the bylaws the way they are written. They don't say KanCare has a seat on the governing board forever. It doesn't say Wichita State University. It says a university, a community mental health provider. So there is some leeway in there that if we did expand versus having maybe multiple, maybe we just expand it, perhaps 5 years from now, maybe it's someone from Fort Hays that's sitting on that governing board as well. I think there's a number of options for growth.
Well, I think one of the other assets you have is the WSU-KU Biomed Center in Wichita, and I think that can be a great connection that you guys can be in. So, committee, are there any further questions or comments? Representative Ballard and then Representative Reese.
Thank you. It was very briefly, and Representative Landwehr just touched on it. I thought the partnership you have is very unique, you know, and was needed as well. But my initial question was your administrative costs, but you addressed that there isn't. And often, you know, whether it's a grant or whatever you have, when you have administrative costs, people see this as a way that you make money too. But then when you don't have an administrative cost, then you have invested in it as well as other stakeholders that come in. And the advisory boards in various places, I think, is very, very wise, because then you have ownership not only in the area where you have it, but you have ownership for the other people that can participate in it, and that becomes really valuable. You know, initially when this was introduced, people were very skeptical. We weren't sure about what had happened. I just want to say, I think you have done an admirable job in terms of bringing all the people together to understand the purpose and how the state of Kansas will benefit from this, not just one area, but geographically other areas as well. So I want to say congratulations on this portion of it, because it's always harder to get it started and get people who buy into it and feel as if this is something that they can really participate in. I think you have done that. So thank you very much.
Further comments or questions? Representative Reed, I'm sorry.
Thank you, Madam Chair. Just to say add a little bit to, you know, the conversation we had about, you know, what if a person gets trained and then they leave later on. A hook, again, I'm going to harp on this, getting the supervision that you need for the independent license. So for a social worker, that would be going from an LMSW to an LSCSW. You become a specialist clinical practitioner. And if you were to go out and find an LSCSW to supervise you, and it takes about 2 years, at least the minimal of 2 years of supervision before you can even try to sit for the exam, you're paying easily $150 an hour. Yeah, 2 years of that, that's very costly. And so this is why it's, you know, it's partly why we have a shortage on the LSCSW, and we get the equivalent on the psychology and the counseling, that if we would have options for people to be able to have that provided, you know, by the association, the state, somewhere, we'll keep people. They'll stay because of that, because it is so expensive to get it.
Further comments or questions? Kyle, I want to thank you for your kind words. I appreciate that, and I think there's a lot of effort on of legislators really trying to push for a lot of this stuff. And then I'm going to tick off probably one of your people that you work with, and that would be Diane Jerstead, because I was shocked to see her in the room today. I know that she monitors us. She always hated it when I would bring her name up in the middle of a committee. But, you know, I have to, and I don't know, Diane, if you had the opportunity to look at the MHIT numbers that were presented yesterday, but it's nothing like what you started with. And I want to thank you for what you did, travel in this state on a regular basis and making that program get off the ground like it did. So thank you very much. So appreciate you being here.
Thank you, Madam Chair, and I was remiss in not mentioning that Diane is our consultant on the ground in Wichita and here for us. So thank you. Thank you.
All right, committee, now, let's see, is Steve back yet? Okay. Don't let me forget him. Now we're going to start with our updates from our MCOs on the Medicare Advantage Plan services. And first up, I have Michael Stevens, President and CEO of Sunflower. Were you looking around to find someone else to do it? Is that what it was?
I was, and fortunately, I found one. I'd like to welcome Sarah Kurgan back to speak on behalf of Sunflower.
All right. Are you shirking your duties or what here?
I am.
Welcome back, Sarah.
Back up. So thank you, Madam Chair and Committee. Sarah Kurgan, Senior Director of Operations, and I will be going through information as it pertains to our D-SNP plans for plan year 2025. So as I alluded to earlier when I was up here talking about the issues log and our 2025 plan benefits, I wanted to highlight information as it relates to the 3 D-SNP plans that we have. So first off, the information that you see there to the left, that is our coverage map for our Medicare Advantage plans. So this represents our D-SNP plans as well as the other plans that we have for the upcoming calendar year for Sunflower Health Plan. Below that, you'll see reference to low-income subsidy. So this is extra help or support that members can access. So some of the individuals enrolled in our plans might automatically qualify for this extra help. And if they are not certain if they qualify, they can contact the Social Security Administration office to determine if they might be eligible. There to the right, you will see the different eligibility categories that the state of Kansas currently has as a part of our D-SNP contract. And so these are the different plans that, I need to adjust this just a bit. Can you hear me okay? I feel like it's echoing a bit. No, I think that's okay now. Thank you. All right, so within our, to answer the question earlier, so we have the 3 D-SNP plans. 2 of our D-SNP plans have the full list of eligibility categories that are reflected here. So the qualified Medicare beneficiary, also known as QIMBY. So we have QIMBY and then we have QIMBY Plus. So sometimes these individuals are referred to as having partial Medicaid coverage. And so for these individuals, the Medicaid plan will cover both Part A and Part B of their Medicare premiums, deductibles, coinsurance, and copayments. And so we have both of these categories within 2 of our plans. We then also have, for those 2 plans, the full benefit dual eligible, also known as the FBDE. These individuals might be eligible for a D-SNP plan based on categorical coverage, also might be medically needy, or they might achieve a special income status. So these might be individuals that are on the home and community-based waiver programs. And then for these individuals, Medicaid may cover their Medicare Part A and B premiums, as well as the deductibles, coinsurance, and copayments. These individuals are eligible for full Medicaid benefits. And so again, we have these individuals in the FBDE category and the 2 of our D-SNP plans. And then moving down to the last category there of the specified low-income Medicare beneficiary, or also known as SLIMB. For Sunflower, we have what is known as SLIMB Plus. So again, we have that for 2 of our D-SNP plans in the Kansas market. We have a 3rd D-SNP plan, and you may recall when we shared that earlier on the spreadsheet, it is actually a PPO, which is a preferred provider organization D-SNP. So for these individuals, they can actually access both in and out of network care, recognizing that maybe not all providers in the state of Kansas, they may not accept Medicare Advantage plans. And so we have created that PPO D-SNP. We believe we may be the only carrier that offers a PPO D-SNP. The table then that is right below those definitions, I wanted to provide that just as a visual to provide that definition maybe in a different way, to then highlight what those cost-sharing benefits are, both for Part A and Part B, as well as the Medicaid coverage. So if there's any questions, please let me know. If not, we can transition to the next slide. All right, so I believe there was a question that was posed around enrollment and adoption rates for individuals to select Medicare Advantage specific to the state of Kansas. And so I wanted to provide Kansas-specific data as well as some national trends. And so the information that's reflected here is based on September 2024 data. And so for Kansas, you'll see that around 580,000 individuals here in the state of Kansas have actually elected a Medicare Advantage plan, or are eligible for a Medicare Advantage plan, I apologize. Of those, 171,000 are actually enrolled, which is just shy of 30%. That, in comparison to national trend, is actually quite a bit lower, because nationally 54% of individuals actually select a Medicare Advantage plan. And so that first metric that I shared comes from CMS data. And then that last metric actually came from the Kaiser Family Foundation report that was published in August of this year.
We do have a question.
Sure.
Senator Gossage.
Thank you. Right here.
Oh, yes.
Thanks for bringing that up. So a couple of things. When we look at your map.
Oh, back on the first slide?
On the first slide. There are lots of companies that don't offer Medicare Advantage plans when you go farther west. So it's not surprising that we don't have as many as the national average would have. So I thought we should just point that out. It's not necessarily people don't want a Medicare Advantage plan, may not be available in their county.
Right, right. We recognize when we look at the potential enrollment rates, there are fewer individuals that are even eligible as you start to go out west. So thank you for that feedback. Any other questions on that first slide? If not, we can go back to slide 5. So looking at the chart here, I did want to share information around the enrollment rates as far as plan selection. So I mentioned that we have the PPO D-SNP for Sunflower. That happens to be the highest enrollment rate that we see here. This is Kansas-specific plan selection type, so at 38%, followed by member prevalence to select a HMO or a health maintenance organization at 36%, and then lastly, a D-SNP plan selection at 26%. I believe there was a question that was asked yesterday during the committee presentation with Christine Osterland around member education. And so we do a lot of education for Medicaid enrollees a full year in advance of them becoming eligible for Medicare Advantage plans. And we do that at 12 months, 9 months, 6 months, and then 3 months, and then right before their enrollment date to let them know of the availability of Medicare Advantage plans available to them, whether that's Medicare Advantage or even Original Medicare. And so I did want to share that with the committee here today, and of course try not to inundate those members as well. So if they decide to opt out of that communication, we notate that information in our system, and then we stop sending them that communication. I did provide slides around our benefits, which I know we covered that already, but I think it was in light of Senator Petrie, your questions around some of the additional benefits. We do not offer an emergency response for 2025, but we do provide acupuncture, podiatry, and chiropractic services as supplemental benefits. Was that somebody else's? I apologize for that. But I did want to call that out. Those were not on the issues log, but those are supplemental benefits that Sunflower does offer for all 3 of our D-SNP plans. So then we can skip the benefit slides and then transition into, I believe it's slide number 9. And this is in relation to questions the committee asked around the network and cost share. And we did provide several zip files to the committee around our network for our 3 D-SNP plans. You received those. Okay, thank you. And questions specifically around network adequacy requirements. So those are defined by CMS. And so a part of our annual plan filing requirements, we have to submit those reports to CMS as well to ensure that we meet network adequacy and remediate any concerns. And then we also provided information and a link to our Sunflower Health Plan Find a Provider tool. So if you have questions specifically around particular providers, that information can be accessed there. And then also wanted to highlight that for our Medicaid network, recognizing for our dual members that would be crossing over in our Medicare and Medicaid plan, we try to contract with anyone that's in our Medicaid network, also in the Medicare network. As far as the reimbursement rates, that is specific to our individual contracts, so we can't go into those specific details. However, we could provide just a high-level example of the reimbursement rate, or cost sharing rather. And so for our dual or Medicare beneficiaries, in general, reimbursement for Medicare Advantage would be at 80%, and then the Medicare enrollee would pay 20% for those covered services. And then in the situation for our D-SNP enrollees, that 20% cost share, they are protected so that they cannot be balanced billed by providers.
Question, and I'm not looking for specific billing. This 80, when you say 80% coverage of services, what does that mean?
So based on the contracted rate with that provider that's been negotiated for those services and benefits that the member's eligible for.
Yeah, so it's the percentage of the rate that, okay, that's what I wanted to understand. Senator Gossage.
How many MCO members do you have? How many members are Medicaid members are within the MCO of Sunflower?
How many Medicaid members do we have? Are you meaning just Medicaid, or are you talking Medicare?
I'm talking Medicaid, and then I'd also like to know D-SNP.
As far as Medicaid, we have about 137,000 currently.
Okay. And how many of them participate in the D-SNP program with Sunflower?
That are enrolled in both Medicare and Medicaid with Sunflower. I think it's around 700 currently. I'd have to go back and confirm that information.
Okay. My biggest concern with helping these folks, and I help them all the time, trying to figure out where I'm in Medicare, I just got into Medicare, I've been in Medicaid, but they always feel uncertain about their Medicaid status. And it's like, I think I'm still in Medicaid, well, I still have a card, but they're constantly feeling like they're going in and out of Medicaid. How do you guys help them with that?
Right, so our customer service line can certainly confirm their status as far as eligibility if they're enrolled in whichever particular plan. So they can validate that information. Our care managers can also validate that information for the consumer.
Thank you. Thank you, Madam Chair.
Are there other questions at this point? I guess one I thought of as the senator was talking is this next year, the feds are going to allow monthly changes. Is there some criteria to that monthly change?
There is, and I
Versus
actually,
quarterly?
if we go to slide 11, I have information.
We'll wait till we get there. That's
Oh, okay. So there's one slide in between that. So let's cover care management. I believe that was also a question, and then we can talk about those monthly plan changes and allowances. So there's a question around care management and what that looks like for D-SNP plans. Okay, and we've got that here. Okay, all right. So just in summary, so we really do aim to integrate the care model for our members that are enrolled both in our Medicare and Medicaid programs, really intended to improve that experience for both members and providers. We do this through a variety of different ways. We have what is known as a model of care, which really highlights those provisions that are required by CMS, outlining our care management model. It also highlights the training that's required for our staff as well as our providers. We complete a health risk screen for our members. We also look at the claims data that comes in, and through the combination of those those things, we then determine what level of support and acuity our members are in to then determine what type of care management they might need, whether that's physical case management, behavioral case management, or the support of a licensed social worker. We also work with the service providers in creating an integrated care plan. We invite those providers to be a part of that, as well as the member and their support team. I mentioned some of our members might be in a waiver program or even potentially long-term care. We invite those providers to be a part of that planning process and assessing what the supports are in the community and developing that plan of care. And then from there, the other thing, I wanted to mention, for all of our D-SNP members, they are enrolled in care management. So for our non-D-SNP members, it's really up to that member and their level of agreement to participate in care management. So we don't require that for members that are not in D-SNP because, again, we have members that might not be in the D-SNP program. I did want to call out for Plan Year 2025 an innovation that we are implementing based on member feedback, and that is a single ID card. I think based on a question just a moment ago, members have a question about what plan they're enrolled in. And for members that are aligned in both our Medicare and Medicaid plan, we will be introducing in the upcoming plan year a single ID card. Currently, members, when they go to their doctor or pharmacy, they have to present 2 different ID cards. I think that's common for many carriers. And to make it easier, we are introducing one ID card. So that is the ID card that they have to present when they go to their provider or to their pharmacy. Any questions related to that? If not, we can talk about the enrollment period changes that are up and coming.
Committee questions? Well, now, and if I think with what Christine told us this morning is that they can be a Sunflower client, but they could do, say, United's D-SNP, right? Okay.
They can.
Thank you.
All right, so the next 2 slides talk about the 2025 special election period or SEP changes. These are being mandated by CMS as a part of the final rule changes. And so I tried to break it out because there are different nuances depending on the full and partial benefit dual eligible individuals. And so these will be effective starting 1/1 of 2025, but right now we are in the middle of the annual election period, which launched October 15th and ends December 7th. So individuals are making their plan election changes now for the upcoming calendar year. And so for the individuals that are the full benefit duals or the FBDEs, those individuals will be able to make monthly plan election changes. Previously, it used to be quarterly, and that quarterly change is going away. And so moving forward, they can start making a monthly election change if they are in what is referred to as a highly integrated dual eligible plan. All of the D-SNP plans in the state of Kansas are considered highly integrated plans. And so that's important to note. And to make that plan change, they have to enroll into a D-SNP that is aligned with the Medicaid plan. So if they're with Sunflower, they have to select the D-SNP plan that we have that matches with Sunflower.
Okay, go over that one more time for me, because then that's a little contradictory, but there's a reason, and I didn't catch that.
So for members that are full benefit dual eligible, they will have to align their Medicaid and their Medicare plan choice moving forward during that monthly election change.
But not in open enrollment.
Not during open enrollment. So if they just make that annual change during open enrollment, it doesn't have to be aligned. But if they want to make the monthly change throughout the year, it will have to align.
Okay. Senator Gossage. Well,
That's okay.
kind of remembered that Christine mentioned something like that. I knew there was a caveat in there, and I couldn't figure out what it was. Go ahead.
So my question is then, CMS is saying you can change every month as a special enrollment period. So you're saying not really?
unless it's aligned.
Okay, thank you.
Senator Petty.
Thank you, Madam Chair. So if I'm a client and I'm dual eligible, then if I make my selection now before December 7th, I can be with Sunflower, but I could have other things with
United or Healthy Blue.
But if in March I want to make a change, I have to be, and I'm Sunflower's my primary provider, I have to choose with Sunflower.
Right, correct.
Okay. Thank you.
Got it. Thank you. All right, so the next slide talks about those that are considered partial dual or in the low income subsidy category and their qualifying SEP. So for these individuals, they either in a non-aligned or an aligned status, they have to make a plan election change during either the traditional Medicare Advantage period or during an annual enrollment period or initial coverage election period or another qualifying enrollment period. So they are limited. They can no longer do the quarterly change. Then to the right.
Comments? Okay.
Okay. Now for any, so for full or partial or LIS, they have the option to go from a Medicare Advantage plan. They can go back to original Medicare fee-for-service. So there is that caveat. If they want to eliminate their election under Medicare Advantage, they could elect to go to original Medicare. They have to ensure that they have credible drug coverage in that instance because we provide credible drug coverage when you select a Medicare Advantage plan. They have to ensure if they make that plan selection to drop Medicare Advantage coverage and pick up original Medicare, that they have the appropriate prescription drug coverage in that situation.
And when you say original Medicare, you're talking about going to the commercial side?
That would be original Medicare, red, white, and blue, fee-for-service.
Senator Gossage.
It's confusing to people because if you're in Medicare, you already have Parts A and B, and that is original Medicare. When they say go back to original Medicare, it's confusing seniors. They already have that. It's just removing the Medicare Advantage, in which case they may want to look at it, as you said, a standalone drug plan, but it depends on where they are in that Medicaid status. Because some of them, they don't have the LIS, they don't have their medication help to pay for their medications, in which case they'd have to get a standalone drug plan and then rely upon Medicaid to fill the holes that Medicare does not.
Yes, thank you for that. Mm-hmm. And I believe that should be my last slide. Are there any other questions?
I guess one of the things that we've been struggling with as we've been discussing about the dual eligibles is the low volume of clients that are on the Advantage plan. So is there a percentage of that 137 that would not qualify?
I hear somebody saying yes over my shoulder here.
Well, you can have someone step up if you've got someone else to help
I
share
think it's Andy
information.
back there.
I don't do everything all by myself, so.
So Andy Brown with KDADS, and I would just say that if 137 is your total membership,
Right.
not everybody is going to be a dual eligible or a partial dual eligible.
Well, that's what we're asking is what do we think that percentage is of that 137 that would be dual
And
eligible?
I don't know the percentage. But I
Okay.
know it's not going to be the full number.
Yeah, well, that I understand.
Okay.
But, because we're sitting here looking at Medicare's the first payer. Why didn't we want to get some of our tax dollars back and put that on the Medicare Advantage plan instead of on the Medicaid plan? We struggle with that. Because I haven't heard, from our last meeting to this meeting, really incentivizing people to get the D-SNP. I know you're shaking your head, but that doesn't tell me, why are we not incentivizing that? Why aren't we encouraging people to get the D-SNPs?
Well, so we have the SHIC program at KDADS, which is the Senior Health Insurance Counseling Program for Kansas, right? And that program allows individuals that are dual eligible to meet with a counselor who's a, non-biased counselor, right? that can basically talk to them about all the different available plans, right? And help them evaluate those and make a decision about what's the best fit for their diagnosis, their disability, the needs that they have, right? So that program is what we offer through the state to help people make these decisions.
But how do you know that that's what they're doing, Andy? And the reason I say that, because I can tell you that most of the counselors out there with SHIC hate Medicare Advantage plans.
Yeah.
Because a
I've
person
worked in
will
it.
have signed up for one, and they'll go and talk to them, and I can guarantee you, if someone in my office offered the same advice, they'd be in trouble for not having a license. And this has been a problem for years, and we haven't been able to stop it.
Yeah.
But they'll get them off of an Advantage and over into a SUP, but they haven't checked their meds, they haven't checked their providers or any of that kind of stuff. And I can tell you what, this next year, it is going to be hard because the reductions in these plans and what's happening with the drugs, the tier 3s and the tier 4s, yeah, there's a $2,000 cap, but guess what? That 3 and 4 is going to kick you in the behind.
Yeah.
So I hear you saying that they do that, but who is monitoring SHIC? Who makes sure that SHIC is doing what SHIC is supposed to do?
Yeah, so KDADS is over the SHIC program at the state level. At the federal level, it'd be through CMS.
But they don't come in and monitor them.
So they provide all the training, right?
Right.
We're verifying that the actual, hours are being put in and that the counselors are meeting those training requirements with the coordinators
So how do you guys monitor them?
through the Aging Commission. So the AAAs manage the project, right? They have the counselors. We're going out there and working with them. We have contracts in place that are reviewed and approved by CMS.
So it may be, so how do we know then that SHIC is encouraging people to do the D-SNP? Because there's no downside for this Medicaid client to have a D-SNP.
Right, so what we said is we're reviewing what their options are and providing that information to them. The client is the one that's making that decision, right?
And
The
then
individual
client
member.
goes and finds an agent.
They're welcome to go find the agent. There isn't anything that prohibits them from going to
that's
the
what the-
counselor or going to an agent.
Right, but SHIC can't sell them the product.
Correct.
So then you're saying that the individual then has to go find an agent.
Yes, that's correct. Because the SHIC counselor can't recommend one agent over another agent
Right,
or
I
one
understand
plan
that.
over
I'm
another
just-
plan.
Yeah, just trying to figure that piece out. But
Yep.
how do we know? And I guess, it's just, we've been in this since about 1993, 94.
Yep.
And I can tell you that people at the insurance department, employees of the insurance department over the years have faced the same thing with some of their family members that went into a SHIC office. So we know it's real. So how do we know that what they are telling these clients, these Medicaid clients, these are our vulnerable people. And you know that as well as any of us do.
Yeah.
And I want to see them to get the best care at the least cost.
Yeah. And I think that's what we try to demonstrate to them is this is a financial decision that you're making. These are the programs that are going to meet your needs in terms of prescription coverage, what doctors you like to see, those kinds of things. And if your doctors are out of network for a specific group, like that's not going to be a good plan for you.
Right.
You want to find a plan where your doctors are in network. So there's a lot that goes into that counseling session, right? But ultimately, we're telling people this is what a plan will cost you, right? As an individual, right? So the counselors aren't evaluating it based on whether or not it's a savings for the state or for the Medicaid program, right? They're looking at it based on what's the financial impact on that individual.
Well, and it should be about the individual.
Yeah.
You know, we're looking, I mean, we up here look at both sides. It's
Yep.
what's in the best interest of the state and then what's also in the best interest. And just looking at the extra benefits, the enhancements that the Advantage plans pay, you know, $250 a month in groceries.
Yeah.
That could be the difference between eating and not eating. Okay. I'll get off my soapbox.
All right.
I just step on your soapbox.
I didn't get to smack you around yet, so. Senator Gossage.
I'm just going to step back on her soapbox for just a second and echo, in the last 20 years, if I told you how many very, very bad advice was given, that I get the phone call that says, can you help my friend because they just went with what they were told was best for them. So I went to a SHIC meeting in Johnson County where they had all these it was just seniors. It wasn't necessarily you're Medicaid, you're not. It was just seniors who were invited in. And then all they did really look at was the Part D drug plan. Tell us your drugs. We're going to look those up. Okay, this looks like the best drug plan for you. But they didn't go into the medical part, other than they didn't look at Medicare Advantage plans at all, in which case you can get lower costs for your drugs sometimes, so it's very important to look at it. When I talked to whoever was in charge, I don't have the name, but the person who was in charge at the time, I was told, well, we aren't really trained on Medicare Advantage plans, so we don't talk about those very much, except to say I'd be careful if you were to take one of those. And I get it. I mean, I have to go through weeks and weeks, months of training, certifications, testing, in order to write Medicare Advantage plans every year. So I write both supplements, Part D drug plans, and the Medicare Advantage, and help folks in 25 states. It concerns me as well. I would be happy to come and visit with the folks who are the SHIC trainees and just have them share with me kind of what they are telling seniors. What are we doing? Perhaps we could do better. That's all, Andy.
Sure.
Thank you.
Any further questions or comments? All right, seeing none, thank you very much. Appreciate it. No, they don't have time limits. Did you want them to? Okay, Kim, if you would, where is Kim?
I'm right here. I'm virtual today.
All right, Kim, that's fine. If you wouldn't mind just holding on for a few minutes, because we kind of shifted our schedule around today, and I've got an individual that was supposed to be earlier that's now back in the room, and I'd like to go through his presentation real quick.
That's fine.
All right, thank you. Steve Anderson, you are up. You're always in this room, so for you to have to leave for a break, that was unusual.
I do apologize for that. I was
No,
actually
you're fine.
providing some training to the long-term care ombudsman's office and her people, and they were a very good audience. So I appreciate the consideration. Yeah, I'm Steve Anderson. I'm the Medicaid Inspector General. I appreciate the opportunity to be here this afternoon, as it turns out, and talk about the Office of Medicaid Inspector General, otherwise known as OMIG. Our webpage, along with the rest of the AG's office, is in the final stages of being updated. It's taken forever. There is a page for our office specifically on there that has a contact link for reporting suspected fraud, waste, and abuse and other illegal acts involving Medicaid, otherwise known as KanCare, Medican, and CHIP. It also has access to all of our annual reports, audit reports, as well as any abuse or any press releases and things like that. There's also a link on there if you want to request a presentation on fraud, waste, and abuse or anything else like that. I've briefed on this before, but just briefly or quickly, the number of complaints involving fraud, waste, and abuse involving the program, Medicaid program, continues to go up. We processed in calendar year 2023, 1,447 complaints. This year, we've already processed over 1,165 complaints, and we're going to have an estimated 1,500 complaints. There's a chart on page 2 that talks about that. Now, what I want to say is that, and I've pointed this out before, we have 9 staff members to do all of our investigations, reviews, and audits of this really important program. We could easily open an additional 200 investigations every year if we had the resources to do it. We just simply don't have the personnel. We've also identified numerous areas during our audit work planning session we recently completed that could be audited or reviewed that would result in additional savings, recoveries, waste identified, also improve effective and efficiency of the program. I want to point out the state of Kansas Medicaid program is over a $5.5 billion program when it's looked at in its entirety. Last year, on average, they served 467,440 beneficiaries. We also want to point out that, because this was asked last time, thus far, since calendar year 2021, our work has identified over almost $300 million in wasteful spending, $6.2 million in overpayments, and $24 million in potential savings. We've had 34 findings. We made 83 recommendations for improvement. Our operating budget for this coming year is $1 million. So the return on investment is substantial. We've requested additional funding via budget enhancement per the government office's request that will allow us to hire 3 additional staff members. I would appreciate the support of this committee in that endeavor. I do want to talk about, we have 2 performance audits that are being wrapped up. The active audit stage of both have been completed, and the draft reports are being prepared for review and comment. The first one involves prior authorizations in the Kansas Medicaid program. This is for people that are going into the ER, that are Medicaid recipients, and then dealing with the prior authorization process that is oftentimes delayed or stalled. And then when they're on their back end of that, when they're being discharged, trying to go to other sources of care, whether it's to a nursing home, rehab centers, or maybe even home with care, the delays and problems that happen with that. Our audit report will address all those very specifically. The second audit that we're wrapping up involves reimbursements for schools. The scope of the audit include all Medicaid enrolled students who had services billed on their behalf from a local education agency provider within the school-based programs. The state of Kansas spends over $25 million a year through fee-for-service, one of the few fee-for-service things that remain. Our preliminary finding, we found that a school district employee had obtained a national provider identifier number, otherwise known as an NPI number, that was used on claims submitted for payment for Medicaid services. The employee had no medical affiliation, had left employment at the school several years ago. However, the school continued to use that NPI number on claims. Over $390,000 in claims were submitted using that invalid NPI number and were paid for by the state of Kansas. It should be noted on the NPI registry, because we've checked, that it says, a quote, issuance of an NPI does not ensure or validate that the healthcare provider is licensed or credentialed. We've talked to other people. Turns out that they do nothing to verify the identity or background or credentialing of the person requesting the NPI number. CMS is the ones that overlords this program. All right? So this audit plus prior work that we had done on the COVID-19 test kit claims identified that as a very interesting issue. If you recall, I've reported on this before, but we did a review of COVID-19 test kits. We found that 11 of the providers billed for 32% of the kits that were billed. 9 of them were registered for their NPI number after March 2020. And if you need a reminder, that's when PHE started. And were likely fictitious companies. Thankfully, Medicaid didn't pay a dime on those claims. Medicare paid almost $1 million out just here in the state of Kansas on those fictitious claims. Our research found that the CMS, like I said, does nothing to check those credentials. We plan to do a test and do a review of NPI numbers being used here in the state of Kansas that may be false or fictitious. After this was written, we found out about an individual who was a science teacher at a school. I won't disclose the school right now, but got his own NPI number and actually managed to get himself a script for prednisone based upon using the phony NPI number that he had gotten. So we're going to be looking at that as well. I want to just talk about briefly a quick example of an open investigation involving Medicaid beneficiary. This person's in a long-term care facility, no longer has decision-making capability. She received an inheritance of over $180,000. A relative with the power of attorney for financial decisions redirected the inheritance check to a bank account that she had opened under her own name. When the nursing home that found out about it, they advised the power of attorney, hey, you're going to have to do the spend down. That money needs to be deposited. She immediately removed her loved one out of that nursing home and into another nursing home that knew nothing about the inheritance. So then when she got the money, she proceeded to go on a spending spree and spent $46,000 of that money within a 2-week period. Naturally got the attention of the bank. They got concerned about opening that account. They froze the account, put a check out there for $140,000 as a cashier check. We have that check in our evidence room right now. And our investigation is going in to see if we can do anything to recover the other money. We know that she went on a luxurious trip. She also went to a jewelry store and bought some expensive jewelry, and also went to the phone store and bought apparently some new phones, but really blew the money. So that's just an example of a case that we're involved in. I appreciate your time this afternoon. If you have any questions, I'd be more than happy to answer them. I know everything's kind of crowded right now. And then obviously, if you have any suggestions for audits or reviews for us or investigations, I'd be delighted to hear them.
All right, thank you. Questions for Steve? Senator Fagg.
Thank you, Madam Chairman, and thank you for your presentation, Steve.
Thank you, sir.
You asked in the budget for 3 new FTEs. My question, why didn't you ask for twice that?
That's what the Attorney General requested on behalf of my office.
Okay. Could you handle more if we come up with it? I mean, that's the most cost-effective thing I can think we can do is
Yes,
chase
sir.
that kind of thing, and you showed the numbers that says this is cost-effective, so.
Yes, sir. Yeah, we could handle more if we had them.
Okay, thank you.
Further questions, comments? Senator Petty.
Stephen, so you share with us that you identified $299 million with the spending. Sorry, Stephen.
I could hear you.
Okay. And overpayment, and then 6 million overpayments, and then 24 million is potential savings. So but I want to know how much has your office actually recovered?
We recovered, in one instance, $1.6 million as a result of our audit work where they stopped the payments, and that was a hard savings. We have the same problem that's always been is we don't have the power to recover money. That's left up to the agencies. All we can do is point them to, hey, you could recover this. If they don't do it, I can't make them do it. That's something we lack that authority to do, nor should we have that authority. So as far as the savings go, it's the same thing. For example, one issue that we pointed out is the state could save $8 million by changing life alert bracelets from being a MCO paid or covered thing and move it to a fee for service. It would save $8 million. They opted not to take us up on that. It would be a relatively simple thing to do, but they chose not to do it. Again, it was a savings that could have been had. I will say this with the CCRC thing and the conversion over to having KDADs oversight that's going to save the state of Kansas $12 million a year. That's part of that calculation. That's a legitimate savings. We identified, the state made that change. They will save $12 million this year on state general funds because of that change.
And how many staff members have we added to your office over the last 3 years?
When I took over the office in April of 2021, we were a staff of 3. We were up to a staff of 9. I want to also remind that a year ago, I got 2 special agents and an analyst for doing eligibility investigations. Prior to that, we had 0. Nobody had been doing eligibility investigations in the state of Kansas since 2014, and there was nobody doing them. And I was able to get a couple of people to do it. I could have used more people then and need more people now to do those investigations. We've opened up over 100 investigations this year alone on eligibility stuff, and I personally scan every eligibility referral that comes through our office, and I can tell you I have to overlook numerous examples that are blatant fraud of people that are lying about their income, lying about their residency. Kansas Medicaid's a great product. People move to other states, they want to hang on to their KanCare instead of taking up Missouri or Oklahoma's version of it because the benefits are better. So they stay with it, but they move out of state. State moved out of state, some people 3 or 4 years, but yet they hang on to KanCare. Those are people who should be cut off the system. They should have to pay that money back because they shouldn't be drawing KanCare. So there's case after case after case like that we'd like to be able to do something about, and we just simply can't.
Well, and unfortunately for years, we've talked about fraud in the Medicaid system, and we have a lot of people up here that are in denial that that actually exists, and we know it does because we know other states that have had studies done and have recovered some of that. Senator Fagg, did you?
Thank you, Madam Chairman. When you mentioned that you point this to the agency and there isn't anything, do they ever report back to you if they do? Because I'd be interested in the reports to make sure that they're doing something about it.
They don't, in their audit report and their response, they provide a thing saying we're choosing not to do this because of this issue, or we'd have to change this statute, or we'd have to move money around, or there's various reasons. I will submit this, that some of those things, we have there's different leadership like at KDHE now, and I think they're more receptive to suggestions, and I'm looking forward to dealing with them in the future.
Representative Reese.
Thank you, Stephen. So the salaries for the three more staff that you're, what kind of salaries are we looking at?
The average salary is around, it's in the mid-50s.
Okay.
And then there's benefits on top of that. So not a terribly expensive people to have on staff.
And so your budget is directly in the AG's budget?
We're a separate line item.
You're a separate line item?
Yes, ma'am.
Oh, okay. That's
If
what
you
I
look
need to
under
know.
the AG, you'll see it, then right below it'll say Medicaid Inspector General.
Okay. So the AG couldn't do some wiggling around
No, actually,
with his budget to,
I can spend his money, he can't spend mine.
okay.
I actually get an amusement out of the fact that I can take their money, but they can't use my money.
Well, how can you take your money, their money, and put it in your,
They're able to transfer funds if we're short, but they can't take money from my account if they're short.
okay, thank you.
That's a great deal.
Other questions or comments? Steve, I guess the question that I would have is there anything that would prevent you from providing us a report of all the things that you report to the agency?
Not at
By
all.
line item?
I send copies of my audit reports to the Bethell Committee. And of course, my annual report then summarizes all of that on an annual basis, and I know I sent that.
And is that like in a line item that, let's say KDHE, and it has, I'm going to say Representative Ballard on there, but does it go by amounts and names, or how is that laid out?
It's laid out on the audits. We actually do a summary of the audit, and then what our number of findings and any amounts that we identify as savings or recoveries in that. And again, our website has all that information in there, but I'd be more than happy to break something out for the committee if they'd like it that way.
Well, I'm just thinking, and when we get to our recommendations, that it would be good for us to have an isolated report, because sometimes it's really hard, depending upon what has come into us, to get through all of the stuff that
Sure, and you're doing that today, aren't you?
yes, we are. So I appreciate that. Any further questions or comments? Senator Fagg.
Thank you, Madam Chairman. When you do your audits, what percentage of coverage do you think you have, Stephen? You know, because you don't cover them all. So
No.
the question is, what kind of coverage do you have?
Well, that's the thing is, right now, we have over 50 issues on our audit plan that could be audited today. And so far, I have 2 somewhat experienced auditors and 1 very inexperienced auditor. So she's currently working with one of the more experienced auditors to get trained up. And if we had additional staffing, we could have more experienced auditors to cover it. I look at other audit offices like the post-legislative audit, they got several auditors and they're able to do more. And sometimes it's beneficial, like on this audit that we're doing of the Medicaid reimbursements. That's an audit you'd normally have 4 or 5 people assigned to, not 1.5 people assigned to. So it makes it very difficult for us. And one of the things that hurt us on that audit is we lost an auditor. She left our agency and I had to put somebody else on it and they had to come up the learning process. So it makes it very difficult.
Senator Gossage.
I guess it begs the question, are there any internal audits within the Medicaid department?
Well, our audits are of KDHE's operations, KDAD's operations. We do those type of things. We don't, like the PERM audit you heard about yesterday, we don't touch that because the feds do that. But the feds audits are very narrowly focused, and they do the same audit on a regular basis. Our audits are more of, if we identify an issue, we go look at it. So we audit areas that have not been audited in the past.
So I guess then I'll restate my question. Is there anybody within that department, the KDHE department, that is auditing and then can report things to you for you to, hey, you know, we have a concern about this. Could you look deeper into this?
Sure. That can happen and does happen. The MCO audit, I'll bring it up again. We were specifically asked to look at that by Secretary Stanek. She was concerned about it. She knew that she didn't have the right people to do that and knew that we would be able to handle that audit. So yes, that was an example of that where we get, I mean, this very legislature's asked us to audit matters as well.
Right. All right. Thank you very much.
Any further questions for Steve? All right, thank you very much, and we appreciate you letting us move you down the line.
I appreciate your accommodating me. Thank you.
Thank you. All right, now we'll get back on the path that we were at. And I have Kim Manning, who's with United Healthcare, coming in virtually. Welcome, Kim, and thank you for being patient with us.
Thank you, Madam Chair and committee members. Next slide. So for our D-SNP product, of which we call Dual Complete, I think all of you are well aware that it is a Medicare Advantage plan for individuals who have both Medicare and Medicaid. And while D-SNPs are like Medicare Advantage plans, there are special things that we offer in addition for these individuals based upon their income and then special needs that they have. Much of that is under what is called the categories, and UnitedHealthcare carries 3 categories within our 2 HMO plans. We take the QIMBYs, as the acronym says, which is our qualified Medicare beneficiaries, and we take the QIMBY pluses. We take the full beneficiaries, and we also take care of the SLIMBYs, which is also known as specified low-income Medicare beneficiaries. And then all of our D-SNPs do offer a prescription drug plan in the supplemental benefits, but the main components for Medicare is, you know, acute care visits, physician office, skilled nursing facilities, acute home care services, durable medical equipment, for example, wheelchairs, and then, as I said, Part D drug plan. Where the Medicaid benefit comes into play as sort of the secondary payer, it's really payment of Medicare premiums, payment of Medicare cost sharing, LTC waivers, long-term home care, and then other acute care needs and drugs that may come into play. Next slide. Earlier this afternoon, I did go through UnitedHealthcare's supplemental benefits for our 2 HMOs. So I won't go through that today in this presentation. And then for the next slide, I did walk through the benefits of our innovation with our U-Card. Looking back on some of the questions earlier to Sunflower, we have 142,000 Medicaid members. Of those, we also have 12,415 D-SNP members. 6,822 of those members are aligned to us, so they have our Medicaid and our Medicare. Of our full Medicaid membership, about 10%, 15,000, would be eligible for a D-SNP plan. And those are categories that many of you have heard. It's the
Kim?
age, blind, and disabled.
Kim?
Correct, yes.
Kim? We were having trouble hearing. Could you start back with your beginning numbers of your Medicaid clients and go down from there again for us?
Yes, so we have
Please.
142,000 Medicaid members.
Okay.
We have 12,415 D-SNP members. And of those members, approximately 6,800 of them have both our Medicare and our Medicaid. Of our 142,000 members, approximately 10% would qualify for a D-SNP, which is about 15,000 members. And that would be under a couple of categories. What we call ABD, which is the age, blind, and disabled category. Our LTC, long-term care services. And then there are some children with disabilities that fit into that 15,000. Currently, right now, of our 12,000 plus members, 47% are under 65. 53% are over 65. So it's, there sometimes is some confusion that a D-SNP plan is just for those turning 65. There's a fair number of populations that would benefit from the additional services of a D-SNP plan that are under 65, and some of them are children.
I just don't think that, when people think Medicare, they just don't think about the kids. And that's the thing that we've discovered getting this through this process. It's not age limited, so.
Correct.
Thank you.
There was an earlier question that was sent to the health plans around what we called service area, or what are the counties that we cover in Kansas. So in 2027, UnitedHealthcare first offered a D-SNP plan in 3 counties: Wyandotte, Johnson, and Sedgwick. Each year following, we have added counties to our service area. Currently, going into 2025, we are in 69 counties. So we have 36 counties that we are not in of Kansas, total of 105 counties.
Would you mind, Kim, providing a map? I think, sometimes for us, the visuals are stand out more for us because of all the verbiage that we read all day long.
I will. It was in my our last meeting that we presented to the committee and to you, Madam Chair, but I will forward that to you and the committee following this meeting.
All right, thank you.
Any questions?
Committee, are there questions or comments? Senator Gossage.
Thank you very much for this information. Can you tell me how actively United seeks out to educate those who have a United or they're part of the United MCO, explaining to them the D-SNP? You're pretty active with that, right?
Yeah, so before they turn 65, we do begin to educate our members that there is a availability beyond just traditional fee-for-service Medicare, that there is another product that they would be eligible for, and we provide them information on those particular plans.
And the ones that are under 65, because if you're disabled for after 24 months and then you're eligible for Medicare, then when you know that they have the disability, do you start reaching out to them as well? Because I've heard that United is very active with that.
Yes, we do. Many times it's the family members or a guardian that may ask the questions in regards to, is there anything additional I could receive? And when they ask those questions, we can begin to share that there is other options for members, particularly when there's some gaps in terms of things that are not offered. For example, with the supplemental benefits, they're really designed to really fill the gaps of things that members have needs for: food, dental care, hearing, vision. And so once they learn that there is those available supplemental benefits, I think that's when they begin to want to sit down with someone and learn more details on what this plan has to offer. You know, it truly is, sometimes I call out as a plan that's really trying to follow a mission of helping those that are very, very vulnerable in our communities.
Thank you. Thank you, Madam Chair.
Further comments, questions? All right, seeing none, thank you very much, Kim. I appreciate it.
Thank you.
Next, we have Brian Baer, Plan President, Healthy Blue, Kansas. Welcome to committee, Brian.
Thank you.
It's been a while.
Yeah, good afternoon, Madam Chairman. It's my first meeting here with Bob Bethell Committee, and sad that it's going to be your last. So we'll have the overlap of this one meeting. I'm Brian Baer. I'm the Plan President for Healthy Blue of Kansas. For those of you I haven't met, I'm a fifth-generation Kansan. I was born in Hayes and graduated right here from Topeka High. So I've had both local, regional, and national roles in Medicaid managed care for the last 25 years. So really delighted to be back here in Kansas. And I think I have I'm not a D-SNP expert, so I think I have a phone a friend who may be joining us.
Awesome. Thank you, Brian.
Yeah. Jeff?
Yeah, wonderful. Yes. Good afternoon, Madam Chair, fellow committee members. My name is Jeffrey Jones. I'm the Vice President of Duals, serving Healthy Blue and Elevance Health. By way of a very, very brief background, I am an honorable veteran of the United States Marine Corps, and I've had the pleasure of exclusively serving Medicaid and dual eligible members for over 27 years. Thank you for the opportunity to participate today.
So we do have a deck, so we can start with that if you like.
Okay.
And I'll just tell you, the Healthy Blue is an alliance between Elevance Health nationally and then two local Blue Cross plans, Blue Cross Blue Shield of Kansas City, Blue Cross Blue Shield of Kansas. Together, they each have 80 years of experience in the state and insure currently through one of their products over 1 million Kansans. So, and we know there's roughly 3 million Kansans, so 1 out of every 3 Kansans get their coverage through Blue Cross Blue Shield product at this time. Elevance Health is our national partner. Currently, they are the largest provider of Medicaid LTSS services in the country, with roughly 500,000 LTSS members in their Medicaid products across 20 states. They also have just under 1 million dual eligibles across their Medicare Advantage and Medicaid lines. About half of those are in a D-SNP product, which makes them the third largest D-SNP provider in the nation. So when we came to the state, our slogan was local roots, national experience. I think that's really what we provide to the state of Kansas. Really looking forward to getting involved in the program. But specifically on D-SNP, we go to the first slide. Maybe. It's a PowerPoint, and I can just talk through
Oh,
too.
we're getting it.
You guys have seen enough PowerPoints on D-SNP. You probably have them memorized by now. So we all know duals are a vulnerable population. About 40% of the duals have 3 or more chronic conditions, so like hypertension, diabetes, asthma, so make them sicker than average, even for the Medicaid population. About 40% of duals have 3 or more difficulties with ADLs or activities of daily living, so bathing, putting on clothes, and then they're more likely than not to have a social functional issue such as health literacy deficiency or transportation issues, housing insecurity, or food inadequacy. So we're dealing with a very vulnerable population that does need a special product, and that's what D-SNP provides. So here you can see on the first slide here, questions you asked the committee, and so each of the slides will try and touch on each one of these. But just in general, that's what the population looks like. And Healthy Blue's approach is dedicated to providing a comprehensive care coordination to these vulnerable members using specifically tailored benefits, care coordination, and targeted services to help bring them integrated service, which will improve outcomes. Also, maybe just as important, reduce administrative complexity for the member and the provider. So we can go to the next slide here. Who's my slide? Okay, let's go to the next slide. Great. Oh, we missed one. Can you go back one? So just in large scope, the value of D-SNP, and you've heard this from the other companies, but it's really to provide value to the member, primarily reducing their cost share. So getting rid of the cost share that they typically see in Part A and Part B and Medicare. Also providing a drug benefit is usually included. We will do that here in Kansas. But also important is the additional care coordination they get by joining a D-SNP plan. When they join the D-SNP plan, they're going to get an HRA, they're going to get a care coordination team, they're going to get an individual care plan, they're going to get individualized attention that they normally wouldn't get in either a Medicare Advantage plan or normal Medicaid plan. All right, go to the next one. We are offering an HMO here in the state of Kansas. We chose an HMO really for ease of administration for the member. When you do an HMO, you're just in network, so you don't have tiered benefits. You're not having to collect a copay from a member who may not be able to pay a copay if they went out of network. So all services will be in network. That also allows us to have providers that are tailored to providing these services to the special population. All right, moving to care coordination. Care coordination, we talked a little bit about this. Being a local Medicaid plan, we're going to have a large staff here in the state of Kansas. Some of them are field-based, some will be here in Topeka, some in Johnson County. But they'll be across the state, and we can leverage those for the D-SNP population. So we'll have the community health workers and the care coordination staff will be able to assist with our dual populations. They'll provide that initial health risk assessment. They'll get their own single point of contact care coordinator that they can call with questions about their conditions or how to get help. And then they'll get their individualized care plan. That's something we're going to be able to do by leveraging the large staff we're going to have here for Medicaid. We'll use that same staff for the D-SNP issues. Here's a wheel, just kind of a visual of what that member journey will look like once they join Healthy Blue. You'll come in through the sales engine, which could be any number of avenues. It could be a social worker, could be one of our community health workers, could be a broker, but learn that they're eligible for additional benefits and get enrolled in the D-SNP. Then we'll help them through and assist them through enrollment, get them a health risk assessment to find out their conditions, find out if they're eligible for new programs, community benefits, other items that they may not be aware they're eligible for. We'll assign them a care coordinator and then get them an individual care plan. And throughout this entire process, really what we're trying to do is make it administratively easier for that member to get benefits they're eligible for and also improve their health outcomes. One thing we do at the end there is we do have an annual wellness check just to help make sure that all their conditions are being met, also help educate them on health literacy. So what we really want to do is we want to educate, empower, and engage that member. So those are really the 3 E's we look to get them involved in their own health care as much as possible. Our footprint, this kind of looks like the maps of some of the other companies, but you heard United say their first year they were in 3 counties. Our first year we're going to be in 47, leveraging the local partnership with our 2 Blues partners, able to come out with a strong footprint in year 1. These 47 counties represent about 72% of the state's eligible duals, and our goal is to go statewide. Hopefully within 2 years, but really depend on the ability to build out that network. But the goal is to have by plan year 2026 a statewide offering. Here are the additional benefits. Similar to what you've heard from the other plans, we do have a benefit that's tailored to this population. We know the dual population tends to be more frail. We also know Kansas dual members tend to be older. So we do have strong vision, dental, and hearing benefits, which this population is more likely to access and use than others. But we also have a lot of those additional benefits built in to help them not just only with their physical and behavioral health needs, but maybe their social needs. If you go to the next slide here. So they do get a $200 a month allowance that they can use on any one of these 4 services. So they can use that for groceries, over-the-counter drugs, utility bills, and other assistive devices to help them, since a lot of them need help with activity, with their annual daily activities of daily living. All right, that's good. So then in summary, just, our plan here is to leverage that local Medicaid plan and provide those services to the member. Really, our goal is to make it more administrative simple for them, to improve their outcomes, and make it community focused so that they are leveraging all those community benefits that they may not be aware of, and make sure that they have that integrated plan that takes care of all their needs. I think that's it, yeah.
Committee questions, comments for Brian? Brian, just looking at your map there, what's going on down there in that southeast corner?
That'll be year 2. But the focus really was to try and get as many counties as we could to hit the largest amount of population as we could. So really went down that I-35 corridor and I-70 to Salina was where we focused. We got about 6% of the states down in that bottom 9 counties, so that'll definitely be a focus for year 2.
What happened to Saline County?
Well, we're working on the network in Salina.
Okay. Senator Gossage.
A quick question for you, and thank you for this presentation. I'm actually impressed that in such a short period of time you were able to put together a D-SNP that is certainly suitable and competitive. So the question that I have is, could you just explain in general for folks that don't know, if I'm going to go to a provider and I'm a dual eligible individual, it's not a matter of whether they take Medicare, it's a matter of if they take Medicaid, correct?
I don't know for a fact that's true, but yeah, anecdotally, that's what we hear.
So if I'm in Medicaid, I need to find a Medicaid provider. Whether I'm in dual eligible, whether I'm in a D-SNP or not, they have to be someone. So in your provider network, for the Healthy Blue, you're looking for providers that would be willing to contract, that would accept the MCO contract for Medicaid,
Certainly.
correct?
Certainly, yep, correct.
All right, thank you.
Committee, further questions? All right. Did we go through your numbers on
We have not yet.
your, oh, no, because you guys don't have open enrollment until November 1, correct?
And I believe we're in open enrollment now.
For Medicaid?
Oh, sorry, for for dual SNP, for D-SNP. No, yeah, Medicare's not started, Medicaid has not started yet.
Okay, all right. I'm sorry. I didn't tell you which one I was referring to. Yeah, I guess I'm just a little bit concerned when I take and look at this map and I'm looking at Reno, Rice, Saline, Cloud, Nemaha.
I would have loved to have been in all 105 on day 1.
Well, no one's going to be in 105, and we know that, and that's not the problem. And we know that we can almost draw a line right down the middle of the state and tell you where they're going to be, and they're going to be east for the most part. And that's just the nature of the beast. So that has nothing to do with with an MCO. It's not a negative against the MCO. It's just when you see these big gaps in areas, because I know down there in that southeast, it's just that's a big populated area.
Yes, and you got to recall, we built the network before we won the Medicaid bid. So a lot of providers won't discuss the contract with you until you've actually won the Medicaid business. So this was all built prior to having won the Medicaid bid, which made it a little more difficult. So I'm pretty proud of the fact we were able to get in 47 prior to submitting that bid. And the 2 Blues plans are in 105 counties for the Affordable Care Act. So I'm hopeful we can leverage that success and bring that to Medicaid as well and be in all 105. Even though I know some of those western counties are very difficult, that is the goal.
Okay. And, I was kind of surprised when I started looking at the folks that are signed up on your D-SNP side, and we're missing one of the biggest hospitals in Wichita. Why is that?
Like I said, we had, about 3-4 months to build the network. Before we had to submit that to CMS. So we're continuing to build it, and we'll fill out that network as we go.
And I'll just be upfront with you, Brian. I think one of our concerns is I think the negotiations in this area is different than the commercial side. Yeah. And I have a good understanding of the negotiations on the commercial side for Blue Cross. And if you try to apply it to here, these gaps are going to continue, and they're likely to grow. And that's not going to be a positive from the state perspective because Aetna had, 167,000?
I think so.
Something like that, clients that could very possibly come over to you, and you're not going to be able to provide them providers, and that's concerning to us.
Yeah, no, we're definitely putting a lot of focus on building that network. As you heard yesterday, we're at 33,000 just on the physical health side. Right. Ahead of the benchmarks. That will continue to grow every week between now and go live. And, quite honestly, we'll take any provider that'll accept Medicaid. So really, we're beginning those negotiations. We'd be happy to have every provider in the state in the network.
Yeah, that's right, Brian. And, Brian, I would just add, Madam Chair, that we are still building. Building is every single day. We are focused on expanding our network as quickly as possible across the state. Because we don't have them today doesn't mean we won't have them tomorrow or next week. And so we will stay laser focused on our network development build here with a special emphasis on ensuring we're maximizing overlap between the Medicaid and the Medicare provider network to ensure we can service our duals most effectively.
All right, committee, further questions, comments? Anyone? Are you good, Beverly? All right. Appreciate it, Brian. Welcome to the process here in Kansas. And, I'm sure there'll be hiccups along the way. There always is in the transition process. And what I would ask of you, because we know the hiccups that Aetna went through when they got in here, is just stand up and say, we've had them. Now we got the right team here, and we'll fix them. As long as you play up straight with us, which I think that you will. I don't have any doubt in that. But it's just kind of something now that we dealt with the AmeriGroup deal that we don't ever want to see that happen again, because that's going to be a major problem in Kansas. So,
yep. Thank you,
all right,
Madam Chairman.
welcome to the process.
Thank you.
All right, committee. That's it. It's what?
Aetna virtual.
Oh, we've got a virtual. Oh, I'm sorry. Angelica Hughes with Executive Director, Chief Duals Officer, Aetna. Are you with us?
Hi, Madam Chair. Can you hear me?
I can. Thank you.
Perfect. Thank you, Madam Chair and members of the committee. I appreciate your time again. Again, this is Angelique Hughes, Chief Duals Officer of Aetna's D-SNP programs across our Mid-America and West Territories. And what I would like to present today, first of all, is follow up to a question that the committee posed during our August 27th committee meeting regarding turnover of Aetna members. In addition, we did receive the committee's request for D-SNP network provider participation volumes. So I will share that. And I'm also here to answer additional questions that you may have for D-SNP. We do have a presentation. I will say most of the information is similar to what has already been shared today. A lot of the information, the majority actually, is what we did present in our August 27th meeting. But you should have that information with you today. And I'll pick out a few slides for just to highlight some of the information that I was listening to today that I think might help to provide some additional context to some of today's conversation. So we can move to the presentation and go to slide 1. Is there someone in the room operating the presentation for Aetna?
Yes, they're working on it. You
Okay.
can actually go ahead because we have it in front of us on our computers.
Perfect. Okay. It looks like you have it up. Can you go backwards actually to slide 1? Perfect. Okay. Thank you. Okay, next slide, please. Thanks. So this is our response to the question about Aetna turnover. What we were able to provide is volumes of Aetna members at the end of December 2023 versus membership through the end of September 2024. So as you can see, at the end of 2023, we had roughly 7,800 members. At the end of September, we had roughly 11,000 members. Now, internally, I just want to share a disclaimer. Internally, we do have specific data that would show specific member longevity, right? So if member Mr. Brown began our program in 2019 and he stayed with us through 2023, for example, we have information that would track how long our members have been with us. Unfortunately, because we researched and saw that that's not information that would be publicly available, for example, through the Centers for Medicare and Medicaid Services, we did not feel comfortable sharing that information because no one externally would be able to verify the accuracy of our data. So for that reason, that's why you're not seeing specifically turnover data, but just membership growth instead. Are there any questions regarding our membership growth this year?
No, we're fine. And I think, Angelica, if we can kind of just hit some of the highlights with what you've got instead of just going through the whole presentation, that would be awesome.
Sure. Okay.
Thank
Well, let's advance then to slide 21. Just want to talk a bit about growth a little bit more, and it will somewhat, it should address a question, Madam Chair, I believe that you had earlier for one of the plans. There we go. Just regarding, there we go, D-SNP membership, just regarding why aren't more people enrolled in D-SNP? And if we look at this, what this is showing is D-SNP growth from a plan's inception through current, right? So we see that United has been in the game the longest, since 2017. Aetna's in purple, and we have Sunflower in blue. But what's encouraging about this, for example, if you look at where D-SNP volumes were in 2017 with United, for example, versus where they are today. And then Aetna entered the game in 2019, right? We had about 699 members versus, these numbers are outdated, we've got just over 11,000 today. What it is showing is that D-SNPs are becoming more and more popular because we do see this surge in membership growth. I think what could further facilitate growth, because there's about roughly 33% penetration for D-SNPs in Kansas right now, is a matter of approaches taken to educate Kansans about the benefits, right? D-SNPs are very grassroots plans, meaning it really would behooves organizations, right, to have strong alliances with community organizations and those who are really there on a consistent basis, working with dual eligibles who individuals trust, right? And once you strengthen that relationship with that community organization, and they see that that D-SNP is a reliable and trustworthy organization, they then can feel comfortable in spreading the word about D-SNP. And that is one of the paths used to increase D-SNP growth. So that's just one of the ways that more evangelism of D-SNPs takes place. There's also other paths as well, but it's really letting folks know that the plan is available and how it does help meet a lot of their needs. I will also say, it's not on this slide, but just in response to the question about D-SNP network, right? So D-SNP is a Medicare Advantage plan, which means if you're a Medicaid beneficiary, and let's say you have Aetna D-SNP, you can go to any Aetna provider our Medicare Advantage provider, since D-SNP is Medicare Advantage, and that provider has to accept you. That provider does not have to be a Medicaid provider. What's going to happen is that provider should render services to that patient. The provider will then bill that D-SNP organization. Aetna would then send a provider a explanation of payment, and the provider would see how Aetna paid the claim, and then would see if there's any remaining cost shares. So for example, for a non-D-SNP plan, that provider might normally bill the member $25 for an office visit, but that's not allowed with our D-SNP. So at that point, it is the provider's responsibility to submit that claim to state Medicaid for additional payment consideration, and that's how the payment is resolved. So that member at no point has to have gone to a Medicaid provider, but they can go to that Medicare Advantage provider, but then the Medicare Advantage provider, if they want additional payment, must bill Medicaid for that additional payment. Are there any questions regarding that?
Nope, I think we're good. Thank you.
Okay. And lastly, we can go to slide 17. I heard other plans talking about the care team, and this is something that we did not touch upon in August during our meeting. So this is just a real one-stop shop, just showing Aetna's care team. We do have 100% care management, meaning all of our members are assigned to a care team, regardless of their risk stratification. So whether they're a high tier tier 3 member that has the most unstable and vulnerable needs, or whether they're a medium tier 2 member that has some unstable needs, or whether they're our most stable member, which would be tier 1. All of our members are assigned to a care manager. And this slide just shows the assistance, the support that our care team does provide our members. In addition, all of our care team staff help form an interdisciplinary care team that goes over the needs of each of the members. So we do have a holistic approach. And lastly, just to speak to, and I don't have a slide for this, but just to speak to the request that we did receive from the committee regarding network participation. For our Kansas D-SNP, we have roughly 15,700 providers that we track for network adequacy. So that number does not include our behavioral health specialists, our dental providers, but when we're looking at primary care physicians, internal medicine providers, for example, and specialists, for that alone, we have about 15,700. And then in addition, Aetna has interstate reciprocity. And what that means is we have about 8,000 providers in the state of Missouri that we allow our Kansas D-SNP members to see, and they are still considered as in-network. So that just provides some additional flexibility for our members when they can leave the state if they would like to see some additional providers. And I will end there for today and answer any questions if there are any.
All right, thank you very much, Angelica. Are there questions or comments for her? All right, seeing none, thank you very much for being here with us today.
You're welcome, thank you.
Okay, committee, now we are done with that, and it's time for us to make our recommendations. And I know as we've gone along through this process the last couple of days, we've kind of alluded to some different things for our staff. And if it's all right with the committee, I'll start off with some of that I have on my list, and then we'll hit each one of you of recommendations that you have. The first would be to recommend that the appropriate agencies, which if I understood it correctly, would be KDHE on the GME, is that right? Or was that KDADS? Was that KDHE that we had to make the recommendation to, Andy?
I think KDHE would be.
Right, okay. I just left that off my notes for the MHIT program, or the Behavioral Center for Excellence program. And it sounds like that's already in the work, and I'm very happy to hear that the secretaries and Christine are working with them on it. Yes, Representative Concanon?
What is your recommendation?
That we recommend that KDHE work on the GME program for the behavioral excellence of mental health excellence. Yes, Senator Gossage.
So the recommendation from this committee would be that they start looking at that for us. It's not, we're not authorizing them to do anything or budgeting anything, just to clarify.
No, we are telling them, or suggesting to them that we highly recommend that they put this program into place. Because what we did this last year at $5.7 million is, that's how we funded the Behavioral Center for Excellence, all SGF. And as you heard Kyle Kessler talk about, is that he learned that they have the ability then to pick up GME money, which would be all federal. So hopefully we can switch to being able to fund it more with those federal dollars versus our SGF dollars. So we would be asking them to do that. Is there a concern? Okay.
I guess my concern would be anytime we're asking them to do something, it would be more, would they report back to us? They've looked into that. Yes, indeed. We have these federal dollars, et cetera. So I would say report back. That would be my recommendation, rather than say do it.
I guess I'd like to have a stronger position on it because we see the benefit, or we wouldn't have funded it last year with all SGF, because there's a lot of programs that we did turn down on an SGF side, and we don't want to see any loss in momentum. This will take a while, and Andy, if you can help me out a little bit. I mean, we're probably looking at, what, a year out before maybe something like that would get approved, maybe through that process, or, and I know I'm putting you on the spot, I just don't see Kyle out here.
It's okay. We've had some discussions about it. I do think it is going to take a significant amount of time to implement it.
Right.
Because there's basically, the state has one GME plan for the entire state. And so we have to basically amend the current plan that we have, add the Center of Excellence into it, and then get approval for that from CMS. So it'll take some time to do, but I think it is doable. And I think both the secretaries agree that it's something that we'd like to accomplish.
And it doesn't cost us to do that.
Correct, yeah. We can use the existing funds that are in the KDAS budget for the Behavioral Health Center of Excellence to do that.
And that would be full federal funding?
It's a match. I'm not certain what the percentage on the match is, if it's 80-20 or if it's 90-10, but it's a match. We'd be basically extending the amount of funding that's available for the program.
So again, Madam Chair, I would be saying, I would be thinking that the recommendation of the committee is them to do exactly what Andy just did, but get back to us and say, this is what it's going to cost, this is the match, this is how long it's going to take, that kind of thing. But definitely recommend that they look into transitioning that.
Well, I think we're kind of saying the same thing. It's just I'm being a little bit more forceful with it because we've already committed $5.7 million. And had we been aware of this GME when, this was being processed, we might have turned that $5.7 million into $11.4 million if there's a 50-50 match. But I think that Andy's right. I think it's a higher match. So we would have less to put in, I think, from a SGF perspective.
Yeah, and my partners at KDHE have just informed me it's probably an 18-month timeline.
Yeah. So it's not something that would happen next session. We wouldn't be budgeting anything for next session. So you'd have next session, and then you'd also have the 26th session to actually finalize anything. And it still has to go through the budget process.
Okay.
It doesn't mean that we're giving them the authority to go out and spend the money, yada, yada, yada. It still goes through appropriations and Senate Ways and Means. But I just want to send the strong message that we support the discussions that have already happened with our secretaries and our Medicaid director on this issue.
I'm
Does
fine
that
with
make
that,
sense?
Madam Chair.
Okay. Sometimes I don't always explain myself. Is there other questions or objections on that committee? All right, seeing none, are we good? All right. Then we have to draft legislation for the MHIT bill. And I had Jenna go back and pull the proviso that was actually put in the bill. And what we did is we had a piece of legislation. It passed the House with 112 votes. The Senate chose not to take it up. Then we got it put into conference in the first budget. The governor chose to veto it, but she left the money in. Then the governor and I sat down and had a conversation, and I explained to her that the program would end this year if we didn't get legislation done. And she said, well, the money's there. And I looked at her and I said, Governor, you wouldn't have done it as a senator to leave $13.5 million out there without any guardrails. And this legislature is not going to do that either. So she was very willing and accepting to sit down and negotiate with us, and she did. And this proviso was the bill that passed out of the House at 112. The modifications that were changed was, instead of the private schools at $3 million, we went to $1.5 million. And then there was also did we call it, is it called a board, or what is it that looks at all the private school stuff, Andy, on the MHIT? I don't remember the terminology.
I believe the bill refers to it as an advisory board.
Yeah. And it stated certain individuals that work with KDADs on this. So we're asking to put this language into a bill to be submitted for next year. Any objection? Yeah. The K-12 mental health program. Senator Petty.
I do recall the bill. But remind me, was that 1.5 million, was that new money? Or was that taking out of that pot?
No, that's new money. That was new money.
So I'm kind of at a loss here. So the recommendation at this point is putting forth that MHIT bill from 2024 as a recommendation for this committee. Is that correct?
Well, the proviso that was put into the budget. And the base of the bill was the bill passed out of the House. I don't know what that number was. Was that the 2551 number, Jenna? No, that's the budget bill. So I don't remember the bill number it passed out of the House. I operate off of subjects. But it passed out of the House 112, and then it passed out with the $3 million in it. And we modified it, and when I negotiated with the governor to 1.5, and then this advisory board to be a part of that as well.
Thank you.
Senator Gossage.
Just to clarify on what Senator Petty said, and of course, this would go through the whole process of the committee, et cetera.
Oh, yeah. We can't pass legislation. We can just recommend legislation.
Right, just in case there was discussion.
Yes, and Will Carpenter's going to have to introduce them all.
Well, it'll go to the floor as Bethel committee bill and then be referred to.
That's fine. That's the omnibus version. Yes. Yes. Because that's the one that we passed and had a lot of agreement on, and I was very appreciative of the governor being willing to work on that. She has been a supporter and added additional funding each year for us. So, did you have a comment, Representative Carpenter?
No, I'd probably better not.
I'm not going to go there. We are on WebEx. Then we also need the introduction of legislation, and I, at this point, would recommend, because I believe that we did have a bill for the Behavioral Center for Excellence last year. You don't think we did? Did you guys have one in social services budget? Colin, do you know? Well, I was on pieces of that project, and I got just on other projects.
Thank you, Madam Chair. Colin Thomas said on behalf of the Association of Community Mental Health Centers of Kansas, there was no bill. It was just a set of budget recommendations.
Okay, so we'll recommend that legislation be drafted for the Behavioral Mental Health Center for Excellence in conjunction with the community, well, with, I guess we can call it now because that's their organization, and with KDADS, is that running through you guys?
Right now, the funding runs through us, but it's an independent nonprofit.
Right. Well, but I'm just saying that between KDADS and them or the community mental health centers, whomever, work on a piece of legislation to get introduced for next year.
Sure.
Senator Petty.
I just want to clarify, I think isn't it the Behavioral Health Center for Excellence? Is that what it is currently?
Mm-hmm.
Yes, okay.
Yes.
Yeah, but mental's not in there, it's just behavioral
Oh,
health.
behavioral, you're right. Yeah, but you can't draft it without working with that other entity. Yes, I want it drafted with their help.
Okay, but for.
And it'll all go then back through Representative Carpenter to introduce.
So somebody needs to get with one of us to give us language.
Representative Carpenter will work on that.
In
Along with Representative Ballard, I think.
in some committee somewhere. You don't, I mean, do you want this?
We don't get to assign a committee.
Right, but do you want it introduced as a non-level bill?
That's fine. Or just go through the regular process, but I just want us to recommend that we do that. So we get it into statute. Representative Concanon.
I think to clarify, we can do a bill, a committee bill here, or we can recommend passage of a bill during session.
And that's what we're doing, because we don't have the language.
Right, well, okay, so you're recommending the passage of the bill done through the regular process through committee in January.
May I ask a question? I thought I understood. So,
I thought I clarified.
all right,
No, she clarified it.
but we said through but it's going through about Bethel, or not?
No.
No, it's not.
Okay.
We're just
gotcha.
going to recommend,
Recommendation for the legislation
yes.
versus.
Senator Petty.
Bill that we will draft.
I got it.
For the committee.
All right, Senator Petty?
So, Madam Chair, is this going to be legislation that we're recommending that during the legislative process, that there be a passage of a bill supporting the Behavioral Health Center of Excellence?
Yes, ma'am.
Thank you.
You're welcome. Okay, next we have the legislation for the chip fix, which would be the same bill that was introduced this last year with the changes that need to be made for some of the federal changes. And I believe that, well, I don't believe, Heather Braun brought this up, and it wouldn't be legislation, it will be a proviso to the Appropriations Committee. It's not going to go anywhere as legislation. I know.
So recommend that a budget proviso be drafted for inclusion in the budget bill.
Yes, with the minor tweaks, and I think Heather's already visited with Jenna somewhat on that and given her the original bill. Is that correct?
Thank you, Madam Chair. Jenna Moyer, Revisor Statutes Office. And we just need to clarify what parts will go in that proviso, because there was the one passed in the proviso last year regarding the 250% federal poverty level in the year, and then the two other changes as a result of the federal law change relating to the waiting lists in the lockout period.
All of
And
that.
those are, all three of those are in the same statute, and so one proviso could be drafted to fix all three.
Yes,
But only, we just want to make sure which ones you wanted to do.
yes. All of those. Because I think there's a couple of them that are new since the session, but I think we had a federal fix in there from something last year that was the proviso.
Yes.
Yeah. Then committee, and I'd like to do this, but I want the opinions here of this committee is Clint with the Home Plus homes was wanting to look at making the change from 12 to 16.
Yeah, that's fine. Go ahead.
So is that something we want to entertain?
May I?
Yes, Representative Ballard.
I think this over here, yes. That was one request, and I have support over here as well, that he did ask for a decrease of 12.
She's just not close enough. You got to eat it.
Or have to yell. So it's a request from 12 to 16 individuals. And remember, this was from Clint Arndt, who was a licensed Kansas adult care homes operators, and mostly small homes, and he serves the majority, he said, of dementia. And when I asked him a question, he said it would not make a significant difference in the care that the consumers received, but at the same time, they would add an additional staff person. And I think he made a case for why he wanted to go from 12 to 16, and I didn't really hear any opposition, so that's why I'm making this recommendation.
Okay.
Is the recommendation just to recommend that, or is it for legislation?
Do we have to do legislation in order to do that? I do not know the proper way. I thought he said it would take legislation.
So again, do you want it drafted, maybe you do want it drafted during session? How do you want to handle it?
Jenna, you look like you might want to say something.
Thank you, Madam Chair. So if this is a statutory fix, it would change 39.923. It's the definition of home plus. It's been amended in years prior. It started off as 5 beds, 8, 12, and now this potential to change it. There are 2 numbers in that one that could be changed. First is the home plus, the separate homes, and then there's also reference in that definition that an adult care home could convert a portion, like a wing, to home plus, and I would want to make sure if we want to change one or both of those
I would
numbers.
say both.
I think I would give him that option.
Representative Concanon.
I don't have a problem with it, but we didn't really hear any testimony on that type of change. We just heard on the
Well, again, I think,
home, and I guess I just would like to have more information that we could still recommend it, but
Right.
and the information will come out in the process. But I don't, sometimes we do things without all the information that we need, and there might be some unintended consequence with it, but it'll come out.
No, and I agree with you on that. What my thought process was, and I can go either way, is that we do both, and then during the committee process, I think that'll be thorough discussion, and then they can take and pull those back if they want to. That way, we're doing the whole change in that statute is just a little bit cleaner is what I was looking at, but I can go either way with that. All right. Yeah,
So what are we deciding?
that we'll change the 2 numbers that Jenna referenced.
Gotcha. Well, then that would be my recommendation.
And then the last thing I've got on my list, I believe you're right, Ed, that we had some things during the discussions the last 2 days where we were making recommendations as we went along. Is that correct? I did not list all those down. Or Elizabeth, either one of you.
I have one from this morning. During the spreadsheet, you had request the Social Services Budget Committee review providing grant funding for local communities to apply for a grant to make digitally available a local resource guide based upon the out-of-print Explore Your Option resource guide.
Yes. Discussion? We're good? All right, we're good with that one. Was there something from yesterday?
Senator Fagg.
Oh, yes. Senator Fagg, you had a comment?
No, I have a recommendation.
Okay, yeah. No, just a moment. I'm not done. I'm on a roll. I'm on a roll. Usually I wait till the very end, but I want to get through this list here. And I don't know, did I hand that to you, Dave? Do we have copies of it? Right, okay. No, no, we're still on finishing up what we had. Yes, okay, all right. You want to go last? All right, we'll make sure that happens. Committee, if you remember at the last KanCare Oversight Committee, and I don't remember if it was the first or the second day, and we had said that we would do legislation to propose changes to the procurement process or RFP, whichever way you want to look at it. And I think I'll have Jenna explain it because we have simplified it a lot. And keep in mind, this has got to go through the whole legislative process. We're just putting a bill out there. So Jenna, would you like to explain what we've drafted? And it will only deal with, did it only deal with Medicaid, Jenna? Yes.
Thank you, Madam Chair. I emailed this to Dave, so hopefully it'll be uploaded to the S drive at some point. That was at 1:12 p.m. And this would be a new statute requiring the Department of Administration to adopt a written policy governing the negotiated procurement of managed care organizations to provide Medicaid services pursuant to a contract with the Kansas Program of Medicaid Assistance. And the policy shall include a prohibition on destruction of records that complies with the Kansas Open Records Act, adoption of a tie-break procedure if part of that evaluation process used to make award recommendations involves scoring, and a requirement to be transparent with the legislature to the fullest extent permitted by law. And the policies would have to be adopted and implemented by July 1, 2026. Additionally, Eileen made a good suggestion when I sent it to her, when we've adopted similar legislation to this for other agencies, adopting policies that it be made available to the public as well as to the bidders. That just, it would be an open record when the policies are adopted.
Sorry, thank you, Madam Chair. The Department of Administration doesn't really have, like, they don't publish their policies per se. They have a policy manual that they publish a link to. So when we say publication, we're just talking about having it done by the date and into their manual versus just kind of saying, oh yes, we adopted a policy, but not making that whole process transparent to people who would want to refer to that policy if needed.
Discussions, comments on that legislation? Representative Reese.
Thank you, Madam Chair. My head's all kind of fuzzy right now. It's a lot of information.
We've had a busy 2 days.
Wasn't there a third-party involvement? There was like a consultant or something? Mercer, thank you. Will this affect them? I mean, Mercer would have to follow this? And do we need language in that to say that whoever the contractor is or the consultant is? Okay, so it's clear what we're trying to, okay.
Oh, it's now on the S drive, folks, so if you want to pull up a digital copy of it. Any further discussions? Are we good? Okay, we've got that one. Then, and you know, this is up to you guys because do we need something else? Okay. We didn't have discussion on this, but last year, with the governor's support, we did a proviso to provide additional SUD funding in kind of a grant fund. And it was kind of like dealing with, we've got some of our SUD programs out there that spend their grant money down early, and then they're scraping by to try to get into the next fiscal year. Because we have some that just have a higher need, and this would allow them then to apply for additional funding out of this grant fund to get them through the rest of the year. And that was done by proviso, and I'd like to see that done. Well, it probably has to be a proviso again this year, but I'd like to see it in legislation. But let's make it a proviso and let's see where it goes from there. Is there objection, or Senator Petty? Huh?
I'm not following you on what you're referring to.
It's kind of like, you're familiar with disproportionate share with our hospitals in Medicaid? It's kind of like a SUD program that's a disproportionate share. You have some facilities that have a greater group of people that they have to serve, so they run out of the grant money that they originally get. Because we have basically, I think it's like a block grant, if I recall correctly, is the way that we do it, and then it's dispersed accordingly. This fund sits out there, and then when the need comes that they've run out of their grants, and they get to apply for that funding out of that pot of money. And I think we did $5 million, maybe it was in the omnibus bill. Does that sound right? Because I think we started with like 6, and I think we ended up, the governor and I negotiated at 5.
Where are you talking about? DCF, KDHE? Where are we talking about?
SUD is our substance abuse programs, and I don't remember which budget that's in. Is that you, Andy? Yeah, that's KDAD's. Andy, was it $5 million? Do you remember? That's all right. Okay.
Yes, it was $5 million.
$5 million, yes. Senator Gossage.
Andy, could you come to the mic? So, I mean, this is a possibility, but why do we do a block grant? If you have some that we know are going to have, they typically have a larger population of the SUD population. Could it not be based upon that rather than you get this and you get that and everybody gets 3 million or something?
Well, the way we currently structure it is we do have a federal block grant that we receive. And we work with Carelon to set up a network of providers that have access to those block grant funds. That group of providers is then allocated funds for the year based on their previous year's utilization. So it is already sort of structured in a way that the participating network providers are allocated based on previous usage.
And what if you have one that didn't use as much as they normally do?
So there's an adjustment that we try to make near the end of the year where if there are funds left over in one agency's allocation, those can be shifted to an agency that's already expended theirs. The funds that Representative Landwehr is referring to are basically additional state funds that we can then supplement those federal dollars with.
And this was done last year? So was this the first, was 2024 being near the end of the year? Are those the funds that would be used for this year?
Yes, that's correct.
And do we know yet if those will be tapped?
So I believe we've already set those aside for that purpose. I can't tell you yet whether or not the providers have had to dip into them yet, but they're available for them in the case that they need those.
Okay, thank you.
Further discussion or comments? All right, so we're good with that, to add that? It's kind of a population that gets overlooked, but it's also an increasing population. So, did we have anything else from yesterday that you recall? I think we put a lot on our... Oh, yes. If you recall, committee, I mentioned something on Monday because I was very disappointed in KDHE coming in on late Monday evening to provide all of their testimony. And if you look at most of it being written, it came in, it was pretty abundant. And Arida and Dave were working until 9 o'clock Monday night to get all of this put on our S drives and make sure that it would be up for the public to view. And I've never, in all the years I've chaired joint committees, have I ever had that as a problem. So as I got to looking into how this committee's structured, we really don't have conferee rules. Now, yesterday you heard, or the other day you heard me talk about committee rules. No, that's separate. The conferee rules come in with the chair determines the agenda, which we already have now, but individuals wishing to testify before the committee must notify the committee assistant no later than the morning before the day of the hearing. Electronic copies, 5 hard copies, must be submitted no later than 10 a.m. the working day prior to the hearing. And this is to give our staff, and I've always tried to be very respectful of our staff's time, because as much as I think they only work for me, they've got a whole slew of committees and 165 legislators in their ears. So this would just set up for the KanCare committee a conferee set of rules that when someone wants to testify, they'll get these rules, and that's what they'll be governed under. Good? Senator Petty.
I think that does show respect for staff, but at the same time, I'm not referring just to this committee, but there are times when departments are asked for information at the very last minute. So how would that fit into this kind of guidelines?
Well, that's a totally different issue. This here.
It becomes testimony. I don't know how it's different.
Huh?
I'm not sure it becomes testimony.
Well, we occasionally have something last minute come up, and it's at the discretion of the chair whether it even gets heard or gets submitted. Now, I don't deny testimony. If a person, they may not get to testify if they've come in at the last minute because there may not be time in the agenda, but their testimony will be given to the committee members. I never deny testimony being distributed to the committee. If it has been something that could not be avoided, then we have to be flexible with that. And that's us being also respectful with the conferee, whether it's an agency or, one of our lobbyists. These are harder rules for agencies and lobbyists because they live this life up here. We're not as stringent when it comes to like individuals, because they may not know exactly how the process works or they get confused with the process. We are definitely going to be flexible with them. But these are the same conferee rules that I use in the Health and Human Services Committee.
I guess I'm not saying that those rules aren't important, but I don't think that we as staff members or as a chair can ask for a department, whether it be KDHE or KDADS or DCF, to provide us with information that we ask them to, that they only get notice 24 hours in advance.
Well, we agree with you. That's a different story.
Okay.
This here was, they had what, a week, Arida? 2 weeks, almost 2 weeks to provide this information, and they did not do that. And the disrespect Senator, that was shown to this committee was bad. The secretary didn't even have the courtesy to show up in this committee, and she didn't the previous 2 meetings. And I don't know why. I don't understand it. And apparently, we need to have these rules. And they'll be posted on the committee website. Are we good? Yes, I'm passionate about it because I tell you, I know what staff does. And being a member of appropriations, and Representative Ballard has been here, and I've been here, we're here 1, 2, 3 o'clock in the morning going through the appropriations process. And I know what staff is being put through. And I will bend over to backwards anytime that I can make their job a little bit easier. And to ask them to work till 9 o'clock at night on Monday was despicable, in my opinion. So
We agree.
All right, so we're good. Anything? Okay. Now I think that I'm done with everything, right? That I had? No, he wants to be last. So, Representative Concanon.
Thank you, Madam Chair. I just have a question to follow up on from your previous number 9, that on the conferee rules. This is just a question I have for staff, and it really has nothing to do with what happened with this written only. But I've always wondered why the written only is not released to us until the day of a committee meeting. And I'm sure that there's some logic to it, but I don't know what it is. And I'd like to know because I'm usually driving for 2.5 hours to get here, and I don't have time to read the testimony, and there's not really enough time while we're going, while we're going through. So I'm just curious as to why that.
Can you answer that, Dave? You need the microphone. Because he does all the work.
I do that part of the work. The main reason is that as the testimony is coming in, I could post it each individual time, but the issue is that we don't, until we have a final agenda, I think you would prefer to have the testimony in the order that it's going to be presented, and I can't do that until a final agenda is done, and that usually is because we're always waiting on pieces of testimony until usually the day before or maybe 2 days before. Also, too, most of our committee meetings are beginning of the week, so we're finalizing on a Saturday or a Monday, and so it's difficult to do it for that purpose. I would prefer to get it out as soon as possible. For this, it's different for our normal committee meetings because technically we're not allowed to post testimony until the day of. And
Yes,
well,
that's my point.
For informational, it's not as big a deal. When you're dealing with a bill, you can't give opposing the testimony. You can't give a proponent the testimony for an opponent and give them time to adjust their testimonies. So that's the reason for that. So there is a...
That makes complete sense, and I've always kind of wondered that. But I like to study ahead of a meeting and be prepared, and I get it with having it in order. That is frustrating if it's out of order, but I get that. If there's any way to solve that, I would love to even just get an email with some of the testimony or something that.
Well, and I know that in my discussions with Gordon Self is that his concern was, and they actually had this happen, was where someone found an error in their testimony and they had to pull it back. It had already gone out to members, and as you heard Dave mention, it went out to the opposite side of the issue, and then they made hay of it. So even the old way of, I say the old way because I've done paper for many, many years, even in my previous term, is that we did not, as committee members, have that testimony until the day of the committee, and it was put in our folders. It's no different than with the PROPs. It's the same way with the PROPs.
Okay.
So it has to do with a lot of quora. And I think, Gordon tries to guard that really well and protect all of us with it. So that's why, because it's not public until we present it in the committee process.
Okay, makes sense. Thank you. Thanks for the explanation. I appreciate the clarification. I'll continue to come unprepared. No, I won't. I'm leaving.
Okay.
I think we have one more item.
Okay, I think Susan, all right.
Oh, yeah, more, okay.
Representative Reese?
Thank you, Madam Chair. Yesterday, I had asked a question about pediatricians and where the pediatricians that are billing for Medicaid or accept KanCare members, put it that way, where they may be located. And Stuart Little was the one that spoke on their behalf and used the word geomapping, which is like, yeah, that's exactly what I wanted. But then it occurs to me that I've also wondered whether So let's just take pediatricians for an example, because they came to see us yesterday, asking for a rate increase. Their intention is to ask for a rate increase at Social Services Budget Committee. But there's, without a guarantee that more of the pediatricians will see more kids, more members. So then that brought to mind about a cap. Do Medicaid providers have a cap? You know, is it an artificial cap, or is it a cap that everybody knows it's a cap? Like, I'm only going to see, 10 kids that with Medicaid, I'm not going to see any more of that, is there a cap? And so my question is that being tracked for all KanCare providers, if there is a cap?
In all my years representative, I've never heard of such a cap. Now, a provider, whether it's a pediatrician or whatever, may self-impose and say, I will only do X number of Medicaid patients a day. And that's a business decision that they make.
It's a cap.
Well, it's a bit, but that's a business decision they make. It's not a cap set by us or anyone else, and it's not a cap that's going to be, advertised any more than some of their rates are going to get advertised, or what negotiated rates are out there. It's a private decision. Some of them don't cap it. Senator Gossage.
In my experience, it changes, because maybe they have X number of patients, it comes down to their bottom line, and they have to say, in order for me to keep my doors open, I cannot take more than this many Medicare patients, more than this many Medicaid patients, but it's usually a percentage of the total patient population. And so maybe there have been some changes, and these patients have dropped off or whatever, and so now they can take a few more Medicaid patients, so it just fluctuates.
Yeah, because there's even some that limit how many Medicare patients they'll take as well.
So having this geo map that is going to be worked on regarding the pediatricians, I think I've seen something like that for other Medicaid providers as to where are they located within the state. And we already saw the maps for the MCOs. We see where the gaps are. But where are the gaps of where the Medicaid providers are that have to do with the, HCBS, they see our most vulnerable folks, where are they located in the state? I think that's helpful information as we look at workforce and look at trying to attract more physicians into, some of the areas of our state that are more rural, more frontier. So my ask is, can we have a geo mapping of all of the KanCare providers?
Well, I think that would have, gosh, I don't know who that would necessarily be done by, because you're talking, if you don't narrow it down to specific ones.
Yeah.
Stephen Anderson wants to do it.
Stephen.
I don't think Steve Anderson heard you, Representative Concanon. She just volunteered your office to do that for us.
If we get you more staff, he'll do it.
I don't know, I guess we could direct staff to check with the agencies and see what they may have and look at ideas that they might have in order to create something like that. Would that be good?
Yes, yeah.
Okay.
I think I've seen it before, but I can't.
Well,
Can't remember.
a lot of times you'll see, like you saw with the MCOs, okay,
Right.
they show us a map.
Yeah.
You'll see that with your CMHCs, you'll see that with your FQHCs, it goes by, but,
Dentists that take Medicaid.
and dentists, yeah.
And it may not be one big spreadsheet, but
Right.
maybe several for categories maybe.
Right. Well, that's why I think if they just check with the agencies, see what they currently have, and then they'll know what some of their providers provide, and then take it from there. So it's, it's just, we always have to be a little bit patient on how we try to design something.
Sure, absolutely.
But if we ask their help on it, they're seeing it, and they may say, oh, yeah, we just got to do da-da-da-da-da, and it'll pop out.
Right.
Or, no, we don't have that, but it's a good idea, so we could figure out how we could gather it.
Mm-hmm.
Because I think we dealt with that a little bit today with, was it today or yesterday with Christine? It was, some ideas that, well, yeah, that would be a good one to track and add it, yeah. Because the agencies are usually pretty responsive on that stuff.
Absolutely, yeah.
Yeah.
All right, thank you.
Did you have anything, Concanon? Representative Concanon, I'm sorry. Well, no, I thought you had. No, no. You were going to carry something for Representative Ballard. That's why I'm thinking of you. Did you get yours done?
I'm just laughing because you called me Concanon. No, you've done everything I was.
No. Clint Art was one that I had left with her, but I did it, so I'm real cool about it. But there is
Berquist.
one more before he gets to it that I would like to just bring up, though.
Go ahead.
All right, and it was the one that we heard today from Leah Chaffee.
Uh-huh.
Okay, and part of Leah Chaffee, she's new, but I'm new, that's right, yeah.
You've been here longer than I have, girl.
I know, but I don't have a big mouth, though. So let me say.
Cat fight.
Just so you understand. Just one with Lee Chaffee request, and that was the one when she was talking about PACE today. That's the all-inclusive care for elderly, and she just made the comment that she would be interested in, instead of it being 3 years, that it would be annually rebased, okay? And I'm just bringing that up because it was mentioned, and I thought we should at least discuss it and decide what we wanted to do.
I think Representative, and you and I were actually here and helped we helped create that rebasing process. And I think when we're dealing with times where our nursing homes, finances, and everything are pretty stable, that 3 years probably works. So it would be my suggestion that you look into the rebasing every year, and what does that entail? What would that look like from a cost perspective? And if you decide to do it for every year, I would suggest that you then sunset it so that it gets revisited, because there may come a time when it should go back to being 2 or 3 years on the rebasing.
Okay, and that was the one, may I?
Uh-huh.
That was one that Representative Carpenter was coming in on, and I know he's really big on rebasing, so that's why I'm just bringing it up for discussion.
Representative Carpenter.
So we look at it annually, and I think it's on our radar screen because, you know, PACE is a great program, saves money, keeps people out of nursing homes and stuff. But the bottom line is, just like the bill that we're talking about to adjust the federal poverty rate on CHIPS, those are never going to see the light of day because it's Medicaid amendable, and we're not going to have a floor fight, so you can do whatever you want to, but that bill is not going to see the light of day.
But we could do a proviso.
Oh, and that's what we've done for the last
We did that last year.
2 years, the last 2 years. And we've also changed PACE into caseloads too. So, but anyway.
Shall I?
The caseloads helps a lot.
The caseloads help, yes, but shall I just offer a proviso that we look at it?
Sure.
I mean, we have done it, but I mean, rather
And we'll
than,
continue. You could say that.
that we
You
will continue
to
doing that
adjust
as
the
well.
PACE annually by proviso.
Okay. You got it? You okay with that?
You need anything else from us?
I think.
No, on this issue. Okay. Representative Berquist, didn't you have something? No, I just smiled. Oh, okay.
He was smiling, I was watching him.
All right, seeing how Senator Fagg wants to go last, does anyone else have anything that needs to be added to our recommendations or to the spreadsheet?
If it has
Senator Gossage.
I was going to make the recommendation for the rural emergency hospital environment, but I'm assuming that that's your, then go right ahead, sir.
This is your last time. Speak now or forever hold your peace. All right, Senator Fagg, you may close up this process.
Thank you, Madam Chairman. I forgot what my recommendation was. Oh, no, I got notes here. I'm sorry. This is truly an honor to make the last recommendation for the Bob Bethell Joint Committee chaired by Chairwoman Brenda Landwehr, ending a stellar legislative career. And I want to tell you thank you, and I know everybody on this committee. the people of Kansas say thank you for your work that you've done here. So.
Thank you.
So I hope I can get my recommendation through. So I'm asking the committee that we recommend that the 2025 legislature seek legislation to allow a rural emergency hospital to be granted a waiver from the physical environment requirements of a new facility for skilled nursing beds that need to be included for hospitals, and this would be like the Mountain Ridge Hospital, for an example, to be able to transition to a rural emergency hospital without having to meet requirements as if they were a brand-new facility. So they have started to work on this. I don't know anybody that's really against this. They will work on the details when it gets there, but this will be seeking the deal. And it's going to be like the number of beds and stuff they're going to be talking about on that, so.
Oh, absolutely. Representative Carpenter.
So just for clarification, is that not just specifically that hospital?
No.
But, okay.
No.
Statewide?
Statewide.
Okay, good.
That's an example. Yeah.
Great, because I have one in mind myself.
Did you? Okay.
We're good with that committee? All right. Good job, Senator Fagg. Did you have something, Representative Ballard?
I don't have another recommendation. But I would like to say, to have had a partner for over 20 years in the legislature has been a rare privilege. And I think sometimes what we read in the newspaper or observe about what the legislative process is all about is not always accurate. I believe as legislators, our job is not only to work hard to get elected and to do the people's business, but it is also to develop relationships. And when we develop relationships on both sides of the aisle, the people of Kansas are the winners. They're the winners because we don't get totally caught up in what the majority party does or what the minority party does. But we spend the majority of our time trying to decide how to make life better for our constituents. And we at times may get very upset with each other and feel it's unfair, and the majority party does this and the minority party does that. But at the end of each session, we close talking about what the staff has done, what we have accomplished, and why we are pleased with some of the things that we accomplished. I have done that for many years, starting with 1997, with Representative Landwehr. And though I told my husband I was prepared, I realize I'm not. So I will simply say, being elected to the legislature gave me wonderful opportunities, and one of the most that I will value will be the years I spent working with Representative Landwehr, developing a relationship, and having so much fun, making sure, especially our constituents in social services budget, received what they deserved. It was not always accomplished, but it was never for lack of trying to make it possible. Thank you, my dear friend. It has been a pleasure.
I told her not to make me cry.
I didn't want to cry either.
Representative Carpenter.
Thank you, Madam Chair. I didn't want to do what Barbara did. So I'm just going to play this game with you. Dedicated, commitment, best interests of the people of Kansas, unfiltered, true servant leader, a pain in the you-know-what. Can you guess who that is?
Who is the chair for 5 minutes?
That's my game. Who is it?
That's not me.
It's Representative Landwehr.
Representative Berquist.
When I grow up, I want to be like you.
Well, don't ever grow up, because I have not done that. I want to say that even after 26 years, there's not a day I leave this Capitol and look back and think, wow, I get to be a part of this process. I get to work with some of the greatest people, some that I don't think are so great. But Representative Ballard and I went on appropriations together in 1997 on social services budget. And it has been one of the most fruitful, heartwarming opportunities to be able to find middle ground on working with some of the most vulnerable people in the state of Kansas. There were times that we had to battle our appropriations members because they decided that their budgets were more important than ours. And Barbara and I did not back down. I should say Representative Ballard. You're Barbara to me. And her husband, as well as my husband, know how close we are, and I don't think either one of them would try to get between the two of us. And we came across a photo here a while back, and it was in an appropriations committee, and the looks that we were giving were ones that probably put people 6 foot under, because we were determined. But Representative Ballard's right. The press wants to paint more division than what there is. And I actually had someone, when I came back, they said, you know, I don't know about you being conservative because you work with different people. And I said, well, what do you mean by that? Well, like liberals. Okay, well, who's the liberals? Well, you know, the Democrats. Okay. And I said, do you think I get anything passed by myself? No. It takes 63 votes in the House to get something passed. And many times I've done that with my colleagues across the aisle. And it was the best way to operate. I carried legislation this last year because a colleague in the House was afraid it wouldn't pass if their name was on it. And I couldn't have been prouder to have had that opportunity. And it dealt with internet suicide. I've been so fortunate and so blessed, especially the last 8 years that I've been up here, to work on some of the most important issues to my heart in the area of mental health. I know that my colleagues got tired of every time I said mental health, they were like, let's leave the room. She's going to spend more money. And I hope that there are people that will carry on doing that, because I know some people were afraid that they'd step on my toes, and it's like, no, we need help. It's just because it appears that it's our issue, it's not our issue. It's all of our issues. But to watch our ranking in the services of mental health increase and improve has just been incredible. And I'm not going off into the sunset, because that wouldn't be me, and I can't do that. I hope that along the lines, as I find something that I can still kind of keep my fingers into some of this, just not full-time. I don't want to work full-time. And ever since I joined the legislature in 1995, this has been a lot more than a part-time gig. Because I can't do what I do, I can't investigate, I can't research and know what's going on, and it just be a part-time job. I had a legislator that was arguing with me one day, and they finally said, I'm done arguing because you have an answer for everything. And I said, you're right, because I deal with facts. Because I won't come back at you if I don't have an answer to it. And I hope that, well, I don't hope, I know that it has happened. And Representative Ballard and I have experienced this over the years, of individuals that didn't particularly agree with my politics or with my views or my opinions. But I've had several of them say, we respect you because we know that when you're talking to us, you're laying it on the line. There's no reading between the lines with you. So I want to thank everyone that I've worked with. I couldn't do it without this wonderful staff. Rida and I've been together a whole lot of years. She is a woman that she needs to learn the word no a little bit more. I think Elizabeth knows that about her. And it's been a joy to work with Elizabeth as well. Jenna, I have put her through the ringer. I don't ask for permission from her, so maybe her daughter got about a 4-foot giraffe showed up at their house. But it was such a joy to see that little girl sleep with that giraffe. So Dolphin is its name. And I've had many people, it's like, well, why do you do a giraffe in your office? Because I have about a 5-foot one that sits in there, and it's because of Representative Patton and the giraffes born at the zoo. I followed the birth of them, and then Representative Patton showed his little giraffe, and I was like, really? That's all you got? So that's how Julie the giraffe got up there into my office. But I'll leave advice with you is keep an open mind. Build relationships, and be honest, and forget you are a servant of the people. And this is their house that we get the privilege to work in. So I want to thank everybody, and I hope I haven't forgotten anyone to thank you, but it's an honor. Thank you.
Before
Senator Gossage.
Thank you. Before she does the gavel, I just want to say it's been an honor to be your vice chair and on alternate years, chair, and you're my vice chair, working on the House and working on the Senate on some of these issues. But I would also be remiss if I didn't mention Representative KanCare, because this will also be her last time that she will be here. So if we could have one more round of applause of these two folks.
Yeah, well, and I've had the privilege to serve with Representative Concanon on the Appropriations Committee, and just like Representative Ballard and I, we have our differences, and people think we're going at each other's throat, but it's never, oh, you were, okay.
No, I said we're going at each other.
Yes, but it's never personal, because the person I go against today, 10 minutes later, we may be allies on an issue. Just never make it personal, and always remember that. So with that.
No. And with that, I have to say, I was waiting for the right time. I just want to say, as difficult as I know it must be for you to leave earlier than you really wanted to, your time here.
I didn't lose.
No, she didn't. No. But just to know, it has always been a pleasure when I know I can come in here and we can talk about an issue, and she can either offer it, vote for it, or not vote for it. But I know she was really contemplating it, thinking about it, and working it out. And that's all you can ask of a legislator, to do that. And I would say thank you.